Hello friends and welcome to the discussion of CBoT questions of forensic medicine. Let's take up our first question. The first question is a picture based question, and in the question you can see there are certain x-rays which are highlighted. Let's read the question. The question says, when a girl was reported missing from the town, the people informed the police that they believe she has been kidnapped by a guy. However, the girl later testified in the court that she is a major and was married to the man. Her wrist, elbow, and pelvis x-rays are shown in the picture. What is the girl's estimated age? Okay, so question बहुत clear है हमारे सामने. There are three x-rays which has been shown in the picture. The question is whether the female is major or not.
Hello.
Which means
I hope you had a good CBoT. Let us discuss the anesthesia question which was asked. The first question. A 42-year-old man with serum creatinine value 4.5 and a serum bilirubin level 6 mg per deciliter. Which of the following muscle relaxant can be safely used in this patient? Now, the patient has derangement of level of serum creatinine, so renal function is a bit deranged.
The first X-ray is
the LFTs are also a bit deranged.
And in
so in this patient, which neuromuscular block?
See complete fusion. You can see that all the epiphyses of the joint area are completely fused. In the second X-ray, that is X-ray of the wrist and hand, we can see that again there is complete fusion. We can see that the epiphysis of the lower end of radius is fused. That would be the last fusion that would happen in this X-ray. Okay, and in the third X-ray we see the lower half of the pelvis, where we can see at this area at the lower end there is fusion. Fusion of ischium, right? So ischial tuberosity is also fused. Rather than ischium, I should write here ischial tuberosity. Okay, so if we look at the fusion table of these three very important X-rays for estimation of age, what do we see? We find that when we look at the elbow joint, if everything is fused, the age is 16 years. The last process to happen here is fusion of medial epicondyle of the lower end of humerus, and this happens close to 16 years, right? So if everything is fused, the person is more than 16 years. In the wrist joint, the last process to happen is fusion of lower end of radius. This fusion happens between 18 and 19 years. It means if the lower end of radius, the epiphyseal fusion has happened, the person is greater than 18 years. Okay, and in the hip joint, what we can see in the X-ray, the last process would be fusion of ischial tuberosity. This happens at 20 years. So if ischial tuberosity has fused, the person is more than 20 years. So the best answer that we get from these three X-rays is that the person in the question, that is the female, she is more than 20 years, which means the most appropriate answer it would be that she is above 18 years of age, right? So correct answer is option A. Let's move on to our next question. Section 314 of Indian Penal Code deals with, and then there are four options given: causing miscarriage without the consent of the mother, causing miscarriage with the consent of the mother, causing the death of the quick unborn child by an act amounting to culpable homicide, or death of the mother by an act done with intent to cause miscarriage. This question or question around criminal abortion punishments are very frequently being asked in the examination these days. Okay, the one thing that we should remember is section 312 to section 316 of IPC, they all punish for criminal abortion. Okay, what are the different scenarios and how much is their punishment? Let's see it. So the first section is 312. 312 punishes for abortion done not to save the life. If it is done like that, the punishment is 3 years of imprisonment. But if it is done on a woman who has experienced quickening, so woman who has experienced quickening and the abortion is done on her not to save the life, the punishment is 7 years. 313 punishes for abortion without consent of the woman. The punishment is 10 years of life imprisonment. 314 is death of a female due to an act with an intent to cause miscarriage. The punishment is 10 years. And if the act is done without her consent, the punishment escalates to life imprisonment. 315, as you can see, is punishment for preventing a child from being born alive or causing it to die after birth. Again, the punishment is 10 years. And 316 is act causing death of a quick unborn child. Again, punishment is 10 years. So what very importantly we see here is that punishment from 313 to 316 are all 10 years. ओके, सो एक चीज जो हमें याद रखनी है वो क्या है कि 313 से लेके 316 में मिनिमम 10 साल की पनिशमेंट तो है ही, बट क्वेश्चन में स्पेसिफिकली पूछा हुआ है कि 314 आईपीसी में कौन सी पनिशमेंट है, विच इज डेथ ऑफ अ फीमेल ड्यू टू एन एक्ट विद इंटेंट टू कॉज मिसकैरेज, राइट, विच मीन्स हमारा इस क्वेश्चन में करेक्ट आंसर क्या होगा? ऑप्शन डी, दैट वुड बी करेक्ट आंसर. Let's take our third question. After the delivery of a lady, one fetus gained live birth and the other was found dead and compressed in the uterus. Now this is a very important information. The other was found dead and compressed in the uterus. The father for some reason asked for a DNA testing. The live born child was discovered to not belong to him after testing. The best way to characterize this case is as, okay, so basically पूरे सिनेरियो में हम देख क्या रहे हैं that a female has delivered one live birth, the other fetus is dead. Not only the fetus is dead, but it has a compressed body also. This condition is called as fetus papyraceous. This condition where the fetus is dead and compressed in the body is called as fetus papyraceous, right? This fetus papyraceous happens when two fetuses are growing in the utero, but one fetus which has a deficient or defective blood supply is overgrown by the other fetus, and because of the compressive effect of the growing fetus, the other fetus dies and is flattened. That is how it becomes a compressed fetus. So one fetus grows well, the growing fetus compresses the other fetus. This condition can happen in a situation called as superfecundation. So correct answer here is superfecundation. What is superfecundation? Two ovas released in the same ovulatory cycle getting fertilized by two separate acts of coitus. And these two separate acts of coitus can be done by two separate people or two separate men. And that is how two separate ova released in the same cycle gets fertilized, but one ova grows better than the other. As a result, the better growing fetus causes the other fetus to die and compress, called as fetus papyraceous. Right? This is superfecundation. On the other hand, there is another important word given in option B, which is called as superfetation. What is superfetation? Superfetation is a process where a female who is already pregnant with a fetus releases another ova during the first trimester. So sometimes during the first trimester, another ova can be released and the second fertilization happens to that ova. Okay, and as a result, two separate binovular twins grow in the uterus. Both can grow differently and different deliveries can happen, which may be separated by 1 to 3 months. So examples are there. So there is already a fetus present in the uterine cavity. Within the first trimester, another ova is getting released. Even that ova is getting fertilized, and two fetuses grow, and two separate deliveries which can be distant from each other 1 to 3 months apart can happen. This is superfetation. Okay, so what do we see in superfetation is that already pregnant lady, another ova release during first trimester of pregnancy, two fetus grow with different level of maturity and उसकी डिलीवरी जो है वो सेपरेट हो सकती हैं. राइट, दिस इज सुपरफिटेशन. हमारे क्वेश्चन में क्या पूछा हुआ था कि कंप्रेस फीटस जो डिलीवर हुआ है वो क्या चीज है, वो सुपरफिकेंडेशन का एग्जाम्पल है. ओके, लेट्स टेक द नेक्स्ट क्वेश्चन. A male patient who has worked for previous 18 years in a matchbox industry present to a dentist with many sinuses, fistulae around his jaw. So उसके jaw में बहुत सारे sinuses and fistulae है. Okay, and he is working in a matchbox industry. Now this is a very important information. कई बार हम questions में ये important information miss कर जाते हैं. Chronic एक्सपोजर टू सर्टन केमिकल जो कि किसी ऑक्यूपेशनल सेटिंग में खासकर हो सकता है. ओके, द साइनसेस एंड द फिस्टुलास are draining with unpleasant smelling discharge. Which of the following substances is the reason behind this? इस तरीके के आंसर क्वेश्चन को आंसर करना बहुत सिंपल है. हमें ये पता होना चाहिए कि वो जिस इंडस्ट्री में काम कर रहा है वहां पर ऐसा कौन सा केमिकल, कौन सा कंपाउंड है जो ये कॉज कर सकता है. आमूमन तौर पे हमारे नीट पीजी एग्जामिनेशंस में, एनआईसीटी एग्जामिनेशंस में इस तरीके का एक क्वेश्चन आता है जहां पर द एग्जामिनर वांट्स टू असेस यू ऑन योर नॉलेज that whether you know what chemicals are preferentially used in certain industries, right? In this case, the matchbox industry or the incense industry, माचिस बनाने वाली, अगरबत्ती बनाने वाली जो इंडस्ट्रीज हैं वो पॉपुलरली यूटिलाइज करती हैं फॉस्फोरस. तो करेक्ट आंसर हियर इज फॉस्फोरस. एंड अगर मैं ज्यादा एक्यूरेटली कहूं, दिस इज रेड phosphorus. Red phosphorus is used in the matchbox and incense industries, and workers who are working in these industries for a long period of time, they are very vulnerable to keep on inhaling the fumes of red phosphorus. Okay, this condition which is mentioned here, that is draining sinuses and fistulas, is called as phossy jaw. And this condition is the result of inhalation of fumes of red phosphorus. Right? So correct answer here is phosphorus. Next question. The cause of death was determined by doing an autopsy on a dead person. The examination revealed circular bruises on the neck. Okay, so if I were to draw, let's say, somebody's neck here, we are talking about these kind of circular bruises present on the neck, right? The fracture of the thyroid cartilage was also seen, and bruising of the subcutaneous tissue beneath the neck is also seen. What is the most likely reason of death? The answer is mugging, strangulation, hanging, or throttling. Now, what is the most important clinching factor which is giving in the question? Something that can really take you or jump you towards the answer is the circular bruises on the neck. These circular bruises on the neck, they are result of pressing on the neck by pulp of fingers. So when you take the fingertips and when you press the fingertips to compress the neck like this, the fingertips are going to create circular or slightly oval to circular kind of bruises in the neck, also called as six-penny bruises. Remember, these are also called as six-penny bruises because they resemble the size of a six-penny coin, right? And this procedure is called as throttling, compression of neck by bare hand. Okay, so correct answer here is simply throttling, right? Next, a girl 17 years old was brought to the OPD. When examined, the hymen is intact, vagina is spacious, the labia majora are separated, and the labia minora are flabby. What can be considered possible? See, if you read in this question, there are few findings which are very consistent with the girl having sexual intercourse, also known as habitual, somebody who has experienced sexual intercourse or somebody who has lost her virginity or somebody who is not a virgin. But one finding which is very consistent with the virginity of the female is intact hymen. So although she has an intact hymen, but her vagina is spacious, labia majora is separated, it is not covering labia minora, okay, and labia minora itself is given as flabby. So how can these two things coexist together? That some findings are consistent with a habitual female and one finding is consistent with intactness of her virginity, which means she is someone who has experienced sexual intercourse, but hymen tells that she is virgin. These kind of females are called as pseudo virgins or false virgin. They are not true virgin females. So correct answer here is pseudo virgins or false virgin. So let's say, who is a pseudo virgin or a false virgin? A female who has experienced sexual intercourse but her hymen is intact. Now hymen is a structure which gets ruptured as soon as primary sexual intercourse. So intactness of hymen highly is suggestive of a female being virgin, right? But on clinical examination, as we have seen that the other signs are consistent with her having sexual intercourse, it means she is someone who has experienced sexual intercourse but hymen is intact. The reason is that these females may have a very fleshy hymen, so that when a penile penetration is attempted, the hymen doesn't get ruptured but it rather dilates, so that it creates a track for penile entry into the vagina. But when she is examined, the hymen is found intact. Okay, so let's see what are the differences between a true virgin and a pseudo virgin. So when we examine such a clinical case, what are the findings that we may see? The first is hymen. Now in both the cases, the hymen is going to be intact. But in true virgin, it is not only intact, it does not permit more than a fingertip, right? But in pseudo virgin or a female who has experienced sexual intercourse, because the hymen would be dilated, it would admit 1 to 2 fingers. So when you do a PV examination, you can make that difference. Second is labia majora. In true virgin, it will be apposed, whereas in pseudo virgin or false virgin, it will be open, right? Third is fossa navicularis. It will be seen as intact in a true virgin, whereas it would have disappeared due to sexual intercourse. It would have disappeared in a false virgin. And fourth is vagina itself. In true virgin, the vaginal walls will be apposed, whereas in false virgin there will be roomy vagina. Because of the repeated penile penetration, the vaginal wall will separate, so the vagina will be felt roomy. There is a lot of space in the vagina. So these are the differences that we can see in examination of true virgin versus false virgin. Next question. The prosecution files an appeal after the defense lawyer asks a leading question. During the court hearing, the appeal is accepted by the judge. Okay. Out of the given options, leading questions are not allowed with the exception of. So question basically is asked in an indirect form where the question wants to ask leading questions कब allowed होते हैं. और ये क्वेश्चंस रिपीटेडली काफ़ी बार एग्जामिनेशन में पूछा गया है डिफरेंट फ्रेजिंग के अंदर डिफरेंट तरीके से कई बारी कुछ सिचुएशंस देख करके और हर स्टूडेंट को ये चीज़ मालूम होनी चाहिए लीडिंग क्वेश्चंस कैन बी आस्क्ड ड्यूरिंग क्रॉस एग्जामिनेशन. करेक्ट आंसर इज क्रॉस एग्जामिनेशन, राइट. लीडिंग क्वेश्चंस एग्जामिनेशन इन चीफ में नहीं पूछ सकते, री एग्जामिनेशन इन चीफ में भी नहीं पूछ सकते और डाइंग डिक्लेरेशन में भी डाइंग डिक्लेरेशन रिकॉर्ड नहीं करी जाती विक्टिम से उससे लीडिंग क्वेश्चन पूछ के. तो डाइंग डिक्लेरेशन इज रिकॉर्डेड इन प्लेन एंड सिंपल वर्ड्स. जो भी विक्टिम बोलना चाहता है उसी के वर्ड्स में. नो लीडिंग क्वेश्चंस आर आस्क्ड टू दी विक्टिम. व्हाट आर लीडिंग क्वेश्चंस? लीडिंग क्वेश्चंस आर दोज काइंड ऑफ क्वेश्चंस वेयर द आंसरर यानी कि जो विटनेस है जिससे वो सवाल पूछा जा रहा है he has to answer in yes or no. So you lead the witness to a point where all he has to do is say yes or no. Okay. Next question is, if farmer felt something bite his leg while he slept in the field, something was slowly backing away from him. After that he became sleepy and was brought to the hospital. He started to feel discomfort in the same area of the cut and the bleeding from it continued. So important thing which is given here is a very continuous bleeding. The cut turned red and developed blisters. Okay, so there is a history of development of blisters also. What is the most likely reason among the following? Okay, so we are talking about a farm field and some kind of a sting that a person felt in his lower limb while he was sleeping, and he saw something backing away from him, and later on there is continuous bleeding from that area and also development of blisters. Okay, this thing is consistent with a snake bite. The only thing that we need to differentiate here is what kind of snake. Does it look to be a neurotoxic snake or it does look to be a vasculotoxic or hemotoxic snake? Okay, so if we read the question completely, development of blisters, continuous bleeding from the site of bite is consistent with a hemotoxic snake bite, which means this snake would be viper. Out of the two options A and B, viper and cobra, cobra is a neurotoxic snake and viper is a hemotoxic snake, right? So this is consistent with a viper bite, right? Okay, with that we come to the end of discussion. Stay hard in your preparation and keep faith. See you next time. Bye.
Hello. I hope you had a good CBoT. Let us discuss the anesthesia question which was asked. The first question. A 42-year-old man with serum creatinine value 4.5 and a serum bilirubin level 6 mg per deciliter. Which of the following muscle relaxant can be safely used in this patient? Now, the patient has derangement of level of serum creatinine, so renal function is bit deranged, and the LFTs are also bit deranged. So in this patient, which neuromuscular blocker we will use? See, most of the neuromuscular blocker is metabolized by liver and kidney. So in case of liver and kidney dysfunction, we need to be very careful in using those neuromuscular blocker. Their action can get prolonged. Which is the safe agent in this case when the liver and kidney of the patient is deranged? A neuromuscular blocker which is independent of organ metabolism, and that is your atracurium and cisatracurium. So let's see the options: pancuronium, doxycurium, vecuronium, cisatracurium. Well, the answer has to be cisatracurium. So as I discussed, atracurium, and its cis isomer, cisatracurium. Both of them are metabolized by Hoffmann degradation and non-ester hydrolysis. So Hoffmann degradation and non-ester hydrolysis. Okay, so both are metabolized by these two processes, right? Both these process of metabolism, Hoffmann degradation and non-ester hydrolysis, are organ independent, right? They do not need the support of liver and kidney for its metabolism. Hoffmann degradation is non-enzymatic self-destruction of drug, and non-ester hydrolysis is the ester which is released by RBC, WBC. They metabolize these drugs. So neither liver nor kidney is required for the metabolism of these two drugs, atra and cisatracurium. In case of liver and kidney dysfunction, they would be our neuromuscular blocker of choice. If in a question both are given in the option, then which drug we should choose? Definitely we should choose cisatracurium. This is a better atracurium. The benefit of cis-atra over atra is that cisatracurium release less histamine and is cardiovascular stable and is more potent than atracurium. So if I compare them, then atra is less potent, release more histamine, and is more cardiovascular unstable, and cis-atra is a better drug. So remember this. Coming on the next question, a 32-year-old driver was brought to the emergency room following a collision, RTA. What kind of cannula should we should attach for the fluid administration? Well, in trauma, when we need the cannula for fluid resuscitation, then we should choose the thickest possible cannula which we can put in the patient. So gray one, it has 16 gauge. The green one, it has 18 gauge. The orange is 14 gauge. And the blue is your 22 gauge. So which is the thickest one among these? The orange one. So I would go for orange cannula, right? Remember, 16 gauge and 14 gauge, that is orange and gray. Both are used in trauma and cardiac surgery, right? Both are used in trauma and cardiac surgery. And your 18 gauge and 20 gauge. 18 gauge is your green and 20 gauge is your pink. These are the commonest one used in adult. So these are used in adult in perioperative period. And both are used for fluid resuscitation. And then 22 gauge and 24 gauge. This is used in pediatrics. These are pediatrics cannula. Okay, so these are the cannula color coding. Color coding we need to remember. 22 gauge is your blue one and 24 gauge is your yellow one. Okay, so remember. Next question. You see the OT is using this particular vaporizer. So image based question. Which gas do you think is coming out of it? So this vaporizer is using which inhalational anesthetic agent? This is a unique vaporizer. It has a blue color on it. So blue color coding. So blue color coding of this unique vaporizer is for desflurane. Now desflurane requires a special vaporizer, right? So halothane, halo, iso, CBoT and des. These are the agents which we give by vaporizer because all of them are liquid at room temperature and they need to be vaporized. Okay, these three, the boiling point is 50 plus minus 2 degrees Celsius. Desflurane is liquid but can boil at room temperature 22 to 23 degrees Celsius. So desflurane needs a special vaporizer. This needs a special vaporizer. Okay. So desflurane requires a special vaporizer. Remember this. So desflurane, this is a vaporizer of desflurane. Now color coding which we need to remember. Halothane has red color code, iso purple, sevoflurane yellow, and desflurane blue color code. Okay. Okay. Now coming on next question. When filling up 26 years old patients preoperative food advice there in their chart for an elective surgery, what advice would be for the fasting? So what will be the NPO advice? Now for NPO advice for adult and for pediatric, we need to remember some timelines. For adult, 8 hours, 6 hours, 4 hours and 2 hours, right? 8 hours for full fatty meal, okay? 8 hours for full fatty meal, 6 hours for light food, light, semi-solid food, okay? 4 hours for, let's say, 4 hours we don't use in adult. I have written it here just to compare it to pediatric. 4 hours is only for used in pediatric and this is for breast milk. Breast milk. So 4 hours is not used in adult, it is used in pediatric for breast milk, and 2 hours in both for clear fluid. Okay. So for both, for clear fluid, it is 2 hours, like your tea without milk, your plain water, coconut water, right? For pediatric also same, 8 hours for full fatty meal, 6 hours light semi-solid food and outside milk like cow, etc. and your infant formula, other infant formula as well. For all that we need a 6 hours NPO. 4 hours is only for pediatric, that is for breast milk, and 2 hours in both for the clear fluid. So let me see the options. 8 hours for full fatty meal, 2 hours for plain water. Well, this seems a right option. So I would mark for it and let me read others as well. Always read all the option before answering the question, because in medical, in your entrance exam, they say best possible answer. 2 hours for full fatty meal, 4 hours for plain water. This is incorrect. 2 hours for full fatty meal, 8 hours for plain water. This is absolutely incorrect. 4 hours for full fatty meal, 2 hours for plain water. This is also incorrect. So definitely A is the correct choice. Okay. Now coming on the fifth question. An acute pancreatitis patient weighing 75 kg was admitted to emergency room, sent to ICU and was put on intubation on mechanical ventilation with FiO2 90%, that is 0.9, PEEP 12, respiratory rate 16, tidal volume 420, and his ventilatory setting was his ventilatory setting, and ABG analysis listed below. So in ABG, for any setting of ventilator, after 30 minutes we get an ABG done and we analyze for oxygenation and ventilation. For oxygenation analysis we see PaO2 and for ventilation analysis we see PaCO2 and pH. So pH is 7.33, but acidosis, a little acidosis, normal is 7.35. Okay, PaO2 is 110, which is absolutely within normal range, 98. Normally it should be above, let's say 60, above 60 on normal healthy person. On room air it is 98 to 100 and it should be above 60 to prevent hypoxemia. PaCO2 is 58, well, little higher side. Normal is 35 to 45 mm of Hg, right? Or let's say 40 to 45 mm of Hg. 35 to 45 is in EtCO2. So it is little higher. SpO2 is 100%, right? Patients SpO2 is 100%, SaO2 most probably also would be 100%. Okay, in pulse oximetry reading we could I write it SpO2 and ABG reading we write SaO2. So what would be the next thing we do in ventilator setting? Well, patient has achieved a right PaO2, right, on this setting of FiO2 90 and PEEP 12. Now FiO2 is very high. When we need, the target is more than 60, just more than 60. Okay, it should not be, and it should be just more than equal to 60. That would be good enough for PaO2. We should not go for very high PaO2 target, because for that, if we need to give a high FiO2, this can also be cause oxygen toxicity and can also produce a lung injury. So we need to decrease FiO2 as soon as possible to non-toxic level. So one thing I have to do, seeing this PaO2 is normal, I would reduce the FiO2. Okay, so one thing which I need to do is I reduce to FiO2. But PaCO2 is also higher side. One thing which I need to do, I have to improve the ventilation. And how do we improve the ventilation? By increasing the respiratory rate and by increasing the tidal volume. Now remember, in pancreatitis, especially acute pancreatitis, we go for lung protective mode of ventilation. So in acute pancreatitis, we go for lung protective ventilation, right? So lung protective positive pressure ventilation. For this, tidal volume should be chosen between 6 to 8 ml per kg body weight, right? If it is possible, if the airway pressure is rising, we can reduce it, let's say even lesser than 6, if we are able to achieve just adequate pH and PaCO2 what we target. So we need to keep the pH above 7.25, that is the target pH above 7.25, and PaCO2 we should keep it less than 50 to 55 mm of Hg to achieve this pH, right? So this should be the target for lung protective ventilation with a low tidal volume ventilation. So low tidal volume ventilation, okay? This is lung protective mode of ventilation. So in this patient, PaCO2 is little higher, little out of range, for which what we can do, we can increase the tidal volume. But we can tolerate this PaCO2 and airway pressure of the patient is within the normal limit, it is just towards the higher side. I would not increase the tidal volume. I would try to keep it lower side because patient is 75 kg. Patient is 75 kg, and if I give 6 ml per kg body weight, then what do I give? I give 450 ml. Okay, and we are giving the patient 420 ml. Yes, little bit of tidal volume we can increase. So I can increase the tidal volume. So this is one option we can go for. Or we can also decrease the FiO2 because the PaO2 has been achieved. So this option seems also correct. So what I will choose in this two, increase tidal volume and reduce FiO2. Actually, I would do both in my practical clinical patient. But what answer I would choose in this patient? If the, let's say, PaCO2 is increasing, is a 58, the first thing which I will do, I will increase little bit of the tidal volume, keeping the airway pressure within the limit which I want, less than 35 mm of Hg, and I will increase the tidal volume. After increasing the tidal volume, I will reduce the FiO2. So I would choose for answer D, right? I would choose for answer D. Okay. If PaCO2 was given 55, right, I would have just gone for the option reduce FiO2. So go like this for the answer. So in this patient, we would increase the tidal volume. The answer has to be D, which is better than your B, right? But both we can do, seeing the question. Okay. Then for this patient, fourth, the NP order question, answer is A. Then the image-based question, the answer is desflurane. For the cannula, which cannula in trauma patient? The answer is orange cannula, which is 14 gauge. And which neuromuscular blocker in liver and kidney dysfunction? Cisatracurium. So these were the 5 questions which were asked. I hope you have done all your 5 questions correctly, right? So best of luck for your exam. Thank you.
Ladies and gentlemen, welcome to the Ophthalmology CBoT 6, and let's see what you've done. This has not been a very difficult paper, and I hope that you've all done well here. Let's look at this. And as before, again, your friendly neighborhood ophthalmologist guiding you through the questions. Let's take a quick look at this. A 65-year-old smoker has a 4-week history of decreased vision with distortion of images in the right eye. The patient is suffering from visual problems like difficulty in driving and reading newspaper for the last year. So what you see here is an old guy, well, 65 is old, but not really very old, of decreased vision with distortion of images in the right eye. So now remember, distortion means metamorphopsia. Metamorphopsia pinpoints the diagnosis towards some retinal problem, macular problem actually. They're not. Visual problems, difficulty in driving the newspaper for the last year, newspaper, again macular function, remember. When you read something, pupils constrict, so the basic vision is hitting the fovea. He is not suffering from diabetes or hypertension, that's good. On right eye examination, it was found to have a grayish discoloration of the macula with adjacent areas of hemorrhage. Okay, now that's very significant. What should be targeted in this patient to treat this condition? Choices of tumor necrosis factor alpha, interleukin 2, EDGF, and VEGF, that is vascular endothelial growth factor. Now, first of all, we have to diagnose the condition. So, remember we said metamorphopsia, which pinpoints the diagnosis to a retinal and rather macular disorder. Also, that he has a grayish discoloration of the macula with his hemorrhage, and the diagnosis, you've all got it, and that is quite right. It is ARMD, age-related macular degeneration, which is the wet or the exudative variety or the wet ARMD, which constitutes about 10% of the ARMD. Remember, we have two different types called the dry and the wet. The dry RMD is 90%, is the more benign form. The wet RMD is the more dangerous one, it's only 10%. Okay, so this is wet RMD. Why? Because the hemorrhage, the grayish area and the hemorrhage, very typically you can see the grayish area, this is how it looks like, and the hemorrhage from the vessels that have already started bleeding. This is typically VEGF. The diagnosis is wet RMD, and we all know the diagnosis is going to be anti-VEGF drugs. So we inject through the pars plana, we have to inject any of the anti-VEGF drugs like bevacizumab or ranibizumab. These are the drugs that you inject. So the answer should be quite clear, legend, is choice D. Very well. Next question, a 60-year-old woman with a past history of diabetes and hypertension is brought to ophthalmology OPD due to a fall. She's been falling, isn't it? She's been having visual problems for the last 6 months, and because of that, she'd had a history of several ground level falls and has given up driving due to near miss vehicle accidents. She's been falling on and off. She's given up driving. Now, this is very specific for a particular problem, as we're going to talk about it. Eye examination revealed that her peripheral visual fields have been reduced bilaterally with elevated intraocular pressure. She was prescribed Ventilator eye drops. Which of the following structures does this drug target? Okay, now, so we basically given the diagnosis, raised intraocular pressure and loss of visual field. This is glaucoma. We've given the diagnosis. We also given the anti-glaucoma drug, bimatoprost, and what you want to know is what is the mechanism of action. So now, bimatoprost, remember, is a prostaglandin analog, is it not? PA. And remember, even if they had not given us the drug and the diagnosis, we could have got it, because you see, this constant falling around and having near accidents is a very clear sign of visual field contracting. So you see, normally we have visual field, you all know 60, 60, 70, 100. So we can see a lot. Looking straight ahead of the camera, I can see many of the peripheral areas, not. But when there's visual field contraction and then you're not able to see the side vision, so this often leads to accidents, and these people have to give up driving. Okay, they have to give up driving because they can see only through tubular vision like this, and that is why they have often a lot of accidents. We call their cars as fender benders. The fenders of the car are bent because of constant accidents as they drive over footpaths, sidewalks, and they hit over dividers on the road. Okay, so we have been given a diagnosis. So this is a prostaglandin analog, which you want to. So what is the mechanism of action? And that should not be very difficult, ladies and gentlemen, if you know the mechanism of anti-glaucoma drugs. Does it act on the ciliary muscles? Incorrect. It doesn't at all. Does it act on the episcleral veins? Incorrect as well. The uvascleral pathway is the correct answer. You all know prostaglandin analogs work on the uvascleral pathway. Is it not? So, answer is C. Let's discuss this for a second. You know that there are two pathways of aqueous drainage, is it not? 80% of the aqueous humor flows out through in a normal eye, through the trabecular meshwork, is it not? Through the trabecular meshwork. And 20% of the pathway flows through the ciliary body or the ciliary muscle. We call the uvoscleral pathway. This is the normal distribution. See, both of them, they start and reach the anterior chamber angle, and from the angle, they take a diversion. Okay, so trabecular meshwork takes the high road. 80% goes that. Most of it, aqueous, goes through the normal 80% trabecular muscle. And the uvoscleral pathway, the rest of the 20% of aqueous takes the so-called low pathway, and through the uvoscleral pathways where it goes out. Well, it's not really low. I'm just saying it just to make it sound different. That's all. So this is a normal pathway. So now what happens when you use a prostaglandin analog drug like bimatoprost, latanoprost, travoprost, These drugs, they all increase the outflow through the uveoscleral pathway, and that is why the answer is it works on this particular target, the uveoscleral pathway. So this is very important. Now, is there any other drug which also uses the uveoscleral pathway apart from the prostaglandin analogs? And the answer is yes, it does. There is one more drug which belongs to the alpha-2 agonists. The alpha-2 agonists. Remember, alpha-2 agonists, they work on a dual pathway, on two pathways. One, they reduce the production of aqueous also, and second, they also increase the outflow through the uveoscleral pathway. There are dual mechanisms here. Okay, so this also reduces in two different ways, uveoscleral pathway, and there are two drugs in the alpha-2 agonists. One is brimonidine, second is apraclonidine. But you see, apraclonidine nowadays is not used anymore because of its very severe allergic reactions. Okay, it has a lot of follicular conjunctivitis, a lot of allergic reactions. In fact, out of all the anti-glaucoma drugs, remember, the most allergic are the alpha-2 agonists. So apraclonidine is number one, which has been discontinued nowadays, and even brimonidine is well known to cause allergic reactions, but it is much less. So brimonidine is the other drug, kindly remember, apart from the prostaglandin analogs, which use the pathway of the uveoscleral pathway. No other drug, apart from these two, no other drugs use the episcleral venous pathway, which we said is the uveoscleral, not episcleral, beg your pardon, the uveoscleral pathway. Okay, very well. So next question, a 4-year-old child presents with complaints of protrusion of the right eye. Dear me, it doesn't sound very good, particularly for a small child, 4-year-old. It sounds very ominous, in fact. No history of fever, there is no history of fever, but the CT scan shows well-defined mass in the orbit with an irregular border. Now, irregular border is always serious because remember, this leads to some neoplasm, some malignancy, and adjacent bone destruction, even more dangerous. So, you have this jagged edges with bone destruction. It is surely heading towards some malignancy of the orbit. And the biopsy showed small round cells which are Desmond positive. Desmond positive. And what is the most likely diagnosis? So here, Desmond positive, we know all. There's very specific marker for rhabdomyosarcoma. They are very specific markers. Remember, Desmond positives can be seen in a lot of smooth muscle tumors, but particularly are the positive, very specific markers for rhabdomyosarcoma, which remember is the most common primary ocular orbital tumor, beg your pardon, orbital tumor of children. It is the most common malignancy of the childhood orbit. Okay, remember, if you say the most common ocular tumor of the orbit, most common tumor of the orbit in children, it would actually be a benign tumor which occurs here, and this is the most common malignancy of the primary malignancy of the orbit in children is a rhabdomyosarcoma. Okay, so we don't have to look at other choices. It is in rhabdomyosarcoma. This is the Desmond positive cells, so specific a marker for rhabdomyosarcoma. A 72-year-old patient presents to you in the ophthalmology OPD for a follow-up. 3 months back, he had a history of a sudden painless loss of vision, and he was diagnosed with CRVO, central retinal venous occlusion. So we've got our history here, for which he was treated and his vision improved. So 3 months later, he had a red eye with raised ocular pressure of 60. That's pretty high. So he has glaucoma. Okay. Among the following options, which is the most likely diagnosis in this case? So remember, let's summarize our information. So we have a patient of CRVO which resolved and now has glaucoma because raised intraocular pressure with red eyes. What kind of a glaucoma is seen in CRVO? Remember, it is obviously neovascular glaucoma. In fact, it is the famous, or I should say infamous, 90-day glaucoma, which is 90-day glaucoma, you all know, is a glaucoma which occurs within 3 months of a CRVO, of an ischemic CRVO. This is we call it, this is the second commonest cause of neovascular glaucoma is CRVO. The most common cause of neovascular glaucoma, as you all know, almost 30% of neovascular glaucoma due to that particular cause is diabetes. Second commonest cause is CRVO. Please remember, 90-day glaucoma is specifically glaucoma which is neovascular glaucoma occurring after CRVO. So when you say 90-day glaucoma, it only means neovascular glaucoma occurring after CRVO. So the answer is neovascular glaucoma, and that you can see here, which is this ferocious neovascularization, the rubeosis, see the redness of the eyes. You can sometimes see ectropia on UVA, where the pupil margin is pulled out like this, pressure is very high. This is a very difficult glaucoma for us to manage, and I hope you all got this right. A 80-year-old smoker, we have an 80-year-old smoker, hypertensive and diabetic male patient comes to the OPD with gradual onset of blurred vision in both eyes, along with difficulty in reading and driving at night due to bright halos or colored halos for the past 3 months. Vital signs are normal, visual field testing is normal, and the corrective vision in both eyes is 6/18. So the maximum with correction, which means with the glasses, with contacts, is only 6/18. What is the most likely diagnosis of the patient? Remember, the clue here is that apart from his problems of blood pressure and sugar, he's a smoker. He comes to with blurring of vision, which is painless because they do not mention any pain, difficulty in reading newspaper and writing at night due to colored halos. Now, that is the clue because colored halos are not seen in too many conditions. In fact, the 3 most common causes are cataracts, you have angle closure glaucoma, mucopurulent conjunctivitis. Is it not? So, is diabetinopathy incorrect? Diabetinopathy, you do not expect colored halos. Hyperretinopathy, again hyperretinopathy incorrect, you do not expect colored halos. Cataracts is right, as I was mentioning, and ARMD does not have colored halos again. So, the answer here, ladies and gentlemen, is a cataract, which causes, why does it cause colored halos like this, which you see here? This is because of the differing refractive indices of the various parts of the lens. As the aging lens develops a cataract, so the refractive index differ. The center could be 1.40, the periphery could be 1.38, and the mid periphery could be 1.39. So, because the rays of light hit various areas with different refractive indices, so some get bent earlier, some get blunt later, and they produce a colored halo. Remember, this mechanism of colored halos in cataract is very different from the mechanism of colored halos in glaucoma, where the reason is angle closure glaucoma is corneal edema. The corneal edema is droplets of fluid collecting in the cornea, which behave as an optical prism, is not? So, you see, as the rays of light strike the prism, all prisms, they split the light like multiple colors of the spectrum. So, that is why these patients, they develop colored halos in glaucoma. This is completely different from the mechanism in cataracts, where there is no corneal edema. Okay, so the answer is cataracts indeed. Let's look at the next question. A 65-year-old asthmatic patient visited an ophthalmic OPD for regular screening and was found to have increased intraocular pressure of 28 millimeters of mercury. That's pretty high from a normal of 21. He's taking inhaled LABA. LABA stands for long-acting beta agonists, and ICS is inhaled corticosteroids combination to manage his asthma. That's correct. You have to use long-acting beta agonists and inhaled corticosteroids to manage his asthma. While vital signs are normal, the eye examination shows normal conjunctiva, lens, and cornea. So, perfect. That's all fine. What is not so perfect is on fundoscopy examination or retina examination, you have a cup ratio of 0.8. Remember, that's pretty high. Normal cup ratio should vary from 0.3 to 0.6, and anything more than 0.6 is deeply suspicious. So, here we have a 0.8 cup disc ratio, and we have a disc pallor. The disc is also pale. So, that is another clue towards developing glaucoma. And the third is asymmetry of cup disc ratio. Remember, asymmetry means when the cup disc ratio between the two eyes is more than 0.2. That means if one of them is 0.5, the other is 0.7, this is called cup disc asymmetry. Within 0.2 cup disc ratios of both the eyes, they would have been normal. And again, it's the third sign of glaucoma. So, we have 3 signs of glaucoma, which use the cup disc pallor, the cup disc ratio, and the asymmetry of cup disc. Plus, the intraocular pressure is high. So, we have diagnosed glaucoma. Now, the question is, what is the next best step? Should advise to stop all glucocorticoid therapy? Remember, this is not possible. It is in the glucose in the steroid which causes a glaucoma, but it is the glaucoma that is causing it is the steroid which causes the glaucoma. The inhaled corticosteroids, could be beclomethasone inhalation, could be budesonide, and they have chance of causing glaucoma. So, should I stop the steroid? It is difficult because remember the asthmatics, if you stop the steroids, they may have a bronchial asthma attack. So, this is not possible. Should I use atropine? Incorrect. Atropine is not an anti-glaucoma drug. It has nothing, it cannot lower the intraocular pressure here. Timolol should be stopped. Incorrect. Why? Because remember, timolol is a beta blocker, and you cannot give a beta blocker to a bronchial asthma. It will cause bronchoconstriction and it may lead to bronchial asthma flare-ups. So what is left must be correct. Latanoprost eye drops should be started. So again, we start a prostaglandin analog because the pressure is high, and the drug of choice of open-angle glaucoma, remember, or steroid-induced glaucoma in this case, would be a prostaglandin analog, which is a latanoprost, like which we see here. So this is the drug of choice. We cannot stop the glucocorticoids because that's important to maintain the airway passage, and the rest of course are not at all indicated. So answer here is latanoprost should be started for treatment of glaucoma. Next question is a 30-year-old lady. It's a long question, ladies and gentlemen. So let's read this. A 30-year-old woman presents with complaints of itchy eyes from the past several months, with gritty sensation in her eyes and crusting of her eyelashes in the morning. Okay. She has no eye pain, photophobia, or visual disturbances. Seborrhea is present on the scalp and eyebrows, but the skin of the face appears normal otherwise. And the patient doesn't use facial cosmetic products, very good indeed, and there is no exposure to any sick patients and has not changed bathroom products recently. So see how many things have not changed bathroom products, and you haven't had cosmetic products, so there's no question of any allergies. And because she's not in touch with infectious patients, so she does not have an infective condition also. So allergies ruled out, infections ruled out. The analysis of the patient is shown in the picture where you see it like this. Which of the following options is the proper diagnosis? Is it dry? It is incorrect. In dryness, you don't have crusts like this. Allergic conjunctivitis, incorrect. I told you that has not changed bathroom products or has not used a new product, so it's unlike to an allergy. Could be hordeolum, which is incorrect. Either external hordeolum, which is called a sty, or internal hordeolum would be extremely painful. Okay, there's nothing mentioned here. She has no eye pain, remember, so it's ruled out. There's no photophobia, no disturbance. So whatever left behind is blepharitis, infection of the anterior lid margin. Blepharitis, which in this case is called a squamous blepharitis. Remember, there are two kinds of blepharitis. You have anterior blepharitis, you have posterior blepharitis. Okay, in the anterior part of the eyelid margin gets inflamed, we call it anterior blepharitis, and if the posterior margin of the lid gets inflamed, called posterior blepharitis. Anterior blepharitis is classified in two different types. One called a squamous blepharitis. Squamous blepharitis, okay, which is basically when the dandruff from the scalp travels down here and is visible to us like these collarettes, which you see here, small eyelashes sticking, this whitish discharge looking like dandruff, looks very ugly, sticking to the base of the eyelashes. Okay, these are called collarettes, and they could be seen in squamous blepharitis. The second type of anterior blepharitis is called as meibomianitis. Beg your pardon, it is not meibomianitis, it is called ulcerative colitis. Ulcerative blepharitis. Beg your pardon, I am veering towards colitis. Ulcerative blepharitis, also called as staphyloccal blepharitis. This is infectious. How would you know the difference? Remember, they'll have small ulcers at the base of the eyelashes, and it's extremely painful. And the telltale sign is when you take out these crusts, you can see the bleeding at the base of the eyelashes. So they're painful and they cause ulcers, and they bleed when you pull them out. So this is how we distinguish between ulcerative or staphylococcal blepharitis from the more common variety of squamous blepharitis, which is because of the greasy scalp and migration of the grease to the base of the eyelash. Here you have to wash the hair also and have it treated by a dermatologist to treat the seborrhea. Posterior blepharitis, posterior lid margin, is what is called as meibomianitis, where you will see inflammation of luminal glands, and you will see the soap bubbles which cause so much burning sensation. Here, the typical look is of squamous blepharitis. The history is of squamous blepharitis. It is indeed blepharitis, but not allergy, not dry, and not hordeolums. Very well. The last question, gentlemen, is a 35-year-old woman who uses extended wear contact lenses and presents with complaints of left eye pain, redness, and discharge since morning. Doesn't look very good. Wearing lenses, having pain and discharge. She's having difficulty with the lens, even worse. Her past medical history includes chronic back pain, obese bodily habits, and acid reflux disease. May or may not be a red herring. On eye examination, a thick greenish yellow discharge is present at the medial eye corner and the lid margins. Very ominous, a greenish color thick discharge is very suggestive of one particular dangerous organism which we are very scared of. The corn is edematous, hazy, and ulcerated, and there is extensive scleral injection. What is the most likely diagnosis in this patient? This is the one that I told you that we need to be scared about. The answer is Pseudomonas keratitis. Pseudomonas, remember Pseudomonas, is an extremely dangerous organism because it has these lipases and these enzymes which can capable of digesting the cornea in 48 hours. Okay, so very sticky, very difficult to dislodge. Pseudomonas, and unfortunately, is the commonest organism attacking a contact lens wearer. Okay, so whenever you have a contact lens wearer, you have to think of Pseudomonas. You'll see the classic grayish green discharge. Okay, and one more sign mentioned here. Remember, it's well known for its scleral extension. Okay, a lot of these corneal ulcers, remember, do not extend to the sclera, but this is an exception to the rule. The Pseudomonas is well known to extend to the sclera and may perforate the sclera also. So this, we've got every information here. It is, the answer is Pseudomonas keratitis, remember, is the most common cause of corneal ulcer in a contact lens wearer. So you will know Pseudomonas by intense pain, by grayish green discharge, the congestion, and the scleral inflammation, which is simply too much. Okay, so the answer is Pseudomonas keratitis. And the best of luck to this patient also, because Pseudomonas keratitis usually is very difficult to treat. And with that, ladies and gentlemen, thank you for a very patient hearing for this CBoT 6 in ophthalmology. Thank you very much and all the best.
Hello, welcome students. So I am your dermatology faculty, Dr. Manish Soni, and let us discuss these few questions of dermatology. In this first question, they are saying that 21-year-old lady has a complaint for 15 days about yellowish discoloration in her axillary sweat. So there is yellowish discoloration in the axillary sweat, stains on her clothes. She doesn't have any more complaints. Upon examination, her hard nodular masses resembling yellowish concretions are observed on the left axillary hair shaft. So over the hair shaft, these concretions are present. Skin beneath is typical, means the skin is normal, only problem is here in the axillary hair follicles. Which organism is most likely to cause this condition? So do you know any condition where yellowish discoloration of the axillary hair follicles is seen? Yes, that condition is trichomycosis axillaris. And remember that this mycosis word is there, but still it is not a fungal infection. This mycosis is a misnomer, and this is a bacterial condition caused by Cornybacterium tenuis. So Cornybacterium is the causative organism for trichomycosis axillaris, and that's why this becomes the answer. 20-year-old girl presents herself to the dermatology outpatient department with the results seen in the picture below. So in the picture, what you can see that probably patient is having acne because these papules and comedones are present. Which organism is most likely to be the causative organism? So all of you know that acne is caused by, in the etiology of acne, there is role of Propionibacterium acne. So Propionibacterium acne is the etiological factor for acne vulgaris. The following lesions on the extensor aspect of the elbow is seen in a 27-year-old guy who first appears in December. So December mein it is started. Why? Because this condition aggravates in winters and it is present where? Over elbows, that is extensors. So can you guess the condition? Yes, probably this is psoriasis, because in psoriasis such erythematous plaque with silvery white scaling is seen. Winter is the predisposing factor. Extensors are commonly involved. So just from the first line, you can make out that probably this is a case of psoriasis. There is itching in relation to the lesion. In addition to smoking, about 9 cigarettes a day and drinks alcohol. You know, smoking and alcohol both are the predisposing factor for psoriasis. It aggravates psoriasis. The first time the doctor touched the source, the scales became larger. a shiny red membrane was relieved, not just touched but scrapped. So if you scrap the lesion, then you can see that more and more scales come out, and the shiny membrane which is revealed when the scales are removed, that is known as Berkeley membrane, which is again a feature of psoriasis. There were pinpoint bleeding spots, and when you remove the scales, so on just touching it won't happen, but if you scrap the lesion, then you will find in the end result is pinpoint bleeding, which is known as Auspitz sign. When the membrane was peeled, according to him, the trunk also has similar lesions. So trunk is also a common site, especially the back and the buttock. The patient will have every other trait listed below with the exception of. So oil drop sign is feature of psoriasis. This is the most characteristic nail change seen in psoriasis. Nail pitting is the most common nail change associated with psoriasis. Worn off ring is the hypopigmented ring which is sometimes seen around the lesions of psoriasis, especially after phototherapy. But Sézary cells is not a feature of psoriasis. It is seen in mycosis fungoides, which is a cutaneous T-cell lymphoma. So answer becomes Sézary cells. A young child diagnosed with Down syndrome exhibits big warty crust. So a lot of crusting is there on his feet, hand, and there is also skin scaling over the face, neck, trunk. What could be the probable diagnosis? Okay. So if you see the image, there is a lot of crusted lesions, okay, and if you look at the options, in all the options, scabies is mentioned. So do you know any scabies which is very severe, especially seen in psychiatric patients like Down syndrome and also having lot of crust? Yes, it is crusted scabies, which is also known as Norwegian scabies. This is the most severe type of scabies, and in this type, generally the patients involved are psychiatric patients or bedridden patients because they are not able to maintain their proper hygiene, and that's why a lot of infestation can lead to such crusted or Norwegian scabies. A baby with subependymal nodules on his MRI brain, convulsions and intellectual disabilities is brought to the pediatric OPD. Upon examination, the cutaneous lesion that follows is observed. What could be the lesion which is shown in the image? So there is subependymal nodule on the MRI, subependymal nodules. Convulsions, that is epilepsy is there. Intellectual disability, that is mental retardation is there. So do you know any condition? Yes, epiloia, which you can very easily remember. Epi for epilepsy, LO for low, I for IQ, so intellectual disability, that is low IQ, mental retardation, and adenoma sebaceum. All these are features which are seen in, yes, tuberous sclerosis. So in tuberous sclerosis, various type of lesions can be seen, like over face adenoma sebaceum can be seen, and here in the image you can see this hypopigmented lesion which looks like a leaf. So this is what? This is ash leaf macules which can be seen in tuberous sclerosis. Remember, confetti macules can also be seen, but they are generally present over leg and they are very small white macules. Shagreen patch can also be seen in tuberous sclerosis. It is generally seen over lumbosacral area and it is a plaque. And angiofibromas are the facial angiofibromas, which are also known as adenoma sebaceum, and it is usually seen over face. So probably this is ash leaf macule because it looks like a leaf and it is hypopigmented. So ash leaf macules become the answer here, and the condition is tuberous sclerosis. So I hope this was useful for all of you. Thank you very much.
Hi everyone. So let's discuss the questions of biochemistry from your CBoT exam. So the first question is that a patient presents with hereditary deficiency of aldolase B. So what is your diagnosis? Hereditary fructose intolerance. And this leads to accumulation of fructose 1-phosphate. Yes, because guys, when fructose is converted into fructose 1-phosphate, this happens in liver. Name of enzyme is fructokinase and -1 ATP is used, but next enzyme is missing, that is aldolase B. So obviously fructose 1-phosphate will accumulate. Now guys, Clinical feature which is not found. So this question is easy because oil drop cataract is only found in the classical galactosemia. That is a classical feature of galactosemia. But looking at the other options, see guys, when there is a ATP deficiency, you know what happens? The liver failure occurs, right? And guys, because of liver failure, there will be the features of jaundice, hepatomegaly, etc. And guys, because fructose 1 phosphate is accumulated, it is inhibiting the glycogenolysis by inhibition of glycogen phosphorylase, right? So glycogenolysis will stop and this will cause again the same problem, that is hypoglycemia, right? So hypoglycemia is also a very important feature, and hypoglycemia occurs after the food, right? Like the mother will say that I gave the baby food which included juice, you know, at 3 o'clock, and now the baby is, you know, crying, screaming, or, you know, became drowsy because of hypoglycemia, right? So hypoglycemia will also be there. But guys, this will be 6 months, yes. Jaundice, yes. Mental retardation, again, not very common here. Yeah, it is least common feature of this hereditary fructose intolerance. And it is a feature of classical galactosemia. So yes, oil drop cataract becomes the best answer here. But yes, if the same question appears in the ionized CT with multiple answers, you can go with B and C both. Not a feature of hereditary fructose intolerance. Mental retardation, yes, not a feature. Cataract, never a feature. Okay. Next question. So guys, this patient was taking statins, right, for the last 10 years. And you know, the statins will accumulate, statins will inhibit the which enzyme? HMG coenzyme A reductase. So obviously the HMG CoA will not be utilized in the pathway, and this will be low. This will be accumulated, I mean to say, right? But the other points like squalene, mevalonate, which are formed after the HMG CoA reductase option, so they will be, you know, low in the quantity. Lac Y. So guys, this question is based on lac operon. So like this is a double-stranded DNA. In this DNA, there are 3 genes in the E. coli, right? 1, 2, and 3. And these are named as ZYA in the lac operon. These 3 are called as structural genes. You should know this name. So how many structural genes? 3 structural genes are present in the lac operon. And guys, because you know, they metabolize, they produce an enzyme which is required for lactose digestion. So this is produced by Z, that is galactosidase. Y produces the permease, so this is our answer, and A produces the acetylase, transacetylase. Okay, so these 3 produces enzymes of lactose digestion in the condition when the glucose is absent but lactose is present. You should know this. And when the lac operon is expressed, when the glucose is absent, first condition, and lactose must be present obviously. Tabhi to hoga. So that is your lac operon, right guys? 9-year-old girl present with the bilateral symmetrical discrete papules with a central keratinous plug localized to the elbows. So guys, basically this is the case of phrinoderma, right? So this line is very important. You must remember this line, that papules with central keratinous plug, and especially localized to the extensor surface like elbow or the knee. So which of the following statement is incorrect? So they are asking incorrect statement. So phrinoderma is due to deficient vitamin A, right? So it occurs due to retinoic acid or vitamin A, correct. Absent in green leafy vegetables? No, it is richly present in the green leafy vegetables, that is vitamin A. Pharmacological action of retinoic acid can be to treat acne, yes. Patient may also present with xerosis, conjunctival xerosis, yes. So B is our correct answer. Guys, remember that phrinoderma is also caused by the essential fatty acid deficiency. Okay, so vitamin A or EVFA, that is essential omega-3, omega-6 deficiency, can also lead to that, especially omega-6 deficiency. Okay, so remember this point, this may be a question also. Which of these mineral is antioxidant enzymes, you know, cofactor? Okay, so answer is selenium. Which enzyme guys? Glutathione peroxidase, right? Glutathione peroxidase. Okay, so that's the name of the enzyme. Fine. You should also know, you know guys, this is enzyme. Why we call this antioxidant? Because this breaks the hydrogen peroxide and convert this into the water. Okay, converts this into water. Correct guys? So this is the antioxidant enzyme. Am I clear? You should always remember the 3 enzymes activated by selenium: deiodinase, glutathione peroxidase and thioredoxin reductase. All three important, very important. Guys, in the options given, iron is, never a molecule which is antioxidant. It is always oxidative. If you remember that it can break the H2O2 in the Fenton's reaction to the hydroxyl ions, which are very, very dangerous, right? Linkage in the nucleotides. So guys, nucleotides are connected by phosphodiester bond, right? So nothing difficult here. So it's very easy question. And guys, remember the nucleotides are joined by hydrogen bonds, like 3 hydrogen between G and C and 2 hydrogen between A and T. And when I say nucleotide completely, like this is a nucleotide with the sugar, phosphate, base, hydrogen, OH group. So this OH group will be linked with the phosphate of the next, okay, like this, with the phosphate of the next nucleotide. This is the phosphate, again H, again OH, and this is the base. So they are linked by 3' OH and 5' phosphate. So that is a phosphodiester bond. Okay. Which of the following is true with respect to glycine? Glycine is present in pyrimidines? No. Guys, pyrimidine synthesis requires only glutamate and aspartate. No glycine is required. This is a very important PYQ also. Source of nitric oxide? No, that is arginine. Okay. Absent in collagen? Absent in collagen? No, it is richly present in collagen. 30% of amino acid in the collagen is this. And it is present in glutathione? Yes. Guys, glutathione is GSH. Where the G stands for any amino acid starting with the G, that is glycine and glutamic acid, SH groups of cysteine. So always remember the SH groups are of the cysteine. Clear guys? So guys, next question. 40-year-old chronic alcoholic male with the truncal ataxia. So there is ataxia, breathlessness, right? On examination, peripheral edema, tachycardia, cardiomegaly were found. Nystagmus is there. What is the most probable? So guys, this is an alcoholic patient and the question is on the nutritional deficiency. So that is most probably beriberi, right? Because the most common vitamin deficiency found in alcoholics is this. And alcoholics with the beriberi, right, they presents with when it is like Wernicke's syndrome, that is GOA, that is generalized confusion, then ophthalmoplegia, and A for ataxia. So there is ophthalmoplegia also, confusion also, and ataxia also, right? So the answer is beriberi. Alcoholics most commonly present with the case of thiamine deficiency, correct? Which is a biochemical change seen in osteogenesis imperfecta. So guys, there are a lot of genes involved in osteogenesis imperfecta. Glycine is replaced by tyrosine. That is one case in which a small amino acid, guys, amino acid which is glycine. Glycine has a very simple structure, right? It has a one CWH group, it has one NH2 group, one hydrogen, one more hydrogen. So it has no side chain. So it's a very small molecule which can easily fit into the triple helical structure of the collagen molecule, right? So basically it helps in the folding of collagen into a triple helix, which gives it the strength, right? And it also gives us the what you can say flexibility. There is also a PYQ like this: which amino acid is linked with the flexibility of proteins? So answer is glycine, and we have 30% glycine in the collagen, right? So suppose now if the flexibility is lost because glycine is replaced by some other amino acid, तो क्या होगा? They will be, the bones become brittle instead of flexible. Collagen becomes brittle and breaks easily. Got it, guys? So that is why this is the answer, the best answer here. Next question. 35-year-old man present with a recurrent blistering of the skin on sun-exposed areas. So as soon as you see this line, this is a case, probably a case of porphyria, right? So he reports dark urine and occasional abdominal pain. Laboratory test investigation confirms the diagnosis of CEP, congenital erythropoietic porphyria, guys, which is caused by deficiency of uroporphyrinogen 3 synthase, right? Okay. So guys, this is like, a question where we have to memorize the name of disease and name of enzyme. Just for the first case, it is acute intermittent porphyria. Second is congenital erythropoietic porphyria. ALA dehydratase is inhibited by lead poisoning most commonly. Also, ferrochelatase is inhibited by the lead poisoning, recent MCQ. Coproporphyrinogen oxidase is also inhibited by the lead poisoning, and deficiency of this causes hereditary coproporphyria. Right, so lead poisoning inhibits 3 enzymes, and I told you all the 3. You must know that. And hereditary coproporphyria is a mixed type of porphyria where there is, again, the features of sun sensitivity, and there is also the features of abdominal pain. Fine, but already we have been given with the diagnosis, so we have to just identify the name of enzyme. Okay, so uroporphyrinogen 3 synthase is the answer here. Guys, uroporphyrins, what they do when they accumulate, because it is what happens when they accumulate, they causes the sun sensitivity. Okay, they will convert into UP1 actually, when the 3 is not synthesized, it will convert into UP1, uroporphyrinogen type 1. Patient is suspected to have a genetic disorder involving single nucleotide substitution. So which technique would be most important in identifying such mutations? So guys, point mutations it is, right? Single nucleotide mutation means a point mutation. Suppose this is a gene, let's just for example, with a sequence of A, C, G, A, right, let's say. And now guys, because there is a point mutation, this A is still there, but C becomes, let's say, G. Okay, so A, C, G, A. So A double G, A it is now. So guys, this is a single nucleotide point mutation. This is one strand, this is second strand. This is not one DNA, okay? This is not the one DNA. Got it, guys? So that is PCR with DNA sequencing is the best answer here. Right, guys? Okay. Which antibiotic interferes with the translation by binding to 50S subunit and inhibiting peptidyl transferase? See guys, they are asking antibiotic. If I talk about eukaryotes, peptidyl transferase activity is inhibited by various, molecules. Like one of them is ricin. Castor oil, castor seed contains ricin. Ricin inhibits the peptidyl transferase activity, basically. Okay. Now the question is on antibiotic, and it is peptidyl transferase. So answer is chloramphenicol. Right? Chloramphenicol is the answer of choice here. Okay. Which enzyme is responsible for conversion of oxaloacetate to PEP? So guys, the answer is not the pyruvate carboxylase, because pyruvate carboxylase converts pyruvate to oxaloacetate. And then oxaloacetate is acted upon by PEP-CK to make the PEP. Okay, so this is our question, and the answer is PEP-CK. That is option number C. Fine. So guys, sometimes you will get the questions like, which of the following enzyme is part of gluconeogenesis? Which makes the liver gluconeogenic organ. So we have to answer those enzymes which are only used in gluconeogenesis, not in glycolysis. Otherwise, most of the steps are just reversal of glycolysis. So pyruvate carboxylase, PEP-CK, fructose 1,6-bisphosphatase and glucose 6-phosphatase. Only 4 enzymes we have which are not part of the glycolysis but part of gluconeogenesis. Okay, so gluconeogenesis, these are the 4 enzymes that we have to remember. What is the rate limiting? We will go with this pyruvate carboxylase enzyme as the rate limiting. And if it is not given an option, then go with fructose 1,6-bisphosphatase as the rate limiting step of gluconeogenesis. Am I clear, guys? Okay, so see you. Keep revising. All the best.
Hello and welcome to the CBoT session of orthopedics. Hope you have enjoyed the session. The orthopedic questions were as clinical as the expectations are that you should be knowing about. Right, starting with the first question. 24-year-old man injured left shoulder while playing rugby. Now he is experiencing pain in the left shoulder, inability to move the arm. Radiograph of the shoulder was done. The image given below, what lesion does it depict? Injury to the left shoulder which has resulted or might have resulted in the dislocation.
but now he is experiencing pain with inability to move the arm. Although there is no that much limitation of the movement, but you know, there is an apprehension that whenever you try to move the arm into abduction and external rotation with slight amount of extension, then there is always an apprehension that the patient feels. The patient feels instability, and this impingement which is happening at the head of the humerus, as you can see, there is an impingement in the head of the humerus on the lateral aspect and on the posterior aspect. That means posterolateral impingement is a feature which is suggestive of Hill-Sachs lesion. So it is Hill-Sachs lesion, right? And this Hill-Sachs lesion is because of recurrent anterior dislocation of the shoulder, because of the impingement of the anterior rim of the glenoid on the posterolateral surface head of the humerus, resulting in this depression created on the posterolateral surface known by the name of Hill-Sachs lesion. So answer for that question is D, that is Hill-Sachs lesion. Just on the basis of the x-rays you can identify this abnormality, and actually it is not, majority of the time it is not a result of an acute traumatic event. It is a result of recurrent anterior dislocation of the shoulder. You see, majority of the time it is the result of recurrent anterior dislocation of the shoulder, right? Majority of the times. Coming on to the next question, that when a student was asked about dequervantinosynovitis during a college viva, the examiner included the following option as the classical components of the disease. Which of the following? I mean, they are asking what are the names of the tendons which are impinged in dequervantinosynovitis. Simple. Now, what is dequervantinosynovitis? You know, in the extensor retinaculum, there are 6 compartments. Now, the 2 tendons which are passing through the first compartment of the extensor retinaculum, which are abductor pollicis longus and extensor pollicis brevis, are compressed. As a result of which, the movement of the thumb, that is abduction and extension, is painful. And when you try to move the fist, when you try to make a fist and deviate it ulnarly, means with the forced ulnar deviation, then there is further reduction in the space through which these 2 tendons are passing. That means there will be further compromise in the space, as a result of which the condition will be extremely painful. That condition, that test is known by the name of Finkelstein test, and the name of 2 tendons are abductor pollicis longus and extensor pollicis brevis. So option B is the correct answer for this particular question, not the option 1, right? It is abductor pollicis longus and extensor pollicis brevis. B is the correct answer. Everything you should be knowing about dequervantinosynovitis. Simple. Now, what would be the management for the condition? First of all, identify the condition. Where there is a fracture, the fracture is there in the radius. The fracture is there in the shaft of the radius in the distal 1/3. Then another abnormality is that there is a dislocation of the wrist also. That means distal radio-ulnar joint is dislocated. So when you combine both of them, fracture of the distal radius with distal radio-ulnar joint dislocation, then answer for that question is Galeazzi fracture dislocation. So what you are visualizing over here is the Galeazzi fracture dislocation. And how will you manage this condition? Simple. What you will do is reduce the fracture and fix it with the compression plate. So internal fixation with compression plating is the answer for this question. That you reduce the fracture, you fix it. The moment you have fixed it, the distal radio-ulnar joint will fall back to its normal position spontaneously, all by itself. ठीक है, अल्ना को वापस लगाने की जरूरत नहीं है. It will fall back to its normal position all by itself. So internal fixation and compression plating is the answer for this question. Obviously, external fixation is not the answer. Closed reduction, you know, closed reduction, because the nature of the injury is unstable. So even if you reduce it, there is always a possibility of redislocation. And cast immobilization, again the same. This is of no use. It will result in complications. In future, there are going to be complications. Open reduction, internal fixation is the only method of management for this type of condition. All right. Now, next question is, after falling into a sewage, a 38-year-old presented to emergency with the fractured right tibia. Now, it was possible to feel the distal pulses. That means distal vascular status was not compromised. The photograph is as follows. In terms of Gustello-Anderson system of classification, which is used in order to classify the open fractures, what is the form of the fracture? Now, in this condition or in this type of injuries, what we have to importantly remember is that Gustilo-Anderson has divided the fractures into 3 different types: the type 1, the type 2 and type 3. Now, type 1 is when the open wound is less than 1 centimeter. So, here the open wound is extensive, so it is not type 1. Now, in type 2, although the size of the wound doesn't matter, that means it could be more than 1 centimeter, but the soft tissues are normal, the periosteum is normal, it is less contaminated, the bone is not, the dry bone, the cortical surface of the bone is not exposed. So, obviously, it is not type 2. Now, in type 3, it is further divided into 3 different types: the type 3A, the type 3B and type 3C. Now, in type 3C, there has to be an arterial involvement. Now, in this case, it is specifically mentioned that arteries were palpable, the distal pulses were palpable. That means there is no involvement of arteries. So, it is not type 3C. Now, in the type 3A, there has to be a extensive wound, extensively contaminated, but the periosteum is intact, soft tissue is intact. And here, as you can very clearly see, that there is extensive damage to the soft tissues and bone is broken into multiple pieces. So, it is not type 3A also. So, the only option that remains is type 3B. Whenever you see this kind of a picture where there is extensive damage to the bone, extensive damage to the soft tissues, the bones are exposed, there is damage to the periosteum, the soft tissue closure is not visible, right? Extensive exposure of the wound also. Majority of the time it is type 3B injuries, right? So, answer for that question is type 3B. So, this is how you have excluded the other options out for this particular question. Alright. Next question is, a 24-year-old male was taken into a casualty after being involved in a car accident. ठीक है, 24 साल का आदमी है, कार एक्सीडेंट हो गया. Now, after the assessment, it was revealed that the right leg is adducted, internally rotated and shortened. Now, that means they are asking about a history around the hip joint, where there is shortening of the limb, there is adduction and internal rotation of the thigh. Now, the pulsation of the femoral artery is not felt. What is the most likely diagnosis? Now, as you can very clearly see, it is asking about posterior dislocation of the hip joint. Simple. The posterior dislocation of the hip. Now, you can say, why is it not fracture shaft of the femur? In fracture shaft of the femur, the limb is externally rotated, right? It is kept in external rotation because the distal limb is kept in external rotation, right? And here it is internally rotated. Second thing is that in fracture shaft of femur, the proximal aspect is adducted, but the distal aspect is abducted. So, although the femoral pulses were not feeble, it does not mean that there has to be a vascular injury in the femoral vascular system. It is not feeble, might be because of the arterial injury. It is not feeble, it is not palpable because the bone over which it is palpable, that is head of the femur or the joint of the hip joint, is dislocated posteriorly. So, you cannot palpate the artery over the hard surface because that hard surface is no more there in position. So, the best answer for this particular question is posterior dislocation of the hip joint. So, hope you have enjoyed the test. Hope you are feeling confident in answering all the questions related to that particular test. Thank you very much for attending the session. All the best for your future.
Hello friends, yes, we will solve secondary question. You can comment and ask any question. I am live. Okay friends, first question, please give your answer. This is a typical feature of opioid withdrawal. Okay. Yes, a 48-year-old man presents with symptom of yawning, rhinorrhea, lacrimation, sweating. All secretions are increased. In opioid withdrawal, heroin, most common opioid used is heroin. Heroin is white in color. Question has been asked, heroin is white in color, and you know all heroin, it may be South Indian also, white in color. Okay, question was asked that which substance cannot be used to adulterate heroin, and the answer was charcoal powder. Charcoal powder is black and heroin is white. Okay, so opioid is very addictive, and you know withdrawal symptoms are so severe that patient can't tolerate these symptoms. Okay, typical symptoms: all secretions are increased, means lacrimation, rhinorrhea, sweating, GI secretion increase, diarrhea. GI secretion increase, diarrhea. Yawning is quite specific. Piloerection, goosebump, mydriasis. Yes, you know opioid intoxication, there is pinpoint pupil. When opioid withdrawal, mydriasis would be there. Severe body ache, insomnia would be there. It is sometimes called flu-like syndrome, and these are so severe. This is the reason that patient try to take it, do some crime. This is the reason in government setup we provide methadone free of cost for harm reduction strategy, because we know that if patient will not get these drug and patient is not treated, this patient may do snatching. That's why for the social welfare, social protection, we provide methadone free of cost for the treatment. Okay. Yes, so these are typical feature of mydriasis, increased blood pressure. Yes, patient is not taking medication for last 4 days. That is typical opioid withdrawal. Alcohol withdrawal, you all know, questions are asked. Most common feature is tremors. Earliest is tremor. Yes, generalized tonic-clonic seizure, 12 to 24 hours. This is recent change in synopsis. Previously, we used to say that in alcohol withdrawal, generalized tonic-clonic seizure, mnemonic was also there, appear on second day. Second day means 24 to 48 hours. But now in the latest edition of synopsis, they have mentioned 12 to 24 hours. And very serious side effect of alcohol withdrawal is delirium, tremors, and in this treatment is IV lorazepam plus IV thiamine, then IV dextrose. IV thiamine, then IV dextrose. This is frequently asked question that dextrose carbohydrate should be given after administration of thiamine. Okay, cannabis withdrawal, mild irritabilities are there. So in this question, no need to worry, simple question, simple answer. Answer is heroin withdrawal. Now, next question. Yes, please do reply. A 29-year-old male patient came to your OPD with complaints of being excessively happy. Yes, happiness is there. Decreased need of sleep. These are symptoms such of mania, hypomania for past 2 years. Duration is important. 2 years. Okay. The patient wife reports that her husband frequently complained of feeling hopelessness, depressed and low mood during these episodes. These episodes, yes, means depressive symptoms are there, which typically alternate. Means patient is having depressive symptom, manic symptom, hypomanic symptom, but they don't fulfill the criteria of depression, mania or hypomania. That is called cyclothymia. That is called cyclothymia. Yes, Ashish, answer is C, cyclothymia. So dysthymia, you all know that depressive symptoms are there, but they don't fulfill the criteria of depression, and duration criteria is 2 years. So in this question, answer is cyclothymia. Major depressive disorder can't be answered because depression criteria not fulfilled. Adjustment disorder, no stressor, no subjective stressor is there. Okay, so answer would be cyclothymic disorder. Okay. Yes. Now, next question. A 9-year-old youngster who interrupts other people when they are speaking, can't wait for their turn. his turn while playing the game. Additionally, his teacher is upset with him because he talks too much, does not pay attention in the class. Yes, attention deficit hyperactivity disorder. Attention is deficit in attention. Yes, don't pay attention. Hyperactivity is there, talk much, disturb other student, these types of symptoms are there. Impulsivity is there, means they don't wait for their turn. This is typical example of ADHD. Age criteria of ADHD has been increased up to 12 years and these symptoms should be present in two settings. Okay. So in this they have not mentioned about the settings, about the age is 9 years, so definitely diagnostic criteria is fulfilled and patient is having ADHD symptom and the drug of choice of ADHD is methylphenidate, drug of choice, stimulant drug. When patient is already hyperactive, why are you giving stimulant? We found that in these patient, small area of brain is hypoactive. To compensate that hypoactive area, the other area of brain becomes hyperactive. What we do when we give stimulant, this hypoactive area becomes activated and this compensatory hyperactivity decreases. That's why, yes, we give stimulant drug and this is drug of choice. But in few condition not given the question, in this question answer is methylphenidate. Yes, sometimes they will give the patient is already having seizure. If seizure is there, definitely you will not give stimulant drug. So in that case, ADHD plus seizure, the drug of choice would become atomoxetine, non-stimulant drug of choice. If a patient is having family history of substance use, you know stimulants are addictive, having addictive potential. So you will not give stimulant drug to the patient who is having family history of substance use, you know, substance history runs in family. So in that case, yes, you will prefer atomoxetine. So in this question answer is A. Now, yes, atomoxetine is non-stimulant drug of choice, dear. But if one to choose which is best, stimulant drug of choice, stimulant is drug of choice, methylphenidate. We do prescribe atomoxetine in those cases where we found that there is some contraindication. If one to choose, we will prefer, yes, methylphenidate. Okay, dear. I gave you two scenario on which question has been asked in which we prefer atomoxetine, or in the same question if they mention what is the drug non-stimulant drug of choice, then you will mark the answer atomoxetine. Okay. Question number 4. Yes, a 24-year-old arrives at OPD after experiencing, yes, this is very important question, 4 days of less sleep and talkativeness. In addition, he complains of his distractibility, irritability with minimal socio-occupational dysfunction. The symptoms are related to mania or hypomania. Yes, you know, symptoms of mania and hypomania are quite similar. How you differentiate? The first criteria to differentiate mania and hypomania is socio-occupational dysfunction. Usually we remember the duration. Yes, in this 4 days is there. Definitely 4 days diagnostic criteria for hypomania. Hypo, 4 letters. Okay, hypomania. But more important is minimal socio-occupational dysfunction. Means if manic or hypomanic symptoms are there and socio-occupational dysfunction is present, diagnosis is mania. If socio-occupational dysfunction is absent or minimal, okay, then answer would be hypomania. So in this, socio-occupational dysfunction is minimal. Yes, so answer would be hypomania. Before going to next question, you must have an idea, recently asked question, other points which suggest mania. If psychotic symptoms are there, if all these symptoms are there and they mention that there is delusion, hallucination, without second thought, answer would be mania. If hospitalization is there, means symptoms are so severe that you had to hospitalize the patient, means he would not be able to go to occupation. So occupational dysfunction means he is so violent, he is not behaving appropriately in society. That's why we admit the patient. So if hospitalization is there, definitely it is mania. If and in hypomania we found psychotic symptoms are not there, hospitalization is not there. Okay, so these are more important than duration. These are more important than duration. Now I come to duration: 7 days, 4 days. Okay, means if a patient came to me having symptoms of mania, hypomania, yes, what are the symptoms? Suppose a patient entered the OPD, shake your hand, hello doctor, how are you? Means over familiarity. He is roaming in the OPD, yes, overactivity. He is looking at, where are you sitting doctor? Such a bad place, I will make a new hospital for you. Means delusion of grandiosity, increased self-esteem, over-talkativeness, overactivity, over-familiarity. These symptoms are there. Yes, these may suggest manic symptom. These may suggest manic symptom. And if socio-occupational dysfunction is there, mania. If delusion, hallucination is there, mania. If you had to hospitalize, mania. If duration of symptoms 7 days, mania. But if these symptoms are so severe, we admit the patient after 2 days, we will not wait for the 7 days. We will immediately mark the diagnosis. Mania means duration is not important. Point it out. Okay. Flight of idea present in mania, absent in hypomania, or better to say prolixity. Prolixity. Yes, in hypomania, prolixity, milder form of flight of idea. This question was asked in NEET. They gave us more or less same symptoms, and they did not mention this socio-occupational dysfunction. They mentioned pseudo hallucination. Pseudo hallucination were present. If pseudo hallucination are present, diagnosis is mania. Yes, pseudo hallucinations are commonly seen in mania, and hypomania, pseudo hallucination are usually absent. Now, the last question. Yes, before moving to this, solving this last question, yes, this is very, very important. Delusion, hallucination, formal thought disorder. These are core symptoms. Yes, disorganized behavior, negative symptoms. Out of these 5 symptoms, 2 or more than 2 symptoms, 2 or more than 2 symptoms for more than or equal to 6 months, then diagnosis is schizophrenia. Out of these 2 symptoms, 1 symptom should be either delusion, hallucination, or formal thought disorder. 1 symptom should be this. So total 2, 1 out of these 3 for more than 6 months, diagnosis is schizophrenia. If the same symptom, 2 or more than 2 symptom for 1 month to 6 months, 1 month to 6 months, then diagnosis is schizophreniform disorder. Schizophreniform disorder. If out of these 1 or more than 1 symptom for 1 day to 1 month, then it is brief psychotic disorder. Brief psychotic disorder. So this is DSM-5 criteria. Now we look at the question. Patient is, yes, middle-aged guy came to psychiatric OPD with complaint that he has been experiencing clinical symptoms such as chatting to himself, hearing 2 people talk about him, means hallucinations are there. Reduced affect is seen in schizophrenia or psychotic symptom disorder. Delusion of persecution plus delusion is there for more than 6 months. For more than 6 months, diagnosis is schizophrenia. If in the same question they gave for 3 months, then the diagnosis would become schizophreniform disorder. Okay. In this schizoid personality disorder, yes, schizoid personality disorder is definitely different. In this, patient prefers solitary activity. Mnemonic for schizoid is shy. They prefer solitary activity. They are indifferent to criticism or praise. They are emotionally cold. They are detached. So these symptoms are not there in this question, so can't be answered. Schizoaffective disorder, in this schizophrenic symptom and affective disorder should be present during the most of the illness. So in this, yes, only schizophrenic symptoms are there, no depressive symptom or no manic symptom. So schizoaffective disorder is not there. So answer is schizophrenia. Okay, thank you friends for patience listening. Best wishes for your exam, and continue your study with the firm belief that if you have really worked hard, you will clear this exam with good rank. So self-belief is very, very important. Belief system in psychiatry is very important. So trust on your hard work. So every time I usually say to my students that always trust on your hard work. Don't be afraid of so many news and fluctuations and that I could not study for 10 days, 5 days, doesn't matter. Just remember that if you are studying since morning to evening with positive attitude, you will get a very good rank. So best wishes again. Thank you. Okay, one question. Yes, according to ICD-11, yes, very good question, Amrit. Yes, ICD-11, if more than 1 month, then it is schizophrenia. Yes. So it is very difficult to say that which classification should be followed. But a simple technique to follow the classification, yes, in any question, if schizophreniform word is given, means they are talking about DSM. Schizophreniform word has not been used in DSM, not been used in ICD. So in this question, we will follow DSM because schizophreniform word is given. Okay. Sometimes in the same way you will find the option brief psychotic disorder. In that case also you will think of DSM-5 because schizophreniform word, brief psychotic disorder word are being used in DSM-5, while in ICD-11 more than 1 month schizophrenia, less than 1 month ATPD. So the only if they don't give that we have to follow the ICD or DSM, yes, you will rely on the options they have given. If they have given ATPD, means they are in the option, means they are talking about ICD. If they are giving brief psychotic disorder, means they are following DSM. Okay, thank you.
Alright, hi guys, I hope all of you guys have appeared for computer based offline test, and we are here to discuss some of the questions that was asked. Most of the questions were on the easier side, some questions were a little tricky or on the newer side. Let's see what are the areas that you could have avoided while solving an MCQ, while marking the answer of an MCQ. So as I told you in previous discussion as well, that we are going to quickly understand what is the answer and reason behind the answer, because the detailed discussion has already been given in printed form to all of you guys. In pharmacology, we had a very first question about antibiotic medication is given to volunteer in phase 1 clinical trial in several doses over a week in order to find the ideal dosage that minimizes the toxicity while keeping the blood concentration above the minimal inhibitory concentration. Okay, so you are keeping the plasma concentration above MIC. Okay, so for example, this is the minimal inhibitory concentration, and you are trying to keep the plasma concentration above MIC. Researchers discovered that there appears to be variation in the medication half-life among the subject. So different subject is having different half-life. Which of the following parameter, if increased, you are trying to bring a drug in the market, it's in the phase 1, okay? Which of the following parameter, if increased, further extend the drug's half-life? Okay, so this was again a very easy peasy question. Even if you do not want to read the above 4 or 5 line, doesn't matter, just read about this one last line and your answer is already going to be there, that which of the following parameter, if increased, further increases the half-life. Now always acknowledge, remember guys, that I used to tell you that half-life, what is the definition of half-life? That is time required to bring the plasma concentration to half of the previous plasma concentration. T half life that we have, इसका formula क्या होता है? 0.693, the constant value, and it is directly proportional to volume of distribution. Higher the volume distribution, higher will be the half life, and inversely proportional to clearance. You see, if the volume distribution is high, that means the drug is mainly in the tissues or mainly in some other body compartment. So slowly and slowly from that body compartment, the drug will be metabolized and they will be coming to the circulation, and ultimately the T half-life is going to increase. So if the volume distribution is high, T half-life is going to high. So if you know this formula, you can easily have the answer of this one, that which parameter if increase, the T half-life will increase. That is going to be volume of distribution. Now let's read and rule out other option as well. Oral bioavailability. What is bioavailability, guys? Amount of drug reaching the systemic circulation after the first pass metabolism, that is bioavailability. If you are going to see, if you are going to give a drug, let's say orally, the drug will be coming to the systemic circulation, and before it comes to the systemic circulation, it will passes through the first pass hepatic metabolism in the liver. Now if a drug is given orally, they will via portal circulation, this is the portal vein, via portal circulation the drug will reach to the liver, and after reaching to the liver they will undergo first pass metabolism, and amount of drug that is reaching the systemic circulation after first pass hepatic metabolism is bioavailability. This is the basic concept. Now let's read option B, oral bioavailability. If the bioavailability will increase, will it affect the half-life? The answer is no. Bioavailability if increase, if there is increase in the bioavailability, or if there is a decrease in the first pass metabolism, they can actually increase the plasma concentration. They can increase the plasma concentration. कितना ऊपर जा रहा है, minimum inhibitory concentration कितना ऊपर जा रहा है, that it can decide. It can go further up, but it will not be deciding the half-life. Remember that. GFR, glomerular filtration rate, higher the GFR, that means the drug is going to be excreted mainly. Peak serum drug level, will be deciding the plasma concentration. It is not going to decide the T half-life. It can decide the Cmax, but it will never be deciding the half-life of the drug. Half-life is going to be decided by directly proportional to volume distribution and inversely proportional to the clearance. I hope it is making sense to all of you guys. Let's see the next one. A new antiviral drug has been developed for the treatment of HIV infection. During the initial testing, it had a high rate of treatment failure, okay, due to continued viral proliferation in the brain. But when an adjuvant drug was combined, okay, so there is a drug X, when it is given alone, it is having high treatment failure. But what they are telling, but when an adjuvant drug was combined, the success rate of the drug improved. So that's good, है So they are saying that drug X is having less response, है there is going to be treatment failure. Okay, next that is saying along with drug X, they are adding the new compound, the new compound. Now they are telling the treatment is getting good response, we are having good response, the desired response, right? I think that's समझ में आ रहा है. Now let's read the question further. The biochemical study showed that the addition of adjuvant drug did not change the serum concentration of the antiviral drug. Okay, so for example, if you're going to see drug X alone and the plasma concentration is going to be, let us say the plasma concentration, example I'm telling you, let's say the plasma concentration is 1 is just a number, or let's say plasma concentration is 100, then the plasma concentration is 100 in both the scenario. 100 is just taking as an assumption. You can take 1, 2, 3, 5. That means plasma concentration is unchanged. कहने का मतलब ये plasma concentration is unchanged even after adding the newer compound. Okay, the biochemical study showed that the addition of adjuvant drug did not change the serum concentration of the antiviral but drastically reduced the viral load, है ना. तो viral load तो कम हो रहा है in cerebrospinal fluid at 1 month of the treatment, and copies were negligible in the CSF after 6 months. Okay, so look at the question, very beautifully framed question, that when it is given alone there is treatment failure, although the plasma concentration is going to be same in both the scenario. But after 6 months, when they have added, after 6 months, the new drug added, after 6 months, the viral load is negligible, है ना. Viral load is markedly reduced. That means ये जो drug alone हम दे रहे थे, तो कुछ तो ऐसा हो रहा था कि drug alone काम नहीं कर रहा था. Although when we have added the new drug is not increasing any plasma concentration of the drug. Try to understand, they are not actually increasing the antiviral load का, है ना, load. Antiviral drug का load नहीं बढ़ा रहे थे. By which mechanism is the adjuvant drug is able to improve the viral control? So you see, usually what we see, whenever we give one drug alone and it's not responding, we add a new drug, and when we add the new drug, the overall plasma concentration of the antiviral drug will increase. But here we are not, they have not increased. So that means the new drug has simply boosted the effect of the other one, and so it is having boosting effect or blocking the first pass metabolism. You see, what is first pass metabolism? The one that is happening in the liver, the one that I showed you here, the one that is happening in the liver is first pass metabolism. If the first pass metabolism is blocked, or if the first pass metabolism is inhibited, the plasma concentration will be low. Plasma concentration will never be same. If the first pass metabolism is inhibited, first pass metabolism is blocked. That means plasma concentration will be more. है ना, फर्स्ट पास मेटाबॉलिज्म नहीं हो रहा है तो मोर एंड मोर ड्रग विल बी रीचिंग टू सिस्टमिक सर्कुलेशन, है ना, प्लाज्मा कंसंट्रेशन विल बिकम मोर. Inhibiting cellular efflux transporter. Okay, so there is a drug. This is the cell that we have, let us say, and whenever we are going to give the drug alone, sometime on the cell membrane here we are having some efflux, है ना, जैसे for example P glycoprotein, they are the efflux pump. So sometime when we give this drug alone, they might pump it out immediately, they will throw it out immediately, they will not allow the drug to stay here. I mean intracellular load होने बढ़ने नहीं देगा, concentration बढ़ने नहीं देगा, they will stay outside, है ना, they will not go inside the cell. Okay, so inhibiting cellular efflux can be possibility. Let's see other option. Decreasing cytochrome P450 metabolism. What is cytochrome P450? It is the microsomal enzyme that is present in the liver. Cytochrome P450 metabolism अगर decrease हो जाए, if you inhibit the microsomal cytochrome P450 metabolism, that means the drug inactivation will be low, and this condition will also increase the plasma concentration. If the metabolism of the drug will be slowed down, अगर new drug क्या किया, metabolism को कम कर दिया, that means the drug, new drug का देने की वजह से प्लाज्मा कंसंट्रेशन तो बढ़ जाना चाहिए, बिकॉज मेटाबॉलिज्म को वो इनहिबिट करता, तो इट इज नॉट डिक्रीजिंग मेटाबॉलिज्म, इट इज नॉट डिक्रीजिंग मेटाबॉलिज्म. Diminishing blood flow to the choroid plexus. If they will diminish the blood flow to the choroid plexus, how will they reduce the viral load in the CSF, है ना? So this is a very dummy choice. Inhibiting the efflux pump, this could be the possible answer. Let's understand why and how. Because they are saying if they are going to give the drug alone, it is not responding. Maybe P glycoprotein is active and they are trying to pump out, they are trying to pump every drug that is given inside. So what they have given, they have given a drug in addition to this one, है ना. तो इसके साथ इन्होंने एक ड्रग ऐड कर दिया जिसको मैं रेड से शो कर रहा हूँ. सो इफ दिस रेड ड्रग इज एडेड अलोंग विद दिस वन, तो प्लाज्मा कंसंट्रेशन ऑफ द ड्रग विल रिमेन सेम, बिकॉज जो भी ड्रग था प्लाज्मा कंसंट्रेशन उसका चेंज नहीं हो रहा है. नाउ दिस रेड वन दैट इज द efflux pump or P glycoprotein pump inhibitor, they will go and they will inhibit this one, and now the drug can get accumulated inside the cell, and this drug that is getting accumulated inside the cell will actually be having antiviral response. Now it can have antiviral response. I hope it is making sense to all of you guys. So the way it is possibly working is inhibiting the cellular efflux transporter. Again, this is just a common sense wala question. 35-year-old woman who experienced bouts of severe nausea and vomiting on a recent cruise vacation has come to OPD because she is fearful that it might happen again in her upcoming trip. She is feeling fine now, not taking any medication, no significant medical and surgical history. Her physical examination is also normal, everything is fine. पहले इनको एक मान लीजिए गए थे, motion sickness हुआ होगा, sea sickness हुआ होगा, so for that she consumed some drug and ठीक हो गया, है ना, and she is afraid that it might happen again. So what medication should she be prescribed and side effect that she need counseling for? Okay, so अगर मान लीजिए ये motion sickness है, if it is going to be a case of motion sickness, I always say the drug of choice is going to be hyoscine, which is also given the name as scopolamine. It is the drug of choice. And motion sickness के लिए ये drug of choice अगर होगा तो इसका important side effect, because it's an anticholinergic drug, can lead to blurring of vision. It can lead to urine retention, blurring of vision, urine retention. It can also lead to, in addition to blurring of vision, urine retention, it can also lead to dryness of mouth. In fact, all the anticholinergic side effect will be seen. All the anticholinergic side effect will be seen. So we are having scopolamine that is associated with cough, no, and they have given third ka diya hai 2. Third ka 2 is dry mouth, yes. So they can cause dryness of mouth as well. Now let's read other option. Metoclopramide. What about metoclopramide, guys? Metoclopramide is one of the D2 blocker. And ये क्वेश्चन बार बार आ चुका है आपके नीट पीजी INI-CT FMG. Metoclopramide is a D2 blocker, and this metoclopramide being a D2 blocker, they actually crosses the blood-brain barrier, and they are going to be associated with your extrapyramidal symptom, जिसको कई बार word extrapyramidal symptom ना देके abnormal posture examiner used to give. And the management of this one, we are going to use centrally acting anticholinergic drug by the name of benzaxole, benztropine. These are the agents that can be utilized. Remember, okay? Metoclopramide 1 का दिया है for diarrhea. No, diarrhea is not something that she needs counseling for, है ना? They are the D2 blocker actually. ठीक है? Prochlorperazine, that is again antipsychotic, that can be associated with your problems like extrapyramidal symptom. 2 का दिया है 3. there is frequent urination. No, there is no such effect like frequent urination. And ondansetron, it's the drug of choice for nausea and vomiting. And char ka diya one, cough, they will not be associated with the cough. So correct answer for this one is going to be option C, that she you need to give her this drug, and you can even counsel her that in upcoming trip you might experience dryness of mouth, or these are the important side effects when you take scopolamine. Which of the following statement is incorrect about pregnancy in epileptic patient? Pregnancy in epileptic. What is the drug of choice for epilepsy in pregnancy? Drug of choice for epilepsy in pregnancy is going to be your levetiracetam, or other drug that we can utilize will be brivaracetam. They are actually SV2A inhibitor. लेवेट्रासेटाम, ब्रिवारासेटाम, they are actually what? They are SV2A inhibitor. LEVSV क्या बोलता हूँ मैं? LEVSV है ना? SV sound, LEVSV sounds like BV है ना? SV, BV, LEV है ना? So pregnancy में it's the drug of choice, and remember they are anti-epileptic drug. So we are always supposed to add the supplement of folic acid with them. Folic acid का supplementation will always be added with them. And apart from that, other alternative drug that we are having earlier, we also consider this as a safe. This is also safe. See, no drug is 100% safe in pregnancy. They all have some or the other risk of epilepsy, but if you are going to see drugs like valproate that is causing spina bifida compared to levetiracetam, that is having much lesser risk. So which of the following is incorrect? No anti-epileptic drug is safe in pregnancy. Yes, no anti-epileptic drug is 100% safe. पूरी तरह से कोई नहीं है. Folate supplementation is must, yes, to decrease the neural tube defect wala risk. Immediately stop anti-epileptic once pregnancy is detected. No, never ever stop anti-epileptic drug, है ना? So let us say anti-epileptic agent has to be continued at stabilized doses. Yes. So let's say if there is a patient on AED मतलब anti-epileptic drug, patient on AED मतलब anti-epileptic drug, and she actually conceived and presenting with the urine pregnancy test positive. कंसीव कर लिया, यूपीटी पॉजिटिव आ गया, तो what is the advice that you are going to give to this patient? What is the advice that you are going to give to this patient? Continue the same, never stop the drug, because stopping the drug can be more problematic compared to the epilepsy itself. Continue the same and keep monitoring the pregnancy. आप प्रेगनेंसी के ग्रोथ को मॉनिटर करते रहिए. However, a patient on anti-epileptic drug and she is coming to you seeking advice to conceive. Doctor, I am on this anti-epileptic drug and I'm afraid that this drug might create some teratogenic effect to my baby, upcoming baby. I want to conceive. Please give me some advice. So what is the advice that you are going to give to this one? That you are supposed to slowly shift to safer anti-epileptic drug. Safer anti-epileptic, AED मतलब anti-epileptic. जो ड्रग ले रहे थे उसको टेपर करके बंद कर दीजिए और दूसरे को इंट्रोड्यूस करिए. शिफ्ट टू सेफर एंटी एपिलेप्टिक. यू आर सपोज टू स्टार्ट फोलेट और फोलिक एसिड टू दिस पेशेंट एंड स्टार्ट द कंसीविंग प्रोसेस. एटलीस्ट 3 महीने के लिए इसको देंगे. स्टार्ट द कंसीविंग आफ्टर 3 मंथ, मतलब 3 मंथ ऑफ फोलिक एसिड का डोज, 3 months of folic acid का supplementation. And what about folic acid after that? It should continue 3 months का folic acid supplementation, and after this one एक बार conceive कर लिया, so she will continue the folic acid once again. So folic acid will be continued throughout. ठीक है. So 2 तरह के पेशेंट आएंगे, एक कंसीव कर चुकी है और एक कंसीव करने के लिए आ रही है ना. सेफर विल बी लेवेट्रासेटाम. Given that never stop anti-epileptic drug. Remember, given that dapsone is used to treat fungal infection, leprosy, and immunomodulator, what is the mechanism of action? This was a very simple question. They could have simply asked what is the mechanism of action of dapsone. Dapsone हो गया है ना. They are all folic acid synthesis inhibitor. By inhibiting the folic acid synthase enzyme. So they inhibit the folic acid synthase, and remember they are the dapsone as a drug. They are the drug of choice in a patient with leprosy. They are also the drug of choice in a patient with dermatitis herpetiformis. They are also utilized in certain fungal infection, or I would say in some ENT में भी आपको पढ़ने के लिए मिलता है some condition जहाँ पे भी हम dapsone यूज कर सकते हैं ना. जैसे in a condition where there is chrysomia larva जहाँ मिलता है ना. कई बार there is in the nasal area you might find, है ना, there will be larva of Chrysomia, वहाँ पे भी हम इनको utilize कर सकते हैं, है ना. Which of the following criteria used to identify the drug that require caution in geriatric patients? So caution in geriatric patients mainly will be seen with drugs like antihistaminics, because antihistaminic will be causing sedation. Drugs like anticholinergics, because these are the drugs, you know, sedatives. These are the drugs that will be more problematic because they can cause constipation, they can cause drowsiness, blurring of vision, and that will be more problematic. So geriatric patient के लिए beer criteria, geri के लिए beer criteria, geriatric के लिए beer criteria will be utilized. Apart from that, ransom criteria कहाँ use करते हैं? We use it in acute pancreatitis, है ना. acute pancreatitis को grade करने के लिए L ascorial for ALS का diagnosis, L नाम में ही हो गया, L ascorial ALS diagnosis. McDonald मल्टीपल स्क्लेरोसिस, सो मैकडोनल्ड में मल्टीपल फूड आपको मिलते हैं, मल्टीपल काइंड ऑफ बर्गर आपको मिल जाते हैं, ऐसे याद कर लो, मैकडोनल्ड मल्टीपल स्क्लेरोसिस. L ALS के लिए, रैंसन एक्यूट पैंक्रेटाइटिस, BR जेरियाट्रिक के लिए. A patient with cancer is undergoing chemotherapy. On blood examination, the platelet count were reduced after the previous cycle of chemotherapy. Okay, so there is a case of thrombocytopenia, and to treat the thrombocytopenia, what are you going to use? So oprelvecin, they are the interleukin 11 agonist. Oprelvecin is one of the interleukin 11 agonist. They are the interleukin 11 agonist, oprelvecin. ठीक है. Other alternative agent that we can utilize will be drug like your romiplastim, L-trombopag, avatrombopag, lushutrombopag, and avatrombopag, lushutrombopag. These are all thrombopoietin receptor agonists that can be utilized. All of them are thrombopoietin receptor agonist. These are the thrombopoietin receptor agonists that can be having platelet stimulant property, or they are the thrombopoietin agonist. What are they? They are the thrombopoietin agonist. Interleukin 11 agonist will be 11 interleukin, नाम ही oprelvecin. ठीक है. E-poietin alpha, darmopoietin alpha, they can be utilized if there is a case of anemia. अगर anemia होगा तो ये यूज करेंगे. Filgrastim, they are the granulocyte stimulant. नाम में ये देखिए granulocyte को स्टिमुलेट करने वाले ड्रग हैं. So filgrastim as a compound they can be utilized if there is a case of leukopenia, chemo-induced leukopenia, or leukopenia due to some chronic condition. Amifostine is a nephroprotective drug. It's a nephroprotective drug that is often added with the, sometime it is usually added with the cisplatin. It is usually added with the cisplatin as a compound. Next question that we are having is about a 45-year-old woman with a known case of type 2 diabetes mellitus and depression is on medication that is known as metformin, paroxetine, and multivitamin. So she is taking multiple therapy, no? And she has recently been diagnosed with the cellulitis and taking antibiotic for the same. Okay, so cellulitis के लिए कोई ना कोई antibiotic she is taking. Severe, now she become agitated, delirious, and severe abdominal cramp. Okay, so antibiotic ले रही है, पहले से उसको देखिए पैरोक्सिटीन वगैरह जा रहा है, and she has taken some antibiotic, and now she is having problems like agitation, delirious, severe abdominal cramp, and diarrhea. Her vitals are temperature 39, BP is on the higher side, heart rate is also on the higher side. On physical examination, she has dilated pupil, bilateral hyperreflexia, ankle clonus, and started having seizure. Okay, so remember guys, which antibiotic is having this kind of problem? I have told you linezolid is having a drug that is having MAO inhibiting property, and they can increase the risk of serotonin syndrome. So all of them mostly are feature of your serotonin syndrome. So oftentimes this linezolid as a compound, they are actually going to be avoided. You are going to actually avoid them with linezolid as a drug is going to be avoided with, other MAO inhibitor or SSRI. MAO inhibitor or SSRI के साथ इसको नहीं देते हैं. Rest other compound like doxycycline. Doxycycline is one of the tetracycline. No, it's one of the tetracycline. They can be associated with teeth staining, bone growth abnormality, है ना, or other side effect like nausea, vomiting, but they will not be causing this serotonin syndrome. Vancomycin, it's one of the drug of choice in MRSA, and they can be associated with nephrotoxicity and ototoxicity. Nephrotoxicity Ototoxicity. Okay. Penicillin, you already know penicillin is one of the beta lactam, and they will not be having this kind of side effect. Nausea, vomiting, diarrhea, समझ में आ रहा है. A 65-year-old man is a known case of hypertension, hyperlipidemia, coronary artery disease, and disease with an acute MI 2 years ago. Is complaining of muscle pain and fatigue for the past 7 weeks, and that is not related to any activity. Okay. Physical examination shows diffuse tenderness in the proximal muscle of the upper and lower limb. Which of the following drug combination can cause? So basically they are talking about myopathy. There is myopathy. He is taking multiple drugs. Dyslipidemia के लिए drug ले रहा है ना, coronary artery disease के लिए drug ले रहा है ना, acute MI भी हुआ है, hypertension के लिए भी drug ले रहा है. Now myopathy in anti-dyslipidemic drug is going to be associated with one drug called statins, and there is one more drug that is fibrates, fenofibrate, bezafibrate. These are the fibrate that we know. They are the PPAR alpha agonist. They are the PPAR alpha agonist, and statin, they are the HMG CoA reductase inhibitor. So both of them are having similar kind of side effect. That is why इन दोनों को कभी साथ में देते भी नहीं है ना. जो myopathy है, sometime it increase from simple myopathy to life-threatening rhabdomyolysis. Life-threatening rhabdomyolysis can also be seen. So correct answer for this one is atorvastatin is a statin, and gemfibrozil is one of the PPAR alpha agonists. They are the fibrate. Gemfibrozil and ezetimibe can be given because ezetimibe is inhibiting cholesterol absorption from intestine. Niacin ezetimibe again is not going to be associated with any kind of problem. Niacin can increase the uric acid level. Niacin can cause multiple problems like maculopathy. Niacin can also be associated with the increase in the glucose level, है ना. ये सारे काम करेगा, एम्ब्लायोपिया करेगा, है ना, बट दे विल नॉट बी एसोसिएटेड विद द मायोपैथी एज अ साइड इफेक्ट ना. फ्लशिंग एपिसोड भी कर सकता है ना, प्रोराइटस कर सकता है, जनरलाइज प्रोराइटस, ये सब भी कर सकता है ना. Atorvastatin ezetimibe is a drug that can be safely given. As I told you, ezetimibe is one of the NPC1L1 inhibitor. They are inhibiting the absorption of cholesterol. And so correct answer for this one is myopathy. So atorvastatin gemfibrozil should not be given, or should be a possible cause of this one. A 30-year-old man is taking over-the-counter intranasal decongestant spray for his persistent nasal congestion and rhinorrhea. However, after a few days, he had to increase the frequency and number of sprays. So he is increasing frequency and number of sprays per nostril for adequate symptom control. On examination, his nasal terminates are pale, swollen, and clear nasal discharge. Okay. Rhinitis medicamentosa could be one of the very possible indication here. Huh? What could possible cause? What is the likely mechanism behind the increased medication use? So again, there is the drug is not responding at the same dose, so the person has to increase the dose. And what could be the possible cause of this one? उसको हम बोलते हैं क्या? What do we call that? Development of the tolerance. Development of the tolerance. So receptor become less sensitive. Sometimes receptor is internalized, है ना? Sometimes the receptor is internalized. So increased receptor internalization could be the possible cause. Decreasing receptor affinity will not be the cause of the tolerance. Depletion of receptor associated G protein, reduce parasympathetic activity. Again, they are just dummy choices. Tolerance का simple सी बात हो रही है, and increasing the receptor internalization. That means receptors are hiding, they are going inside. है ना, receptor. That is how they are not responding at the same dose. A 50-year-old woman who is on ifosfamide for the past 1 month due to her lymph node positive breast cancer presented to the emergency with frequent urination, suprapubic pain, hematuria, dysuria. See, ifosfamide के साथ अगर hematuria हो रहा है तो there is no doubt about this. This could be a case of hemorrhagic cystitis. This could be a case of hemorrhagic cystitis, and the prevention of this one we always run IV mesna. So with the drugs like your cyclophosphamide, and with the drug like your ifosfamide, this hemorrhagic cystitis is always going to be a risk. So we are going to, which of the following may have helped to avoid the current state. तो current state को avoid करने के लिए आपको IV mesna देना था. Leucovorin will be added. Leucovorin, folinic acid, they will be added with the methotrexate. Ondansetron for nausea and vomiting, किसी भी chemotherapy induced nausea and vomiting के लिए. Dexrazoxane with the doxorubicin and daunorubicin. Doxorubicin and daunorubicin mediated cardiotoxicity. Ruby induced cardiotoxicity. इसके cardiotoxicity के prevention के लिए we will be utilizing dexrazoxane, है ना, dexrazoxane. They are the iron chelator agent, remember. A middle-aged man suffering from chronic kidney failure diagnosed with sputum positive pulmonary tuberculosis. His creatinine clearance is 25 ml per minute on the lower side. All of the following drug require dose adjustment in renal failure except. So remember, these two drugs could be the potential answer to this one. But अगर मैं बात करूँ rifampicin की, तो that would be the correct one because these streptomycin and ethambutol, they are mainly excreted. They are mainly excreted by the renally. ठीक है? So they require dose adjustment. They require dose adjustment in renal failure patient. Dose adjustment in CKD patients, CKD chronic kidney disease patients, they will be requiring the dose adjustment. Isoniazid rifampicin will not be because they are mainly excreted by the hepatic route. Remember, rifampicin, it is mainly excreted, because isoniazid are having metabolism also via the non-microsomal enzyme, that is acetylation. Rifampicin metabolized in liver and excreted exclusively via biliary secretion. So again, rifampicin will be the correct, but इसमें दो आंसर हो सकते हैं, B followed by A. Next question that we are having is going to be about which antiarrhythmic drug should be given for a long-term management of the 65-year-old man patient presenting with the atrial fibrillation. Comorbidity include इसको hypertension भी है, type 2 diabetes भी है, coronary artery disease भी है, ischemic cardiomyopathy, lot of things are there, and there is 28% ejection fraction, that is also on the lesser side. So long-term usage के लिए you can utilize drug like amiodarone, that is one of the class 3 anti-arrhythmic drug. It's a potassium channel blocker, long-term anti-arrhythmic drug. अगर prolong use करना है तो इसको use करेंगे. They are also having longer T half life. Flecainide as a drug number, अगर किसी patient को cardiac comorbidity नहीं है, if there is a person, है ना, it's a class 1C anti-arrhythmic drug, है ना, utilized mainly in the patient with WPW syndrome. But इतने सारे comorbidity के साथ इसको नहीं use कर सकते हैं, long term के लिए भी अगेन नहीं use कर सकते हैं. They are mainly sodium channel blocker. Ranolazine, they are the late sodium influx inhibitor. They are mainly utilized in angina. और इस पेशेंट के लिए अगर मैं बात करूं वल्सर्टन तो एंटी एरिथमिक ड्रग है नहीं, ये तो वन ऑफ द ARB है, दैट इज फर्स्ट लाइन एंटी हाइपरटेंसिव ड्रग. इट्स फर्स्ट लाइन एंटी हाइपरटेंसिव ड्रग. ठीक है. सो करेक्ट आंसर फॉर दिस वन इज गोइंग टू बी योर B is the correct answer for a question like this, right? So with this we are done with our pharmacology question, and I think 13 questions were there and we have covered all of them, and the detailed description has already been given to all of you guys in booklet. We have just covered why a particular option is the correct answer and what is the reason behind that. I'll see you in my next class. Thank you very much.
Hello students, so now we'll discuss the radiology questions in today's CBoT. So the first question is, child with features of bowing of legs and delayed walking is presented to the OPD. Radiograph of the hand was taken and is given below. What is the diagnosis? So I think we all know by now, whenever a child is given in the question and an X-ray of the hand is given, what are we thinking about? We are thinking in lines of rickets. And if a child and the knee X-ray is given, we are thinking in the line of a scurvy. It's not a hard fast rule, but this is kind of a hack for the exams. Now in the X-ray of the hand, what do we see? We see typical features of rickets. The answer to this question is rickets. I think all of you must have gotten this question correct. So there is widening of metaphysis, there is cupping of metaphysis, there is spaying of metaphysis, and there is fraying of metaphysis. So all these are features of rickets, which is the answer to this question. So what are the features? Features of rickets on hand X-ray are: number 1, widening of metaphysis. And why do these changes happen in the first place? Because there is defective mineralization in rickets because of deficiency of vitamin D. Now second is spaying of metaphysis, cupping of metaphysis, and finally there is fraying of metaphysis. Okay. Now In comparison to rickets, what are the features of a scurvy? So scurvy will also have stunted growth, but in addition, there will be some bleeding manifestations, either in the form of bleeding gums, hemarthrosis, or even swellings in the soft tissues which result from hematoma. Another important feature for scurvy is, which might be given to you in the question, is subperiosteal hematoma. Subperiosteal hematoma. This can occur specifically in the question. It is given in the orbits. Now, what are the features of scurvy on an X-ray? So, number one is these pencil thin cortex. You see these cortices are so thinned out. These are what are features of scurvy. So, number one is pencil thin. This is scurvy we are talking about, and scurvy, whenever you are thinking, the question will give a knee X-ray. Okay, so there is pencil thin cortex. Second, there is this white line of Frankel, which is shown by these arrow, this white line of provisional calcification. That is why it appears sclerotic. So this is white line of Frankel. Then tell me, this ring epiphysis, this sclerosis around the epiphysis, what is this sign known as? This is the Wimberger's ring sign. Now another, this radiolucent zone with just beneath the metaphysis, this is the Trummer-Fields zone. So Trummer-Fields zone. And then we have one spur, this spur which is known as Pelkin spur. So these are the features of scurvy on an X-ray knee. Now, another question which might be given to you, or an X-ray which might be given to you, is that of a healing rickets or a healed rickets. That is the rickets which has undergone a medical treatment, and now the X-ray is done to see whether the healing has occurred radiologically or not. So we are talking about healed rickets. So one thing that you should keep in mind, that radiological improvement lags behind biochemical improvement. What does it mean? That biochemically the markers will get better first, and then the changes will be much more appreciated on the X-ray. Now, what are the features of healed rickets? So you see these parallel horizontal sclerotic lines in the metaphysis. Okay, so these are known as Harry's line, or also known as growth arrest lines. Okay, and these tell you that there is some provisional zone of calcification which happens, then there is some arrest, then again some calcification happens. So these are parallel transverse sclerotic metaphyseal bands. Now, these are not specific for healed rickets, and these can be found in other pathologies like lead poisoning, etc. But what will help you answer this question as healed rickets is that question will give you that there was some growth arrest in the child, short stature, deformities, and earlier diagnosis of rickets was made. The treatment was given to the child, and now this follow-up X-ray of the hand or the knee is done. So I hope this first question and associated discussion is clear to everybody. Now we'll move on to the next question. When a student was asked about nuclear medicine during a college viva, the examiner asked him which radionuclide imaging is most useful pharmaceutical agent for skeletal imaging. Now, when we are talking about nuclear medicine scans for bone imaging, I think most of you, which is the pharmaceutical agent we use, it is MDP, or methylene diphosphonate, which is taken up by osteoblasts. Okay, so answer to this question is technetium-99m linked to MDP. This MDP is specific for osteoblasts in the bone, and hence all those bones which have high turnover like metastasis take up these MDP scans. Now, multiple myeloma, remember, is negative for bone scans, because in multiple myeloma we have depositions of plasma cells and they do not take up this MDP. So multiple myeloma is negative for bone scan. This is known as bone scan. Okay, now just briefly recapitulating, what is this technetium-99m? So this forms the basis of gamma imaging. Technetium-99m, M stands for metastable, and this is the main pharmaceutical agent. This is the main radioisotope which we use for gamma imaging. Now, as the name suggests, which is the ray which is emitted by technetium-99m, it is gamma rays. Okay, and what is the half-life of technetium-99m? It is 6 hours. Okay, so some one-liners which might be asked to you in the exam. Now, just recapitulating a brief summary of various ligands which we attach to this technetium-99m for nuclear medicine scans and gamma imaging in particular. So, we have done MDP, which is used for bone scan, bone imaging. Now, technetium-99m IDA. So, IDA stands for imino diacetic acid, and this is mainly used in HIDA imaging. Now, we know HIDA scan is done for gallbladder pathologies, so acute cholecystitis. EHBA, in EHBA there is no extrahepatic bile duct. EHBA stands for extrahepatic biliary atresia. So, what will you get in HIDA scan in EHBA? After 1 hour, after even 1 hour of giving HIDA, there is no excretion of this dye into the duodenum because there is absence of bile duct. So, non-visualization of duodenum on HIDA scan is marker of EHBA, biliary atresia. Now, again in bile leaks, there will be leaking of this dye into the peritoneal cavity, which you can pick up on the HIDA scan. Now, technetium-99 sestamebe, we know one place which is very commonly used is parathyroid adenoma, and another place it is used for myocardial perfusion imaging. Now, sulfur colloid scan is used for FNH. RBC scans for occult GI bleeds, hemangioma and Muga. Gallium-67, indium-1111 integrated WBCs for acute osteomyelitis, and iodine-131 MIBG scan for pheochromocytomine neuroblastoma. And then we have octreotide, DOTA-NOC, DOTA-TAC. These are used for neuroendocrine scans and carcinoid. Okay, so this is the brief summary of the various radioisotopes and where they are used. Now, coming on to the third question, the following X-ray finding could be caused by any of the following with exception of. So, what are we seeing here? We are seeing air under diaphragm. We are seeing air under diaphragm. Okay, so basically the question is asking which all conditions will have air under diaphragm. So, number 1 will be pneumoperitoneum, correct? Pneumoperitoneum will have air under diaphragm. And second is Chilaiditi syndrome. Chilaiditi syndrome, what is Chilaiditi syndrome? Here the hepatic flexure gets interposed between the right hemidiaphragm and the right lobe of the liver. So that will also give appearance of air under diaphragm, but that is not exactly perforated hollow viscous. That is just a normal interposition of hepatic flexure beneath the right dome of the diaphragm. So among these, which all conditions will not have air under diaphragm? It is acute intestinal obstruction. This will have air fluid levels. This will have air fluid levels. What significance of air fluid levels are? When do we call such air fluid levels as significant? If they are more than 3 in number and the width of these air fluid level is more than 3 centimeter, then we label them as significant air fluid levels and a possibility of an acute intestinal obstruction is raised. Which is the investigation of choice for acute intestinal obstruction? It is CECT. It is CECT. And remember, whenever acute intestinal obstruction is suspected, we do not give oral contrast. Oral contrast is not given. Okay, because the risk of aspiration is more. Now, in post-laparoscopy, the D option, can it also have air under diaphragm? Yes, in laparoscopy, we artificially create pneumoperitoneum and air under diaphragm can be seen up to 7 days. Artificial pneumoperitoneum can be seen up to 7 days post-laparoscopy. Okay. And even post-surgery, open surgery was done for the patient. Up to 48 hours to 72 hours, normal air can be seen in the abdomen after open surgery. Okay, so this was about question number 3. Now let's move on to the fourth question. A 6-month-old infant, so it is an infant with a history of abdominal distension and impaired mental development. So there is mental retardation, abdominal distension, and on laboratory testing, the leukocyte GB1A enzyme levels were normal. Okay, it was normal. Now, this enzyme is deficient in which of the condition? It is deficient in Gaucher's disease. In Gaucher's disease, this enzyme is deficient. So, Gaucher's disease is ruled out. Okay. Now, upon inspection, child's cornea appears clouded. So, we have cloudy cornea. We have mental retardation. And we have some skeletal abnormalities. Okay. Now, what are these skeletal abnormalities? We see that these are wide shaft ribs with this narrow neck. Okay. These are known as oar-shaped ribs. And then if you look at the lateral X-ray of the spine, you see these antero-inferior beaking of the spine. This is antero-inferior beaking of spine. So all these findings point towards a mucopolysaccharidosis. And cloudy cornea with skeletal abnormalities and mental retardation is mucopolysaccharidosis type 1, which is Hurler syndrome, and this is the answer to this question. Now, let's look at other findings that we see in Hurler syndrome or type 1 mucopolysaccharidosis. So I told you about oar-shaped ribs. I told you about anterior-inferior spine beaking. Then there is this pointy proximal metaphysis. Pointy proximal metaphysis. And this spine is showing this J-shaped sella. This is your J-shaped sella. So these are the findings of type 1 mucopolysaccharidosis. So MPS type 2, 2 for T, it is Hunter. Hunter's syndrome is type 2 MPS. And then type 3 MPS is this Sanfilippo syndrome. This is type 3 MPS. Here there is no corneal clouding. Okay, so I hope this question was clear to you as well. Now coming on to the next question, given the image below, what is the most likely diagnosis for a patient who has been complaining of shortness of breath? Okay, so there is SOB, and what do we see here? We see that this in the margins of the heart, in the periphery of heart, there is this calcification. So this is calcification of the pericardium, and the answer here is calcific pericarditis. Calcific pericarditis, most common cause in India is TB. Okay, so answer to this question is calcific pericarditis. Now, how does X-ray of a TOF look? This is an X-ray of the TOF, tetralogy of Fallot, and we have this boot-shaped heart. This boot-shaped heart. Few other pointers that you should remember whenever you're marking a question answer as boot-shaped heart for TOF. Number 1, there should be pulmonary oligemia. That is, blood vessels in the lung should be less because there is pulmonary stenosis. So this should have pulmonary oligemia and no cardiomegaly. No cardiomegaly. If there is pulmonary oligemia but cardiomegaly and the child has cyanosis, mark Epstein anomaly, do not mark tetralogy of Fallot. Okay. Now, the second X-ray is that of leather water bottle appearance. Leather bottle water appearance of heart seen in pericardial effusion. And then this third X-ray is that of cardiomegaly. Cardiomegaly. When do we call cardiomegaly on X-ray? By a CT ratio. Okay, CT ratio more than 0.5 CT ratio in adults is cardiomegaly. acromegaly. And here, what do you see? You see this double density sign. You see the two hard borders can be seen. So this suggests a left atrial enlargement. Double density sign. Okay. So these were the questions in today's CBoT. I hope you got all the radiology questions correct. Thank you.
I hope, dear students, you enjoyed this session of CBoT. So the paper was simple, but the questions were lengthy. So let us try to understand them very quickly. 73-year-old female presents in ER with abdominal pain along with the right upper quadrant guarding. Fever, chills. The patient develops, you can say, these symptoms with SIRS. The ultrasound revealed gallbladder thickening, pericholecystic fluid and hyperechoic, you can say, calculus. So age is on the higher end. The patient is having, you can say, acute moderate type of cholecystitis. There is also air evident in the gallbladder. So this is emphysematous gallbladder. So the best thing is that you will go for conservative management, and along with that, students, you will plan an interval cholecystectomy for this patient. Now students, some people will say that according to Tokyo guidelines of 2018, now there is no recommendation of saving the time or the date. If you are in an advanced center, you can operate him or operate her on any day. So yes, option C is also right, emergency cholecystectomy, but B is better than C. Let us go to the next question. While walking on a treadmill, 54-year-old lady with hypertension, hypercholesterolemia, with type 2 diabetes experiences intense discomfort over the right knee and the posterior leg. So the pain started at the level of right knee and the posterior leg. Now you must be thinking it could be DVT. Let us see. Right ankle and calf are swollen. So ankle is swollen, calf is swollen. The ankle reveals significant pitting edema, patch of ecchymosis at the medial malleolus, soreness and intubation at the level of gastrocnemius. Now, this is a case where the entire scenario changes. Do you know there is something which is known as Baker's cyst or popliteal cyst, which is connected with the synovial fluid cavity, which is loaded with synovial fluid. And if it ruptures, it causes the chemical myositis, which actually has the similar presentation of pain and tenderness swelling over the calf. So the answer for this is, it is ruptured Baker's cyst. Next is 40-year-old female with history of fall from two-story building, sustained 50% of the total body surface area, you can say, burnt. Patient is intubated, sedated, mechanically ventilated. Everything is okay. Good urine output, but her output has started to fall now with difficulty to ventilate. Now, what is the reason? A burn patient with decreased GFR, with difficulty in ventilation. This is now an abdominal pathology. Now, you are citing towards abdominal compartment syndrome, where the abdominal pressure, this is a secondary type of abdominal compartment syndrome, where the abdominal pressure needs to be measured with the help of bladder pressure measurement. This is what is very important, because endotracheal intubation revealed that there is no problem in the chest, because no filtrate was observed in the chest radiograph. So this is an abdominal pathology, and therefore abdominal compartment syndrome needs to be measured with the urinary bladder pressure. 39-year-old male presents to surgical emergency with persistent pain and erection over the past 8 years. So this is a case of priapism, and this is actually what kind of priapism? Painful priapism, which is commonly seen with hematological, you can say, malignancies. This is what is very important. So if you see, there is no history of ongoing sexual stimulation, past trauma, drug medication. So this is not drug induced, papaverine induced. She's not, try to understand, his father had a stroke, his mother is suffering from hypothyroidism, vitals are normal, cardiopulmonary examination, everything is normal. But if you see, the liver and the spleen are palpable. So hepatosplenomegaly, this is now more evident, and indicative of a hematological malignancy and therefore CBC. Monospore test is for infectious mononucleosis. So this is where you go for. Serum ferritin level is not going to tell you except for the iron store, and MRI spine is not needed here because had it been there, patient's penis would have been flaccid, not a priapism would be there. Now, 55-year-old male is being followed for recent uncomplicated thyroidectomy with removal of surrounding lymph nodes. Try to understand, the neoplasm was found to be of parafollicular cell. Let us read the line. Which of the things is useful as a periodic surveillance? I will not even read the question in the middle. It's a parafollicular cell tumor. So this is a MTC, and MTC we will go for calcitonin assessment for the lifelong. So serum calcitonin is what is needed here. This is how you can crack the questions. What is the next step for management? So 58-year-old female, right mastectomy, 8-year back with radiation and chemotherapy with skin lesion on her right arm. So right-sided mastectomy with 8 years back with chemo radiation, now with the lesion. What are you thinking of? It could be angiosarcoma developing because of the lymphatic obstruction. So what is the next lesion what is the next thing? Yes, you need to go for a lesion biopsy because it could be a case of angiosarcoma. 55-year-old female underwent total thyroidectomy for retrosternal goiter. She is being evaluated in the post-surgical care unit. She complains of tightness in the neck but doesn't have any difficulty. The neck swelling is 3 cm, ballotable and expanding. So this is expanding hematoma, and this expanding hematoma, this is what is very important. It needs a surgical wound exploration. It could be a secondary hemorrhage or reactionary hemorrhage in this patient. Next, if you see this question, this is quite long. The last is catheter is sutured to the skin, a sterile dressing is applied. What action should be taken next? Let us see which catheter. Patient had high temperature, chills, abdominal discomfort, lethargicness. She is being evaluated in ER room, tachycardia, low blood pressure, pyrexia. Urine shows her urine and the right costovertebral tenderness reveals that she could be having pyelonephritis, for which she has a central venous catheter placed. So students, if you place a central venous catheter, you need to reconfirm the location and each and everything. And do you know, during placement, your stellate might have caused pleural injury resulting in hemo or pneumothorax. So this is why very important investigation for the patients who routinely undergo, you can say, a central line insertion is a routine chest, bedside routine chest assessment is done. This is a very simple question. If you see, this is a slit-like nipple retraction, and slit-like nipple retraction happens because suppose if all the ducts are involved, the ducts will shrink and they will pull the nipple inside. So this is due to invasion of lactiferous ducts. It's very, very, very simple. What is undertriage? Undertriage means you are incorrectly deteriorating the triage category. So patient will be missed because of the critical nature of the injury has been underrated. So what is undertriage? If you see in this question, a patient who was supposed to get a red tag gets a yellow due to poor assessment. This is why this is undertriage. So remember, when a patient who was supposed to get a yellow gets a red, this is overtriage. So red overtriage is also there, undertriage is also there. Next is, can you see this is ulcer over the plantar aspect? Now 60-year-old smoker with non-smoker with diabetes, with neuropathy and hypertension, with foot plantar ulcer that worsens. Dorsalis pedis is palpable bilaterally. What below is a risk factor? This is what is very, very, very important. Answer is, students, is it incompetency of the wall? No. Try to understand, there is no lower extremity edema or discoloration. It is because of the atrophy of the intrinsic muscle. This is what is very important. Diabetes will always cause atrophy, and that is why there is the ulceration here. Next is a patient with HIV, alcoholic hepatitis, alcohol use, presents to ER with intense midline chest pain with recurrent vomiting. So chest pain, recurrent vomiting, New Year party, bouts of alcohol. Patient uses cocaine, neglects medicine. All these things leave apart. Chest X-ray shows widened mediastinum and left-sided pleural effusion. So vomiting, left-sided pleural effusion, chest pain. The answer is, it is esophageal perforation. No left-sided pleural effusion, pain radiating to back. It could have been aortic dissection. So C is better answer than A. This is what is simple. Non-smoker with BPH on tamsulosin, CAD, hypertension with progressive weight loss and fatigue. Vitals are normal, but PSA is elevated. Now, this is a patient of cancer. Which of the following is the most strongly? Students, age is the very, very, very important risk factor for this. So, advanced age is the answer. Now, if you read this question, it is too long, but if you see this, so you can see a lot of, pneumoperitoneum here. A 45-year-old female presents with low-grade fever, abdominal pain and diarrhea. Middle-aged female with diarrhea, pain, abdomen. This is a classical history of irritable bowel disease. Now, her pain has dramatically increased over 48 hours, lost significant weight, history of travel is negative, the temperature is, mild, moderate pyrexia, blood pressure is 100/68, pulse is tachy, respiratory rate is 24, WBC is elevated. The next line action, you have to understand IBD with perforation. This could be an IBD with perforation, that is why you are having pneumoperitoneum. So, students, in a patient of IBD, it is the steroids, 5-aminosalicylic acid and infliximab, which is the gold standard of the management. So, start with the IV methylprednisolone, NPO. This is how you do. Along with that, the RALS tube decompression of the tract. 35-year-old male comes to emergency with penile fracture 2 hours ago. The pain is aggravated while urinating. Do RGU, retrograde ureterogram, to see whether anterior urethra is damaged or no. And that is why option B is the most important. Last question, 41-year-old lady comes to ER with right shoulder and epigastric pain. So this is actually a pathology involving this area. What is that? Very common pathology which is having a shoulder tip pain. That is a gallbladder, inflamed gallbladder. She had heavy dinners 2 hours ago earlier. And post heavy dinner, that means you are taking a high carb. So emulsification of fat is not there because bile is not released because of the stone. The patient experienced similar incident months prior, but resolved without medical. So this is a biliary colic which usually lasts for hours. Now she was taking ranitidine with a severe history of burn. Stomach is non-tender. What it could be? Fat necrosis? No. Acid hypersecretion? No. Outlet obstruction? No, because vomiting is not there. Hollow obstruction with mucosal inflammation. This is a case of acute cholecystitis. So this is all about the CBoT 6. I hope you enjoyed the lesson.
Hi friends, so we'll discuss up this particular CBoT and the microbiology questions in that. I hope you must have done very good. So without wasting any time, let's start up. The first question is, a 32-year-old man, history of sharing needles during the IV drug abuse, is found to be P24 antigen assay positive. Which the following statement is correct regarding this particular stuff? The first one is, the specific binding to the CD4 occurs by GP41. No, it's not so. Okay. The most common mode of transmission is blood transfusion. In India, it is the sexual route. TAD gene is a non-structural gene. This statement is very much correct. The TAD gene is a non-structural gene. The structural genes you need to know, GAG, INAB and POL. ये तीन होती हैं. GAG, INAB and POL. They are the structural genes. उसके अलावा सारी क्या होती हैं? Non-structural genes. जिनमें की एक क्या है? TAD gene. Western blot is a screening tool? No, it's used to be a specific test. Okay, but now it is being succeeded by HIV RNA PCR. Okay, so it's a specific test, not a screening tool. So answer to this particular thing is C. And important is that if this fellow is P24 antigen assay positive, then you have to go for certain other tests which are more specific, like Western blot or HIV RNA PCR, to confirm your diagnosis. Okay, so it is one of the first antigens to come positive in the case of these particular ones, that is the needle stick injury and all that. Fine. And the GP41, which is termed as the transmembrane protein, is also termed as the fusion protein, and the dock protein is GP120, with the help of which it attaches. Now coming to the next one, a 37-year-old researcher while working in a lab develops high fever, severe shortness of breath, chest pain, cyanosis, diaphoresis. Okay, within a few hours the patient develops septic shock and dies. Investigation shows patient's exposure to the Bacillus anthracis Which of the following statements is incorrect regarding the same? Okay. X-ray reveals hemorrhagic medistinitis and bloody pleural effusion. So this you know that in pulmonary anthrax, because they are sounding the pulmonary features of anthrax. So in this particular one, what happens is mediastinal hemorrhagic necrosis or hemorrhagic medistinitis along with a bloody pleural effusion. So this is correct. Fine. The bacteria forms spores in the body? No, it doesn't form spores in the body. Ciprofloxacin is given for 60 days? Yes. This particular drug is the drug of choice and it is to be given for 60 days time. ELISA is used for serological diagnosis. This is also correct. ELISA is used for the serological diagnosis. Otherwise, you can culture it. Culture is done where? On the PLET media. And what is PLET? Polymyxin lysozyme, EDTA and thallus acetate. Okay. So the answer is B. Bacteria form spores in the body. It is not so. Now coming to the other one, which of the following statement is true about the following picture shown below? So basically, this is Antamoeba histolytica, trophozoite, and what you're observing inside is the RBCs. So it is not found in the stool microscopy. Guys, this statement is wrong because it is being found in the stool microscopy. It is an infective form of Antamoeba histolytica. No, cyst, quadrinucleate cyst. Trophozoites with absence RBC in foot vacuoles. No, the trophozoites with ungulfed RBCs, that is pathognomic of Antamoeba histolytica infection. The spokes-like lineal network running between the nucleolus and the nuclear membrane is the characteristic point of Antamoeba histolytica trophozoite. So this is what is your answer for this particular one. Okay, and the pathognomic feature is they should have what? Ungulfed RBCs within. Now, which of the following statement is correct here? The phenol red indicator of McConkey agar changes to bright pink by lactose fermenting bacteria. So remember, it is not phenol red, it is neutral red. So this statement is wrong. Phenol red indicator of mannitol salt agar changes to yellow by sucrose fermentation of the bacteria. This is mannitol salt agar, from where the sucrose have come. So this is also wrong. The bromothiamol blue indicator of TCBS changes to yellow by the sucrose fermenting bacteria. This is what is right. Okay, BTB is there in the TCBS and it changes color from green to yellow because of what? Because of the sucrose fermentation. So this is correct statement. Answer is C here. And this is also wrong. The neutral red indicator of McConkey agar changes to yellow. No, it changes to pink because of the lactose fermentation. Now, in the fluorescent microscope, the function of fluoropore, which is being used up, is to absorb the short wavelength and emit the light of longer wavelength, which is of the visible spectrum. So answer is B. And number of fluoropores are isothiocyanate. You can use these particular oramin, rhodamin. Okay. Others are also there. That is what is termed as fluoropore. A 6-year-old girl presents with sore throat and the fever. Okay. And this particular picture itself is telling up what they are talking regarding the grayish white membrane, that is pseudomembrane of diphtheria. Examination of the oropharynx reveals the finding given in the picture. And there is a prominent cervical lymph endopathy, that is bull's neck. Which of the following statement is incorrect about the causative organism? You have to see this also, correct or incorrect. Alec gel precipitation test is used to test the toxicity of the bacteria. True, right? Okay, the colony morphology of bacteria on thyroid bread agar shows small, granular and black colonies. The antibody titer considered optimally protective for this bacteria is more than 0.01 IU per ml. The toxin production of this bacteria depends on the concentration of iron in the media. So this statement is very much correct. Okay, it should be optimal. That depends on the optimal concentration of iron. More is also like inhibitory and less is also inhibitory, both ways. The colony morphology shows small, granular and black colonies. That is also correct. Answer is incorrect, they are asking up. The answer is C. So the antibody titer considered optimally protective for this bacteria is more than 0.01 IU per ml. This statement is wrong because the amount is this one, 0.1, not 0.01, it is 0.1 IU per ml. Otherwise, if this is the titer levels which is given in the question, no protection. Okay. Which of the following is correct about the chloricea sinensis? The first of all, you should know chloricea sinensis is what? It's a trematode. It's a fluke. Okay. It causes biliary obstruction in cholangiocarcinoma. The first statement itself is correct. Egg is the stool is ellipsoidal of size. This not exactly ellipsoidal. It is having an operculated knob over it. Okay. It is also known as southeast liver fluke. No, it is termed as Chinese liver fluke or oriental liver fluke. The second intermediate host is fresh aquatic plants. No, it is fish. Okay. This particular one is fish. That is the second intermediate host. The first is snail, second is fish. A known case of HIV presents with community acquired pneumonia, cough, pleuritic chest pain, breathlessness, maculopapular lesions, migratory arthalgia. A probable diagnosis of coccidioidomycosis was made. Okay, dimorphic fungal disease, that is coccidioidomycosis. Which investigation shows the most specific finding to confirm the diagnosis? You know, guys, whether it is bacteria or fungus, the best is to go for culture. And these all, they produce pulmonary stuffs. So obviously the best specimen for them to have is sputum. And when you go for the sputum culture, you could able to find a lot of things. So, okay, so best is to go for what? Sputum culture. And you could able to find this particular stuff. And what are the various features they observed in this? So the mold form of this particular coccidioidomycosis looks like arthroconidal arrangement. Which type of arrangement? Arthroconidal arrangement. And the yeast form of it. The yeast form of this looks like a spherule, and this particular spherule is having what inside? This is having the endospores. This particular one is having what? The endospores. The spherule with endospores. The Faggot sign. Faggot sign is seen in which of the following except yellow fever, chikungunya, anthrax fever, or tularemia? Answer is chikungunya. It is not there. And what is Faggot sign first of all? The Faggot sign is relative bradycardia. And what happens in this relative bradycardia? It is being said that with 1 degree increase in temperature, this particular beats, they increase 10. Okay, but here in the Faggot sign, they increase hardly 6. So that is termed as relative bradycardia, and it is not seen in the chikungunya. Whether like this is observed in what? Yellow fever, anthrax fever, and tularemia, along with the brucellosis also. So remember, like this. Okay, Betty is having this Faggot sign. And what is there in this? B is brucellosis. Okay, E is anthrax fever. T is tularemia. And Y is yellow fever. So these are having this Faggot sign. Now coming to this, the frequent use of some drugs is leading to resistance in microorganisms. The causative organisms are becoming multi-drug resistant from the existing drugs. Which of the following is the most common method of multi-drug resistance through the plasmid? And what is plasmid? Extra chromosomal genetic material which infers a new property to the bacteria. So the frequent use of some drugs leads to resistance. The causative organism becoming multi-drug resistant from existing drugs. Which of the method is the most common to make MDR? No doubt in that, that is conjugation. Through that only, this plasmid transfers through the conjugation tube and it is given to the other one. Now coming to this, a patient presents with lesions which are centri-albicated depression. Okay, frequently asked, of size 3 mm, they appear as whitish nodules, pinkish to whitish nodules with caseous material in them on the trunk. Which pox virus is responsible for it? So answer is molluscum contagiosum. Okay, and which bodies are observed in this? Molluscum bodies. Okay, molluscum bodies are seen, which are having the other name that is termed as Henderson-Peterson bodies, also termed as HP bodies. Okay, Henderson-Peterson bodies or HP bodies, and HP bodies or Henderson-Peterson bodies, these are intracytoplasmic eosinophilic inclusion bodies. Okay, they are intracytoplasmic eosinophilic inclusion bodies, that is the HP bodies observed in them, molluscum contagiosum. And here the added point is, if they ask if these types of lesions, albicated lesions, are seen where else also, they are seen in the cryptococcosis, that is cutaneous cryptococcosis, and they are observed in the cutaneous histoplasmosis. Which of the following is true about the haptens? A small molecule that can elicit an immune response on its own? No, wrong statement. Induce an immune response by mimicking the pathogen structure? This is also a wrong statement. Type 2 hypersensitivity reactions often associated with hapten-induced immune response? Might be correct. Penicillin binding to a carrier protein is like an hapten. Okay, so this particular thing works as an hapten and then they can induce the immune response. The answer to this, better answer is D. C can also be one of the answers if D option is not there. So answer here will be, the better answer will be D. Now coming to this particular one, that is a 40-year-old female presents to the OPD with yellowish discoloration of the sclera for 1 month, easy fatigability for 1 month. After further investigation, probable diagnosis of hemolytic anemia was made. Okay, which test is primarily used to diagnose this condition? So you know guys, for the hemolytic anemias we go for Coombs test. And which Coombs test? Direct Coombs test. So this particular direct Coombs test is being used to diagnose of the hemolytic anemia. Indirect Coombs test is used for Rh incompatibility, okay, to find out the antibodies in the maternal serum, okay, whether they should go for the second child or not. That particular thing is being told up by which particular test? Indirect Coombs test. So direct Coombs test is mostly for fetal antibodies, and indirect Coombs test is mostly for maternal antibodies. And for the hemolytic anemias also, you can go for the Coombs test. Okay, so this much is there. I think they are the easy ones. If you getting up any sort of the mistakes here, you can just see up once and try to rectify that. Okay, so basically micro as such things that 13, 14 questions they come. But if you see the integration of the micro in various subjects, you will observe that number of others questions are also linked with this, because it have an integration with PSM, it have an integration with medicine, it have an integration with surgery, even patho, even pharma. So basically, in total, if you analyze up any sort of exam, the amount of micro questions they come out to be 30 to 40. Okay, so you should have the sound knowledge around the pathogens, and if you have, definitely you have an edge over the others. Okay, so thank you so much. Bye bye. Take care.
Hello, dear friends. I am Dr. Anupama Chaudhary Devgan, the Physiology faculty in Allen Next, and I am going to be discussing the physiology questions in the CBoT. So let's look at the first question. It says, a professor during Viva on sleep asked a student about the stage of sleep where K complexes and sleep spindles appear. Which of the following options is the correct answer? Now, what are the EEG waves recorded in different stages of sleep? And also, let's have a look at the sleep cycle. So remember, when you are awake, at rest, eyes are closed, and mind is wandering. That means you have closed your eyes and you are trying to go to sleep and you're not thinking of anything in particular. This is the time where the waves which are recorded are the alpha waves. Now, what is the frequency of alpha? Now, to remember the frequency of these different EEG waves, remember D tab. As you go from delta to beta, delta, theta, alpha, beta, the amplitude decreases. That means the highest amplitude wave is delta, the lowest amplitude wave is beta. But what happens to the frequency? Frequency increases. Lowest frequency wave is delta and the highest frequency wave is beta. Now, to remember the frequencies, remember your table of 4. So 4 1s are 4, 4 2s are 8, 4 3s are 12, and 4 4s should be 16, but I'm going to write 30. So 4, 8, 12, 30 to remember the frequencies. Now, delta has a frequency of less than 4 hertz. Theta has a frequency of 4 to 7 hertz. Alpha has a frequency of 8 to 12 hertz. And beta has a frequency of 13 to 30 hertz. So roughly remember 4, 8, 12, 30 and D tab. So when I speak about the alpha rhythm will have a frequency of 8 to 12 hertz. And when do you get an alpha rhythm? When you're awake, eyes are closed, mind is wandering. Now, as you go into the first stage of sleep, which is also called stage 1 of NREM, what happens to the frequency of the EEG wave? It reduces. There is a decrease in the frequency. And which is a wave which has got a lower frequency than alpha is theta. So at this time, we will be able to record a theta-like activity. Theta-like activity with a frequency which is going to be 4 to 7 hertz. Now we go into NREM stage 2. Now in NREM stage 2 is characterized by the presence of K complexes. What are K complexes? K complexes are basically biphasic waves. Biphasic waves. And you also get what are known as sleep spindles. And what are these sleep spindles? Sleep spindles are 13 to 15 hertz activity. The background activity is 4 to 7 hertz, and in between you get these sleep spindles which have a high frequency activity of 13 to 15 hertz. So these are typically seen in NREM stage 2. Then we go into NREM stage 3. And in NREM stage 3, delta rhythm begins to make an appearance. And delta, like I told you, these are very high amplitude, low frequency waves, frequency of 1 to 3 hertz, less than 4 hertz. Then we go into NREM stage 4. And now delta rhythm becomes even more prominent. After stage 4, we go back to a lighter stage of sleep. So we go back to stage 3, stage 2, and then to REM, and which is the EEG wave recorded in REM, and that is the beta rhythm. We spend about 5 to 30 minutes in REM sleep, and then we go back to stage 2, 3, 4, 3, 2, and again REM. This is known as a sleep cycle, and each sleep cycle is for approximately 90 minutes. So going back to the question, it says, in which stage of sleep am I going to get K complexes and sleep spindles? Answer becomes pretty simple. This is NREM stage 2. In stage 1, we get a theta-like activity. With a frequency of 4 to 7 hertz. Stage 3, delta makes an appearance. And in REM sleep is beta waves. So the answer to this question is B. Let's have a look at the next question. It says, a left-sided subdural hematoma develops in a 23-year-old man after a vehicular accident. Physical examination reveals papilledema 3 days after the accident. Which of the following is most likely to be seen? So papilledema would tell you that there is an increase in the intracranial pressure, and the fact that there is a subdural hematoma with papilledema will indicate increased ICP. What is going to happen to the cerebral blood flow? Cerebral blood flow will decrease. Why? Because the raised ICP will cause a compression of the cerebral blood vessels, and that will reduce the cerebral blood flow. What will happen to the cerebrospinal fluid production? A raised ICP does not directly affect the CSF production, but definitely it will reduce the CSF volume. CSF volume will definitely be reduced. Because a raised ICP means that now the CSF will start flowing into the venous sinuses, and literally the brain is going to be squeezed and the CSF will move out of the cranial cavity. So CSF fluid volume will definitely reduce. So my answer to this question is D, a raised ICP. Let's look at the next question. It says an ENT specialist through a model of the ear, was demonstrating functions of various parts of the middle ear when he immediately stopped and started asking students about the main function of the eustachian tube in the ear. Which of the following is the correct answer? Now, eustachian tube, this is a fairly easy question, we should be able to answer this, equalizes the pressure between the middle ear and the external environment. Yes, and where have we seen this so often is when you're traveling by air, and especially when you're landing. Normally what happens is that the atmospheric pressure increases, the middle ear pressure is lower, and then immediately you close your nostrils and your mouth and you blow out of the eustachian tubes into your ear to equalize the pressure. Isn't it a very common experience, especially when you're traveling by air? Or you open your mouth wide, that will also open the eustachian tube and equalize the pressure on both sides of the tympanic membrane. Amplification of sound waves is not a function of the eustachian tube. Amplification of sound waves is done by the middle ear ossicles. Control, balance, and spatial orientation is also not a function, and transmission of auditory signals, it has nothing to do with the auditory pathway. So my answer is A. Let's see the next question. Which cytokine plays a major role in promoting erythropoiesis by stimulating the formation of erythroid colonies? Now, the one which promotes erythropoiesis is erythropoietin. Most of the erythropoietin comes from the kidneys. Small amounts of erythropoietin can also come from the liver, but the major site of production of erythropoietin is kidneys. Which cells in the kidneys produce erythropoietin? Not the JG cells. JG cells are renin-secreting cells. Erythropoietin-secreting cells in the kidney are in the interstitium of the peritubular capillary bed. Now, what is the most important stimulus for the secretion of erythropoietin? A decrease in PO2, hypoxia. This increases the erythropoietin secretion. Also, alkalosis, cobalt salts, and hormones such as testosterone, androgens. They increase the erythropoietin secretion. And what is the role of erythropoietin? Erythropoietin acts on the committed stem cell stage. Committed stem cells. Erythropoietin acts on the committed stem cells and it reduces their cell death. So the committed stem cells can now multiply more number of times and it increases the red cell mass. There is increase in hematocrit, there is increase in hemoglobin. Interleukin 6 is involved in the immune process, not in erythropoiesis. Similarly, TNF is associated with the inflammatory response, not with erythropoiesis. Interleukin 3, it does have some role in the differentiation and proliferation of some blood cells, but definitely erythropoietin is a better answer, or the best answer here is erythropoietin, which has a role to play in promoting erythropoiesis. Next, which of the following is true about the tubular fluid that passes through the lumen of the early distal tubule in the region of macula densa? So let's have a look at this. Now, when I look at the nephron, the glomerular filtrate is isotonic with plasma. When I say it is isotonic with plasma, what does that mean? That means basically it has the same composition as plasma. The glomerular filtrate is an ultrafiltrate of plasma. It has similar composition as plasma, except it has no plasma proteins. So practically speaking, it has the same osmolality as plasma. Now what happens in the PCT is, there is absorption of a number of solutes and water. The relative absorption of solutes and water is the same. So what happens to fluid at the end of PCT? Continues to remain isotonic, in spite of the fact there is a lot of reabsorption in the PCT, but because the total solutes absorbed and total water absorbed is the same, the osmolality remains the same. Now, in the descending thin segment, there is absorption of water, so that fluid at the tip of loop of Henle is hypertonic. In the thick ascending limb, there is absorption of sodium, potassium, and chloride. And please remember, the absorption of these electrolytes is more than the absorption of water in the descending segment. Therefore, fluid at the end of loop of Henle is hypotonic. That is why thick ascending limb is sometimes also called the diluting segment of the nephron, which has been asked as a question. Now, so the fluid at the end of loop of Henle or beginning of DCT is hypotonic. Now, when I look at the juxtaglomerular apparatus, what does it look like? There is an afferent arteriole which breaks up into glomerular capillaries and efferent arteriole. Now, the beginning of DCT actually lies between the afferent and the efferent arteriole. You'll have to imagine this a little bit. Of course, when I drew the nephron, I sort of spread it out and I made a diagram like this. But remember, each kidney has 1 million nephrons. So nephrons are very tightly packed. And this beginning of the DCT lies between the afferent and the efferent arterioles, and the cells at the beginning of DCT are modified to form what is known as macula densa. Macula densa are the modified tubular epithelial cells at the beginning of DCT. So what is the nature or the composition of fluid at the beginning of DCT? This is hypotonic. So my answer to this question becomes, it is usually hypotonic. And why is it hypotonic? Because of a differential permeability of the two limbs of loop of Henle. The descending limb is permeable only to water, ascending limb only to solutes, and the absorption of solutes in the ascending limb is more than the absorption of water in the descending limb, which makes the fluid hypotonic at the end of loop of Henle, which is the same thing as beginning of DCT. Let's see another question. Which of the following is directly attributed to enhancing the affinity of hemoglobin for oxygen? So basically, I'm trying to ask you is, which of the following causes shift of the oxygen hemoglobin dissociation curve to the left? Because remember, FAL favors affinity, a shift of the curve to the left. Rightward shift of the curve favors delivery, dissociation. Leftward shift favors affinity or association. Increased temperature causes a right shift. Decreased pH or acidosis causes a right shift. High partial pressure of oxygen does not directly affect the oxygen hemoglobin dissociation curve. It does not cause a shift of the curve, but yes, higher the partial pressure of oxygen, more will be the saturation. But saturation cannot increase more than 100%. So high partial pressure of oxygen will not cause a shift of the curve. Low 2,3 dpg levels, this causes a left shift. Right shift will be produced by a high 2,3 bpg. 2,3 dpg or 2,3 bpg is a byproduct of the glycolytic pathway. So anything which increases glycolysis will cause an increase in 2,3 bpg and a right shift. But the question here says low 2,3 bpg, so this is going to cause a left shift of the curve. So my answer to this question is D. Now, please remember two important points. 2,3 bpg binds at which point? 2,3 bpg and oxygen both bind at the same place on the beta chain of hemoglobin. So if there is more 2,3-BPG, less binding with oxygen, less 2,3-BPG, more binding with oxygen. This is also a INI-CET question which was asked last year. Where does 2,3-BPG bind? It binds to the beta chain of the globin part of hemoglobin. Let's see the next question. Damage to the flocculonodular lobe of the cerebellum is most likely to affect which aspect of motor function? Now, basically, the question is trying to ask you what is the function of the flocculonodular lobe, which is also known as the vestibulocerebellum. The function of the flocculonodular lobe or the vestibulocerebellum is balance and eye movement. And if there is a damage to the flocculonodular lobe, this results in ataxia, nystagmus. Two very, very important signs of cerebellar disease. Because flocculonodular lobe has a role to play along with the vestibular nuclei in balance and eye movements. Motor planning and coordination, this is a function of the lateral cerebellar hemispheres, or also known as the cerebrocerebellum or the neocerebellum. Coordination is primarily a function of the spinocerebellum. Muscle tone and strength is affected by a number of areas in the cerebral cortex, including the cerebellum, but vestibulocerebellum by itself does not have a major role to play in muscle tone and strength. Let's see the next one. A 28-year-old female presents with irregular menstrual cycles and reports difficulty in conceiving. On further evaluation, hormonal profile reveals elevated levels of luteinizing hormone and FSH, elevated levels of LH as well as FSH. Ultrasound imaging demonstrates multiple small follicles in the ovaries. What is the most likely diagnosis? Elevated FSH-LH with multiple small follicles is typically seen in polycystic ovarian disease. In the polycystic ovarian disease or polycystic ovarian syndrome, there is also going to be hyperandrogenism. Androgens will be elevated. Of course, polycystic ovaries, and there are irregular menstrual cycles. The patient commonly presents with infertility. So let's see what happens in premature ovarian failure. In premature ovarian failure, there is an early cessation of the ovarian function, and there is going to be definitely elevated FSH levels. But in this case, the woman is in the reproductive age group, and irregular menstrual cycles, difficulty conceiving, pointing more towards PCOS. In hypothalamic amenorrhea, we expect that the FSH and the LH levels to be low because of a problem in the hypothalamus, which is not able to secrete sufficient GnRH, and therefore pituitary hormones will be less. In endometriosis is definitely one of the causes of infertility, but it is not associated with elevated FSH and LH levels. So my best answer here becomes polycystic ovarian syndrome. Let's look at the next question. Which of the following statements about coronary blood flow is the most accurate? A normal resting coronary blood flow is 500 ml per minute? No, it is about 4 to 5% of cardiac output. So this is about 225 to 250 ml per minute. 500 ml per minute is almost 10% of the cardiac output. Majority of the coronary flow in coronary blood vessels occurs during systole? No, it occurs during diastole. Systole, especially on the left side, will cause a compression of the coronary blood vessels. So flow occurs during diastole. During systole, the percentage decrease in subendocardial flow is greater than the percentage decrease in epicardial flow. This is true. This is a correct statement, right? Subendocardium receives lesser flow as compared to the epicardium. Adenosine decreases coronary blood flow? No, adenosine in fact increases coronary blood flow. Adenosine is a local metabolite. It is generated from the breakdown of ATP, and this causes a coronary vasodilation. Let's see the next question. Which condition is associated with overproduction of adrenal androgens? Overproduction. So let's look at the options. Now, what happens in Addison's? In Addison's, primarily, there is a mineralocorticoid deficiency. There is decreased secretion of aldosterone primarily, and there is also a decreased secretion of cortisol. Cushing's syndrome is due to excess secretion of cortisol. Conn's syndrome is primary hyperaldosteronism. Adrenal androgens are not increased here. Adrenal hyperplasia, like for instance the congenital adrenal hyperplasia, this is definitely associated with excess androgens. There is excess androgens here, which produces virilizing symptoms. So answer to this question is D. In response to a meal, which hormone is responsible for promoting the feeling of satiety? Ghrelin is orexigenic. Orexigenic increases appetite. Leptin produced by the adipose tissue definitely produces satiety. Insulin does not directly affect satiety, but we must remember that the beta cells of pancreas, they secrete insulin and amylin. The ratio is 100:1. Insulin secretion is 100 times that of amylin, and amylin definitely produces satiety, but not insulin directly. Motilin affects the GI motility, but definitely not the satiety. So the one producing satiety is leptin from adipose tissue. Let's see the next question. Which ion is primarily responsible for the depolarization phase of an action potential? This should not be a problem. This is something which is repeated again and again, and we have discussed it so many times. And the depolarization phase of an action potential is due to opening of voltage-gated sodium channels and sodium influx. So the answer to this question is A. But if the question says what is responsible for the depolarization phase of an action potential in pacemaker cells and smooth muscle cells, in these two cells, the depolarization is not because of sodium, but because of a calcium influx. So please remember, in a neuron, in a skeletal muscle, in the cardiac muscle, the depolarization is because of a sodium influx, but in pacemaker cells of the heart and in the smooth muscle, depolarization is because of calcium. Which of the following is correct about the physiological basis of events happening during one cycle of cross-bridge formation? Is troponin C involved in cross-bridge formation? No. The cross-bridge formation is between the myosin head and the active site on actin. ATP binds to the active site on actin? No. ATP binds to the myosin head. One ATP is used in each myosin actin cross-bridge cycle? Yes, this is true. 2 power strokes are performed by 1 cross bridge? No, only 1 power stroke is performed by 1 cross bridge. So answer to this question is C. But let's have a look at the actin myosin. Cross bridge cycling. Now, to understand this, please remember that when a muscle is at rest, the myosin head is in a high energy, high affinity state, right? When the muscle is at rest, the myosin head is in a high energy and high affinity state. That means it's ready to bind with actin. But it does not do so because the active site on actin is covered by tropomyosin. So as soon as calcium becomes available, calcium will bind with troponin C. There is a conformational change which causes the tropomyosin to slide. And what is going to get exposed is this active site on actin. The myosin head now binds with this active site on actin by reversible bonds. It will use the energy. Remember, at rest itself, it is in a high energy state. It utilizes that energy and executes a power stroke. What is this power stroke? The head will move towards the tail. And when it moves towards the tail, it carries or it pulls the actin along with it. The next step is ATP attaches to the myosin head. And this in turn causes detachment of head. There is a conformational change which causes a detachment of the myosin head. And this is a NEET PG question asked last year. What causes detachment of head? Attachment of ATP. The ATP which is attached is now hydrolyzed. There is a hydrolysis of ATP. Remember, the myosin head has an ATPase enzyme which causes the breakdown of ATP to form ADP plus inorganic phosphorus plus energy, and the head goes back into the high energy, high affinity state. If calcium is present, it will now bind with the next active site on actin, utilize the energy, execute a power stroke, ATP attaches to myosin head, conformational change causes detachment of head, ATP is hydrolyzed, head goes back into that high energy, high affinity state. If calcium is available, it will bind with next active site on actin and again power stroke. So basically, there is repeated formation of these cross bridges, which is responsible for actin sliding over the myosin, which results in a decrease in the length of the sarcomere and therefore the decrease in the length of the muscle fiber and the muscle. So this is the molecular basis of muscle contraction. And if you notice something, one ATP is being used in one cross bridge cycle. When the ATP attaches, head will detach. That same ATP will be hydrolyzed to cause what is known as recocking of the myosin head. So one ATP is used in each cross bridge cycle. So these were the questions in your CBT. Hope you've understood these concepts. Thank you very much and all the best.
Hello my dear friends, A very warm welcome to all of you in this live discussion session of CBoT PSM. So, the first question is regarding the definition of index case, primary case and measles vaccination. Here they are saying that Pooja Devi has a 4-year-old son Vijay and 6-year-old Ajay. First Vijay developed measles rashes, which was ignored by the mother. Then Ajay developed fever and Pooja took, the mother took Ajay to the hospital. So in this story, who is the primary case? Vijay is the primary case. Primary case simply means first case is primary case. And from this primary case, infection went to Ajay. So Ajay, because Ajay was reported to health system, therefore Ajay become the index case. Index case simply means the one which is reported to the health system. So definitely Ajay index case correct, Vijay primary case correct. Now, the third option is measles vaccine is effective only if given before infection. And the fourth option is that measles vaccine is effective even if given within 2-3 days of infection, as it gives immunity before development of symptom. So actually, if you look at the measles vaccination thing, yes, Ashish Kumar Parida is asking, is Ashwini sir taking live session? Yes dear, I am live, Ashish, and you can ask your doubt, question regarding any topic, any question, feel free. So in case of measles vaccination, do remember this point that measles vaccine give immunity at immunity in 7 to 8 days. But the symptom of measles comes after 10 to 14 days of infection. Symptom appears after 10 to 14 days. So that means the person will develop immunity before appearance of symptom. And therefore, if in any family one person got infected, then within 2-3 days, if we give immunization, then infection can be prevented in the second child, that is Ajay. So that means this line 4 is also correct. Measles vaccine is effective even if given within 2-3 days of infection. Why? Because if it is given within 2-3 days of infection, if you add 7 days in it, by the time of 10 days, before appearance of symptom, he can develop immunity. So the correct answer is 4, 2 and 1. These 3 are correct. I think index and primary case is clear to you. Like in December 2019, I was in China when COVID started in China. I came to Delhi on 24th of December and then I went to Kerala to take a class, and from the Kerala first case of measles was reported from an student, foreign medical graduate. So I suppose got infection of COVID from China. I became the primary case of COVID. Now because at the airport on that time they were only thermal monitor, they were not doing RT-PCR, so they might not have detected me. And then I infected a student which was reported. So this student from Kerala, it become index case. Okay, so I might be the reason of COVID in India, है ना? कभी घमंड नहीं किया, है ना? But it can be. So I hope you understand. Primary case is the one who develop infection first. Index case is the one who is reported to health system first. And measles vaccine give immunity within 7 to 8 days, but still we do not give measles during disaster. Do remember, during disaster, we do continue the vaccine which we are giving to child. But to general population, during disaster, no vaccine given to general population, except typhoid, cholera and tetanus. These 3 vaccines are given to health workforce, to doctors and other people who are going in that area. They will get these 3 vaccines, typhoid, tetanus and cholera. Okay, but no new vaccine will be given to general public. So question might come in your mind, why we are not giving measles? If it is giving immunity Early, why we are not giving it? First reason, measles is not a common disease during disaster. During disaster, common disease is, most common disease gastroenteritis, then there is cholera, leptospirosis and all. Measles is not a common disease, so that is one reason of not giving vaccine. Second reason is the health workforce is in limited number during disaster. So if we engage them in vaccination, who will save the life? So that is why no vaccine is given to general public, and to health workforce we give these 3 vaccine, typhoid, cholera, tetanus, because these 3 infections are more common to occur in health workforce during disaster. Okay, so I hope you will remember it. Now, the next question is, a child is having chronic liver illness and he is being classified based on this child Turcotte Pugh score. Which type of data is it? Do remember, all scale, whether it's anxiety scale, whether it's depression scale, whether it's glass glaucoma scale, and all the scores and scale or scores, they all have grading. Like if suppose you hit me and you are my friend and ask how much pain you felt, I will say just 1 by 10. But if someone unknown will hit me and ask how much pain, I will show him how much pain and I will say pain felt was 9 by 10. So 1 by 10 is much less than 9 by 10, but these are just categories of pain which we are artificially creating. So this type of grading make the pain categorical variable, and categorical variable are qualitative variable. So this data is qualitative. Now 1 by 10 and 9 by 10 are arranged in order. 9 by 10 is more pain than 1 by 10. So these are qualitative and ordinal data which are here. So the answer become ordinal. Nominal data have only name like male, female, let's say religion, your color, not color but religion you cannot grade. Blood group you cannot grade, and sex, male, female you cannot grade. So sex, religion and blood group, these are example of nominal data. 2-3 more point I want to tell. First thing is, whenever there is qualitative data, the data will be either in percentage or proportion. Like they can say percentage of anemic female in a group. So percentage means let's say 20 by 100, 20 out of 100 female are anemic. So that is proportion or 20%. And when we are saying anemia, anemia you can only categorize as mild, moderate, severe. You cannot say that female has 2.8 anemia. So anemia is qualitative. What you can measure is HB. So HB is quantitative. So do remember this point, that all the disease, whenever we call about hypertension, diabetes or something, this disease are qualitative. But the parameter which we measure in disease, like we can measure cholesterol, we can measure BP, we can measure bilirubin, all these parameter which we measure, because it is measurable, they are quantitative. And do remember one more thing, for quantitative variable we use mean, and for qualitative we use median or mode. Okay, so median, mode, percentage, proportion and disease, if you find any of these 5 things in the question, then answer is qualitative data. And for qualitative data we apply chi-square test. If there are 2 group or more than 2 group, we apply chi-square test. So these information has been asked again and again. I hope you will remember it. Ashish is saying that, sir, kindly discuss type of data and scale. I get confused always. Okay, my dear friend Ashish, let me discuss it. If it is quantitative, quantitative is continuous, and continuous or quantitative will have all the things which we can measure like HB, BP, blood sugar, bilirubin level, cholesterol level, all of these are quantitative. Quantitative data can be ratio scale or interval scale. If it is ratio, ratio means there is true zero. True zero means, let's say I am measuring, you are measuring BP in an emergency room, your senior say, what is the BP? And you measured the BP, you said, sir, BP is 0. What does it mean? Patient is no more. Or the machine is not connected with the tube. That's why it can come 0. So if it is 0 BP, it means there is no BP. That means BP is ratio, because at 0 BP nothing exists. Similarly, weight cannot be 0, height cannot be 0. All of these are example of ratio. example of interval scale are those which don't have true zero. For example, temperature. Temperature is measured in degree Celsius or Kelvin, and if there is 0 degree Celsius, still you can feel the temperature. So temperature are example of interval scale. How to remember it? Before Corona, most of the big vacations in our life are summer and winter vacation. So that means who give us interval in our life? Temperature gave us interval of our life. So interval, temperature, rest all measurable thing goes to ratio. When it comes to qualitative, as I said, qualitative is categorical and qualitative is also known as discrete variable. In this part, all the disease come, and this discrete or qualitative can be classified into nominal and ordinal. When it is nominal, there is only name like sex, religion or blood group. And when it is ordinal, ordinal have, do remember, all scales, all scale and score are ordinal. For example, socio-economic scale, middle, upper middle, like this, there are 5 grading, lower class, lower middle, middle, upper. So all this grading in any scale or score are example of ordinal data. Similarly, if I say mild, moderate, severe anemia, this is again grading. So that will also be ordinal scale. Okay, Ashish, I hope it is clear. If it is still not clear, feel free to ask it again. Next question is about a diagram which is depicting natural history of disease, and they are asking which point marks the onset of symptom. So the onset of symptom is something which start after subclinical disease. At point C, the patient start developing symptom. So C is the point which say onset of symptom. Now they can ask a similar question on the lead time bias thing, and they can give you some point like this, A, B, C, D, E, and they will write A is the point of entry of pathogen, B is the point where early screening test is done. C is the point of spread of cancer. This is known as critical point of spread of cancer. D is the point of diagnostic test. And E is the time of death. So they can ask, what does BD represent? What does BD represent? Okay. I am asking this question, and all of my friends who are listening to this session, please reply. Option A, is it latent period? Option B, is it screening time? Option C, is it lead time? What will be your answer? What does BD represent? Please do feel free and answer. Okay, Ashish is saying his doubt about data is clear. So thank you, Ashish. Now try to answer this question. See, latent period is that duration within which disease is hidden. So we cannot detect the disease before early screening test. So this duration A to B, in this part disease is hidden, that is latent period. Then screening time, we cannot screen before early diagnosis. So before B we cannot screen. And if you screen a disease after critical point of spread of cancer, there is no point of screening. So B to C is the screening time. And what is the definition of lead time? Lead time is the time gap between early screening and usual diagnostic test. So BD stand for lead time here. Okay, this is the definition of lead time, gap between early screening and usual diagnostic test. Now, so Ashish is correct, C. Simu is also said C. Prasant Derricks has said B. Arpit said C. Ram Babu said B. And so all those who said B, they are saying B because original question was asking about screening time. But in that original question, they were not asking BD, they were asking B to C. And I changed the question a bit. That's why some student answered screening, but I hope you understand why it is lead time, because it is lead time is the time gap between early screening test and usual diagnostic test. Now one more thing they can ask is, lead time bias is present in this example or absent in this example. So lead time bias occur if we are doing a screening test after critical point of spread of cancer. Because after spread of cancer, if you are detecting it, then you cannot do anything to prevent the prognosis. Most of the damage has been done. So lead time bias is absent here. Why it is absent? Because we are doing early screening before spread of cancer. Now we can use this B2D is lead time. We can use this part of the time from the lead time in doing some intervention and prolonging the survival of patient. So lead time bias is absent here. Now let's go back to the question and let's discuss, let's say this point is 1, this point is 2, this point is 3, 4 and 5. So which point you will call, which two number you will say as a screening time. Screening time start from anything before the critical time is screening time. So between 2 to 4 we can do the screening. Between 1 to 2 disease is hidden, so that is latent period. Okay, and this 2 to 4 will be the screening time. And if it is stage of recovery, that is something else. So I hope this question must have helped you. Now let's move ahead. A randomized control trial is being conducted in a patient with femoral hernia, and to compare the outcome of new surgery A and a gold standard surgery B, the p-value is found out to be 0.04. Then what we can conclude from this? So can you answer this question? Please try your best. First thing is, p-value is defined as probability of significant result by chance. Probability of significant result by chance. And whatever come by chance, we cannot trust on that. So let me explain this thing to you much better. What I'm trying to say is, p-value have same meaning as alpha error. This concept can help you in solving a lot of question on p-value alpha error. P-value alpha error same meaning. Only difference is alpha error is pre-estimated before doing a study, p-value is calculated at the end of the study. So what does alpha error means? Alpha error means saying non-significant as significant. Non-significant as significant. And a very good example of alpha error is the study on corneal drug by Baba Ramdev. In that study, corneal drug study, researcher had taken people without fever. Asymptomatic patients were taken in the study. And at the end of the study, corneal researcher said that corneal can treat corona fever. If it is done on asymptomatic people without fever, how can you say that it can treat fever? So what was happening in corneal study? In the corneal study, researcher was trying to say non-significant corneal drug as significant. He was trying to give false positive report for corneal drug. And it's not so difficult to understand alpha beta error. Let's say Ashish came to me, he wanted a party from me, so he put a steth on my stomach and said, "Congratulations, you are pregnant," to me. So he is giving which type of report to me? He is giving false positive report of pregnancy to me. He is saying non-significant abdomen as significant. So he is doing alpha error. Now in the same way, let's understand p-value. In the Baba Ramdev study, corneal study, they were saying the corneal drug as significant, but they were getting the result by chance, by mistake. Or in this example where Ashish declared me pregnant, Ashish was getting a significant result from my stomach, but it was not my child heartbeat, it was just the gurgling of my intestine. So he got the significant result by chance or by mistake. That means these two are having same meaning. So p-value also means false positive, alpha error also means false positive. Whenever researcher is trying to act over smartly, chalu ban raha hai researcher, that is alpha error. And whenever researcher is giving false negative report, false negative stand for beta error. Whenever you underestimate yourself, beta error. Whenever you overestimate yourself, alpha error. So this second line is beta error. Type 2 error is also beta error. And p-value has nothing to do directly with beta error. So this 2 line is not talking about p-value. Now come to option C. Option C is saying power of study is something. But power of study have this formula that it is equal to 1 minus beta error. Again, power of study has nothing to do with alpha error directly, and it may be indirectly related but not directly. So what is the correct answer? D. Why? Because in D they have written probability of false positive conclusion is 4%, and false positive means alpha error, false positive means p-value. So whenever they write false positive, it means researcher is acting over smartly, चालू बन रहा है, जबरदस्ती मेरे को pregnant कर नहीं रहा है, declare कर रहा है, जबरदस्ती forcefully he is giving positive report. So that is p value, that is alpha error. That's why the answer is D. Okay, thank you so much. Now, next question is this medicine. This is the medicine for leprosy, multiple drug therapy. Kit 5, which we give for viral genital ulcer, is red in color, but it do not have so much of medicine under it. It is viral genital ulcer is treated by acyclovir only. So it is not that much medicine there. And for HIV patient treatment, we have 3 medicine. LTD, limited is the mnemonic, lamivudine, tenofovir, dolutegravir. So again, in that case also, these many medicines are not there, plus the kit is definitely of leprosy. Now, there was a very controversial question in the NEET exam, that patient have cervical erosion and vaginal discharge. Under which category kit you will classify the patient or give him which category kit? Option is A, will you give grey kit, B, will you give green kit. So, grey kit is given for 3 things: urethral discharge, anorectal discharge, cervical discharge. And basically, grey kit is for cervicitis also, cervical discharge, cervicitis. Whereas for vaginal discharge, we give green kit. So, in Park textbook, it is written that cervical erosion indicates cervicitis. It indicates that there is some pathological changes in the cervix, and therefore some secretion are coming out through vagina, but originally the source of infection is cervix. So because in Park textbook they are clearly written cervical erosion as a sign of cervicitis, therefore the correct answer will be grey. There is a lot of controversy in this from gynae, from derma, but because Park has written cervical erosion as a case of cervical discharge or cervicitis, so we will put it as grey category. Okay? Yes, I know this is controversial, dear, but due to being written clearly in Park, I am confident the answer will be grey only. If you still have some doubt on it, you can see that clipping which I discussed in NEET previous year question discussion on YouTube session. I have put that clipping of Park book also to support my answer. Okay, and always trust evidence, do not trust expert. This is evidence-based medicine. Now coming to the next question. A patient present with fever for 1 week, abdominal distension like me, loss of appetite and lymphadenopathy, there is poor response to antibiotic. This abdominal distension might be happening due to hepatosplenomegaly. Okay, and ascites. These 2 features, they can occur in malaria and a multiple number of illness, but they also occur in Kala Azar. And they have given one hint to understand that RK39 is positive. This is the rapid diagnostic test kit for Kala Azar. Now the question is, what is the drug of choice for Kala Azar? Answer is, I am sure you must have written it correct, liposomal amphotericin B. See, liposomal amphotericin B is the drug of choice for Kala Azar and black fungus both. So black fungus, again Kala fungus, or black fungus is usually mucormycosis. So mucormycosis and Kala Azar both are having this drug of choice, LAMP. Second drug of choice for Kala Azar is miltefosine. Third drug of choice is sodium stibogluconate. Okay, so this is, answer is definitely LAMP. Okay, now next question. In a town with a population of 20,000, a total of 456 births happen in a year, out of which 56 were born dead. So if 56 is born dead out of 456, live birth, how much become the live birth? Live birth became 400, because we will subtract 56 from 456 and that will become live birth 400. Now the total death accounted was 247, out of which 56 deaths were within 28 days of life and another 44 days after 28 days before completing their first birthday. Okay. So calculate the infant mortality rate. Infant mortality rate have, I hope you all know this thing, that between 28 week to birth and then to first 7 day, this is the period of perinatal death. Birth to 7 day is early neonatal. 7 day to 28 day is late neonatal. 28 day to 1 year is post neonatal. So they have asked this, and this period from birth to 1 year is known as infant period. And whenever you are going to write the definition of any one of these, you just need to know the duration. Denominator will always be live birth, and all of the definition will always be multiplied by 1000. So you can know the formula of all of these if you just know the duration. Denominator will always be live birth multiplied by 1000 always. So they ask sometime this question, that which death is not included in IMR. Infant death rate do not include perinatal death completely. It includes this part of perinatal death between birth to 7 day, but not complete perinatal is included in IMR. IMR do not include perinatal death. Now here they are asking IMR. In IMR, first we have to write the neonatal death between birth to 28 day, which was 56, where 56 death were between within 28 day. Then we have to write this part post neonatal. They have written also another 44 after 28 day before 1 year. So this part 44 is post neonatal. If you add 56, 44, it will become 100. So numerator is 100, denominator is 400, and it is multiplied by 1000. So if you will solve it, it will be 1 by 4 into 1000, and 4 will cut 1000 into 250. Answer will become 250. In most of this type of question, the calculation usually they give is not so tough. All such answer are never correct, which has hard calculation. Usually the calculations answer which come out is something which is whole number, like 225, 250 can be the answer. Easy to calculate will be the answer. And if you know this formula, you can do all this question with confidence, I hope. Okay? Chalo, very good. Anurag, Arpit has given answer correct. And Jyoti is saying posaconazole for black fungus is also there. Yes. But lamp is again something which we were using at that time, and it was there. Kaju Katli is a student replying. He is saying, Baba Chaman, kahan se laate ho sir itna energy? All my energy come from your support and appreciation. When I see you appreciating and smiling on my videos and replying so quickly, I get that energy and vibe. You know? Of course, I am coming after taking class from 10 to 8:30 in one batch, but the message which we give to our subconscious mind through conscious mind turn into reality. So if you start saying I am tired, your subconscious will take it as reality. Never say I am tired and you will not be tired. This is a very good way to fool your brain. So never say anything wrong about yourself, like I have weak memory, I have sleeping problem, I am tired. All these things give command to subconscious mind. So if you will not give such wrong command, you can function without any limit, because our brain and body don't have any limit. Now let's come here. All of the following are included in RBSK screening except. So RBSK can screen for vitamin A deficiency. When we screen for vitamin A deficiency, the screening is done by BITOT spot. BITOT spot need to be more than 0.5% to declare vitamin A as a public health problem. And night blindness need to be more than 1% to declare vitamin A deficiency as a public health problem in the children of 6 months to 6 years. So this criteria they have asked in recent exam, do remember. Now vitamin D deficiency, again in NEET they have asked one of the question on this of bow leg. Plus in vitamin D you can see ping pong skull, delayed eruption of teeth, rachitic rosary, barrel shaped chest. So all the thing you can observe from outside. Remember in all this question of RBSK, the Ayush doctor is going to screen in school without any instrument except steth. So if you need some instrument for detection, that disease do not come under RBSK. Like congenital glaucoma do not come under RBSK, because we need, in 90% of the cases, we need either major optic nerve thickness or eye pressure to declare it as glaucoma. So this do not come. And out of these four, government expect that because Ayush doctor is going with a stethoscope, he can detect cardiac wall defect. So this comes under RBSK. Vitamin D deficiency, vitamin A deficiency all come under RBSK, but zinc deficiency do not come under RBSK. A question on this topic came in NEET exam last time, that a patient have dryness around nose and lip or mouth. So this is a clear-cut sign of zinc deficiency, acrodermatitis enteropathica. Okay, answer is zinc deficiency. Okay. Bhartiya is saying ki Bhartiya is becoming abusive on me. Chalo, thank you Bhartiya for abusing me. In that way also you showed that you are watching the video. Very good. Chalo, a new drug combination of chemotherapy and immunotherapy for metastatic melanoma are prescribed by a radiotherapist. It prolongs the survival. Which of the following is true in this situation? Incidence remains same, prevalence reduce, and this type of confusing question has been asked in INICET one time earlier also. To answer this type of question, you have to remember the formula. Prevalence is incidence multiplied by duration of disease. Okay. So, if the drug is, let's say, what is the drug doing here? The drug is prolonging the survival. Simple thing they have written, prolong the survival. So if it is prolong the survival, duration will be more. And if duration will be more, prevalence will be more. This is the same example which occur with case of hypertensive and diabetic drug. They do not prevent, they do not treat hypertension diabetes, but they prevent death from hypertension diabetes, as a result of which patients suffer for very long duration. And that's why at any time in a population, diabetic and hypertensive patient are very high. So duration, if increases, it increases the prevalence. Okay, that means prevalence increase will be the answer, which is in option C and option D. So now you have to think about incidence. Do remember this fact, that whenever they ask question about drug, with drug, incidence is affected but not very significantly. So drug, whenever the question is with drug, do remember that it has almost same incidence. Drug have almost same incidence. Okay, so do remember this point. Answer become C. Incidence remain the same and prevalence increases. Okay, chalo. Now let's come to question number 10. This question is on air pollution level, and in the air pollution level, they are asking that on December 15, the air pollution level that is given, which will come under which category? So you can see in December 15, the air quality index is 366. And if you look at the classification of air quality index, between 0 to 50 is good quality air. 0 to 50 आया तो मतलब अच्छी हवा छोड़ी. 51 to 100 is satisfactory. So up to 100 we need not to worry. Then after that we can remember it by the mnemonic MPVS. MPVS. M stand for moderate. Moderate is 101 to 200. P stand for poor. Poor air quality. It is 201 to 300. Then V stand for very poor. Very poor is 301 to 400. And S stand for severe. Severe is when it is more than 400. So MPVS is the mnemonic, do remember? And it is 366. That means it is between 301 to 400. And therefore it will belong to which category? Very poor. The original question which came in NEET exam 1 year before, they had 468 written. If it is 468, it will be severe. Okay, so in this way you can classify and remember the mnemonic MPVS up to 100 good satisfactory 50-50, then MPBS moderate, poor, very poor, severe, and you will not be wrong here. Chalo, very good. Bhartiya is giving me lot of abuses. Dear friend, if you have to abuse me, at least remove Bhartiya word from there na. Don't discredit our motherland, please. Give abuse, but remove that Bhartiya word. Please come here. The blood pressure of a population was tracked from childhood to adulthood. It was observed that those who had lower BP in childhood had lower BP in adulthood also, while those who had higher BP in childhood have higher BP in adulthood also. Which phenomena it is? So this is the phenomena where if we measure BP with age, the person whose BP is more at 10 year, it has been found that the same person BP will also be more at 50-60 year. Similarly, if someone has low BP at 15 or 10 year, he will also have low BP in adulthood. It looks like BP is tracking the person. This is tracking phenomena which is being shown in this question. Now, in the rule of half, they ask this question, what does the innermost circle represent? So remember, in the rule of half, innermost circle represent adequately treated. Adequately treated come under innermost circle. Okay. In the step approach, which we do for non-communicable disease, we try to compare high risk population, that India have more high risk population or China has more high risk population, that we try to compare. And in the stepwise approach, BPH can be used to remember. We are using two parameters from B, biological and behavioral. Two parameters from P, physical and psychological. One parameter from H, hormonal. So we are not using therapeutic criteria in stepwise approach. Do remember one question of NEET. Therapeutic approach not used. What are the tests being done? So test being done can be remembered by BTR love, BTRL. Hai na? B stand for BP. This mnemonic is being created in the class in today's session. One student gave this mnemonic. B is BP and BMI. Two things we are measuring there. T is for thyroid profile. R, there is only one T. R stand for random blood sugar and L stand for lipid profile. So they have asked this question in recent exam, which of the following test is not done in stepwise surveillance? Whether it's BP, whether it's waist circumference or lipid profile or thyroid profile. So remember, we do BP, BMI, thyroid profile, RBS, lipid profile, but we don't measure waist circumference or mid-arm circumference. So this two is very important. Step approach, do revise. Now let's come ahead. Now let's move ahead and discuss this question number 12. All of the following are showing a false negative tuberculin test except. See, in tuberculin test, sometimes we get confused in false positive, false negative, but it's not so difficult. False negative means you don't have tuberculin, hey, you have TB, but you wrongly came negative. False negative means miss out. Someone have TB, but still tuberculin report come between 0 to 5 mm is the thickness of the induration which occur after giving tuberculin. So, false negative in tuberculin occur in those disease for which you are negative. Like you all think, at least you think that you are negative for HIV. So HIV is for which we have been false negative. HIV means all the immunocompromised condition, immunocompromised state will be false negative. And false positive come in those disease for which you are also positive. Like all of you must have taken BCG. So history of BCG vaccine will give false positive. Now why, let me explain this concept behind you, why the false negative, false positive are there. Suppose I am having HIV, okay. Now if I am having HIV, I have very less antibody in my body. So when you will inject tuberculin antigen on my left forearm and after 72 hours you will look at the swelling, because I don't have antibody due to HIV, there will be no reaction. क्योंकि एंटीजन से लड़ेगा कौन? ट्यूबरकुलिन एंटीजन से लड़ने के लिए मेरे पास एंटीबॉडी है ही नहीं. I don't have antibody due to HIV. So even after having TB, there will be no reaction, and because there is no reaction, report will come false negative. Now, why BCG have false positive? Because suppose I don't have TB, but because I took BCG vaccine in the past, my body have the antibody. मेरे अंदर TB के खिलाफ सिपाही ready हैं. I have the antibody ready against TB. Now, if I take BCG tuberculin test, those antibody prepared by BCG will come and react. I don't have TB, but those antibody will react here. So I will get false positive report here. Okay. So that's why, which will be the not correct for false negative? Immunocompromised, HIV, malnourished, they all can have false negative. But history of BCG will have false positive. Okay. Chalo, thank you. Now, let's come to question number 13. After being inspired by an ASA worker, that student Bhartiya is a very good student. He listened to me and he changed his name from Bhartiya to something else, Sunny Leon, Mia Khalifa, and I removed Bhartiya word. Very good. Chalo, now let's come here. After being inspired by ASA worker, a primary gravida in a rural Bihar states goes for institutional delivery. What financial reward under the Janani Suraksha Yojana would they receive in rupees? This is a question which came in NEET exam, and it can be done by remembering this table. In this table, we have to understand that the money given to low performing state will be higher than the money given to high performing state. Low performing state are those in which mother and infant death are very high. And there are 10 states which are low performing. Very simple to remember. First will be United States of Bihar, the state from which I also come. Then there is the two neighbor UP and MP. And then their brother, which were separated in 2000, Jharkhand, UK and Chhattisgarh. So total 6 you can remember easily. The remaining 4 can be remembered by Roja. Rajasthan, Odisha, Jammu and Kashmir, Assam. Roja, Janeman, and then the 6. Total 10 states are low performing. Now, the money given in rural part is different. Money given in urban part is different. Money given to ASA is different. Money given to Usha is different. And of course, they are different than the money given to mother. So, let me give you a hint how to remember it. In the low performing state rural area, mother get 1400. High performing, 700. Urban area, mother get 1000. High performing, 600. So, you just have to remember these 4 digits. Say it with me. 1400, 700, 1000, 600. 1400, 700, 1000, 600. 1400, 700, 1000, 600. If you remember these 4 digits, now the last thing is ASA always get 600, whether in low performing or high performing. Usha always get 400, whether in low performing or high performing. Okay. So now the question is about rural part in Bihar. First of all, Bihar is in low performing. Second, it is rural part. So rural part of Bihar, 1400 and 600, option B will be correct. In NEET exam, when they ask the question, they have asked it from urban part of MP. Urban part of MP. So MP is also low performing, but urban part means 1000 and 400 was the answer in the NEET exam for urban part of MP. So similarly, you can think about different state and try this experiment with your friend, whether they can tell the money correctly or not. Okay, thank you so much. Now, next question. Roshan Jha is saying, awesome session, sir. Shukriya, shukriya. And that is the thing which is giving me energy. Very good. Now, during the Viva exam in a college, the examiner asked a student regarding physical quality index of life. From the given option, all of the following are indicator of PQLI except. So see, when you write PQLI, LI means, you can write LI as life expectancy at 1 year. So PQLI have this criteria, life expectancy at 1 year. Second criteria is, what about those children who died in less than 1 year? They will be counted in IMR. Really sorry. So, second criteria in PQLI will be IMR. Life expectancy 1 and below that any death will be in IMR. The third criteria is literacy rate. So, all these 3 criteria are in PQLI. That means the correct answer is none of the above. Okay. HDI have these 3 criteria. I hope you all know. In the HDI, the criteria is life expectancy at birth, per capita income in purchasing power parity of country GNP, and last criteria is mean year of schooling is the third criteria. These questions they keep asking in INICT also 2 times they have asked in last 4 year only, and again these topics are being asked, so do remember it. Better indicator of socio-economic growth of a country is PQLI, and HDI is a better indicator of quality of life. But which is a better indicator of socio-economic growth of country? PQLI. Why? Because PQLI have IMR, and IMR is the best indicator of 3 things. IMR is the best indicator of accessibility and affordability of health system. This question came in NEET exam just this year. Accessibility, affordability, health system is good, then infant death will be less. So if IMR is high, accessibility, affordability is poor. Second thing which IMR indicate best is impact of ASA work. ASA is working or not decided by infant death. Third IMR tell is female condition in that country, because if female is malnourished, they will deliver premature baby before 37 week, and due to premature delivery most of the infant die. Most common reason of infant death in India is premature delivery. So if infant death is high, it means mother are not in good condition. So IMR is the best indicator of these 3 things. That's why PQLI is better indicator. Chalo, now coming to the next question. In South Korea, women can expect to live an average of 88 years. Life expectancy has increased by 15 years as a result of recent development in cervical cancer testing. So life expectancy is increasing here due to some intervention, something you have done which increase the life expectancy. This is detected by QALY. QALY stand for Quality Adjusted Life Year. Okay, Quality Adjusted Life Year. And to understand the meaning of all of these better, adjust the word adjusted, remove it. So what is QALY? QALY simply means quality life year added due to an intervention. For example, Park has written that dialysis add 0.5 QALY each year in life of patient having renal disease. So if in the question they talk about any intervention which is prolonging life, answer will always be QALY. Now, what is DALY? DALY has 2 components. Year of life lost due to early death plus year lived with disability. So these 2 components are there in DALY. They keep asking this, do revise it. And DALY is the best indicator of morbidity. Okay, HELL, full form of HELL is health adjusted life expectancy, but again you have to adjust the adjusted word, so it is healthy life expectancy. And this healthy life expectancy is estimated at birth. So for my newborn child of 2.5 months, I can estimate HELL, and the HELL of my child will be less than HELL of a child born in Japan. So HELL is healthy life expectancy at estimated at birth, and DFLE is nothing. Okay, but there are 2 more indicators. One is Sullivan index. Sullivan index is life expectancy minus DALY. So Sullivan index tell us year of life without problem, without disability. Okay, but Sullivan index is estimated at death. At death we count out that how many life year was without problem, without disability. Okay, so that is one more indicator. Do revise it, and this is very important part to revise. Okay, chalo. Now let's move ahead. A patient present with a history of lacerated dirty wound. He claimed that it was been roughly 8 years since his previous tetanus shot. What need to be given following this? Okay, what we should give for this? So to answer this question, we must have a clear knowledge of the guideline for management of tetanus cases. Okay, and those guideline of tetanus management is being given in Park textbook in a very good way. And in that management guideline, do remember they have 2 category. One is clean wound and less than 6 hour duration. I am trying to find out that exact page photo from Park which will help you to answer this question much better. Okay, but in searching I might lose some precious time. So let me tell you the classification, because I also remember it by teaching multiple times. Okay, I am unable to find that picture, so I remember it anyhow, I can tell you. Clean wound for less than 6 hour duration is one category, dirty wound is other category. Okay, dirty wound or more than 6 hour is second category. So first thing is, if the person say that less than 5 year back I have taken previous vaccine, history of vaccine less than 5 year, in that case in both of them we just wash, need not to do anything. If we say history of last tetanus vaccine is 5 to 10 year, in that case we give TT or DT, better TT in both the case. So management is same for clean and dirty wound till 10 year. After 10 year, if it is, let's say the history of vaccine is more than 10 year, we give one tetanus only in clean wound, but in case of dirty wound, if it is more than 10 year with TT, we also add tetanus immunoglobulin. So this is one difference which comes, first difference. Second difference is, if suppose he do not remember the history, no history. If there is no history, we give full course of TT. Full course TT means 5 TT we give if patient do not remember it. And if there is no history here, again we will do the same repetition, full course of TT plus tetanus immunoglobulin. Okay. So this is the classification given in PARC. I hope this is small summary can help you in answering many questions. Here the question have 8 year and it is dirty wound. Dirty wound 8 year, 1 TT, single dose of tetanus will be answer. In place of 8 year, if I make it 18 year, so for 18 year or more than 10 year, answer will come option C in case of dirty wound. Okay. I hope it is clear. I hope you will remember it. Next, oh, the question is being done. That is the last question I had in my slide. Do you have any doubt, any question you want to ask? Feel free to write it in the chat box. Thank you Roshan Jha, Arpit S, Akib Ahmed, Prasant Derek, Simu, Akib Ahmed, and all my dear friends who were listening. I am very thankful to all of you. I am also thankful to dear Bhartiya for making this session interesting by abusing me. So thank you so much. And we have our beloved Aman Sethia sir here. He will guide you through medicine. Thank you so much. Bye bye. Thank you.
इसको इस तरफ कर देना, मेरी तरफ तो यहाँ तो आगे रख दिया, मैं देखते रहूँगा ना, कमेंट दिखते रहेंगे बच्चों। ओके गाइस, सो स्टार्ट करें। प्रशांत, राम बाबू, रेमन, आशीष, अर्पित, आर यू रेडी? शुरू करते हैं। आई कैन सी योर कमेंट, तो अगर कुछ डाउट है तो आप कमेंट बॉक्स में पूछ सकते हो। तो आई थिंक दिस टाइम पेपर वॉज सिंपल, पेपर तो इजी था, इस बार का तो इजी क्वेश्चन आए थे, कुछ ज़्यादा डिफिकल्टी थी नहीं। एम आई राइट? ओके, तो स्टार्टिंग विद द फर्स्ट वन, फॉलोइंग सिम्टम इज नॉट टिपिकली एसोसिएटेड विद हाइपोथायरॉयडिज्म। नाउ लुक एट द क्वेश्चन केयरफुली। आपसे पूछा है कि कौन सा हाइपोथायरॉयड में नहीं होगा, तो जस्ट यू हैव टू सी द क्वेश्चन। सो हाइपोथायरॉयड में क्या क्या सिम्टम होंगे? व्हाट आर द सिम्टम? यू कैन सी कॉन्स्टिपेशन, yes, constipation is a feature that we see in hypothyroidism. Primary hypothyroid diagnosis is anti-TPO antibody. So most common cause of primary hypothyroidism is Hashimoto's, और Hashimoto's में ये एंटीबॉडी मिलती है नहीं मिलती है? इन Hashimoto's antibody is anti-TPO, right? INI TND पेपर टॉपिक स्प्लिट हो गए थे। अब मुझे बताओ हाइपोथायरॉयड में आपको याद कैसे करना, हाउ टू रिमेंबर दिस? इट इज लाइक छोटू मोटू कब्जू, मीन्स मोटा बच्चा है, मोटा आदमी मीन्स मोटा होगा और कब्ज रहेगी उसको। और पेशेंट की कंप्लेंट, द पेशेंट मेन कंप्लेंट विल बी लाइक आई एम ईटिंग वेरी लेस, स्टिल आई एम गेनिंग वेट। सो एपेटाइट बढ़ेगा नहीं, एपेटाइट कम होगा, राइट? ब्रेडिकार्डिया होगा, इज क्लियर? ब्रेडिकार्डिया होगा। सो जस्ट ट्राई टू अंडरस्टैंड दिस मैं एक तरफ लिख रहा हूँ हाइपोथायरॉयडिज्म और एक तरफ लिख रहा हूँ हाइपोथायरॉयडिज्म। सो इट डजंट मैटर कि वो प्राइमरी है या सेकेंडरी है, सिम्टम्स दोनों में सेम होंगे। सो हाइपो और हाइपर। सो अगेन यू हैव टू रिमेंबर द बेसिक फीचर, आपको सारे नहीं पढ़ने, जस्ट अ फ्यू इंपॉर्टेंट वन। सो हाइपोथायरॉयड में आई टोल्ड यू लाइक पेशेंट का क्या होगा? वेट गेन होगा। तो पेशेंट फर्स्ट कंप्लेंट विल बी वेट गेन, लेकिन एपेटाइट कैसा होगा? एपेटाइट उसका कम होगा। सो पेशेंट बोलेगा आपसे या बोलेगी मैं 2 रोटी खाती हूँ फिर भी वजन बढ़ते जा रहा है। हाइपर थायरॉयडिज्म यू विल सी वेट लॉस एंड इंक्रीज एपेटाइट। नाउ सी हाइपोथायरॉयड के कई सारे केस होते हैं, बट हाइपरथायरॉयड के केस उतने कॉमन नहीं मिलते। देन हियर पेशेंट विल डेवलप कॉन्स्टिपेशन, यहाँ क्या होगा? डायरिया। ओके, यू आर आस्किंग अबाउट INI TND शेड्यूल ऑन 6th and 10th. If you give the topic split, then prepare accordingly. Oh, Ashish, we are not splitting the topics. It will be full medicine on 6th and full medicine on 10th, so that you can get more and more questions. दोनों में पूरा आएगा। मैक्सिमम फोकस यू शुड गिव ऑन कार्डियोलॉजी, न्यूरोलॉजी, एंडोक्राइनोलॉजी। ज़्यादातर क्वेश्चन वहीं से आएंगे, बिकॉज एक मेन एग्जाम में भी वहीं से आते हैं। सिंपल। तो यहाँ पर क्या होगा? हाइपरथायरॉयडिज्म में पेशेंट को डायरिया होगा। देन इफ आई टॉक अबाउट हाइपोथायरॉयडिज्म, हियर यू विल सी डिक्रीज इन हार्ट रेट, पेशेंट की हार्ट रेट कम होगी, यहाँ पर हार्ट रेट ज़्यादा होगी। BP will increase in both, but here you will see a classical type of hypertension, and this hypertension is what we call this isolated diastolic hypertension, means नीचे वाला ब्लड प्रेशर डायस्टोलिक बढ़ेगा, बट यूजुअल हाइपरटेंशन भी मिलती है। देन सम important things, if I say hypothyroid patient, this is something which is more common, this is something which is less common. Hyperthyroid थोड़ा कम होता है। Now understand, patient is having decreased heart rate, so there is risk of bradycardia. So patient को आगे जाके bradycardia का risk होगा, and here you will see patient will have risk of tachyarrhythmias, means there is risk of atrial fibrillation or atrial flutter, right? Sinus tachycardia, flutter. So यहाँ पर tachyarrhythmia के चांस है, यहाँ पर bradycardia और AV block के चांस। Many of these patients will have mild to moderate pericardial effusion. सो व्हेन यू ऑस्कल्टेट द पेशेंट, आप देखोगे जो हार्ट साउंड होगी दैट विल बी सॉफ्ट, एंड हियर यू विल सी हार्ट साउंड विल बी लाउड, एंड समटाइम यू कैन फील अ मर्मर. इस मर्मर को हम क्या बोलते हैं? वी कॉल दिस लरमैन स्क्रैच. सो उसको रटना नहीं है, समझना है बस. जस्ट यू हैव टू रिमेंबर, यू हैव टू जस्ट अंडरस्टैंड दिस, राइट. Yes, Siddharth, it doesn't matter you are first year or second year, you can start from now. जितना जल्दी आप स्टार्ट करोगे उतना अच्छा होगा. So you can start from the very first day, right? So ऐसा ईयर मैटर नहीं करता है, आप कभी भी स्टार्ट कर सकते हो. So these are the differences. Now you can see here. अगर मैं बात करूँ most common cause of hypothyroidism will be Hashimoto's. And most common cause of hyperthyroidism will be Graves' disease. So ये थोड़े से डिफरेंस है जो आपको पढ़ने हैं, सिंपल. आगे चले, इजी है. ओके, मूविंग टू नेक्स्ट वन. अब नाउ ट्राई टू आंसर. मेडिसिन के क्वेश्चन थोड़े से लेंदी होते हैं, थोड़े से बड़े होते हैं. सो ट्राई टू आंसर दिस. बताओ. अ 24-year-old स्टूडेंट, 24-year-old पेशेंट प्रेजेंट विथ परसिस्टेंट हाइपरग्लाइसीमिया, शुगर बढ़ रही है, एंड लैक एविडेंस ऑफ ऑटोइम्यूनिटी. कोई ऑटो एंटीबॉडी नहीं है, ऑटोइम्यूनिटी नहीं है. However, their family history reveals a lineage affected by diabetes across several generation. Means एक लाइन से सारी जनरेशन अफेक्ट हो रही है डायबिटीज से, right? Exhibiting a pattern suggestive of dominance. So whenever they say like all generation are affected, we can understand it is some sort of autosomal dominant condition. So here you have to use some pathology biochemistry knowledge. तो पेशेंट का autosomal dominant है because there is no skipping, कोई skipping नहीं हो रही. और जब क्वेश्चन इज मैंशनिंग यू, दे आर क्लियरली टेलिंग यू लाइक देर इज लैक ऑफ ऑटो इम्यूनिटी. ऑटो इम्यूनिटी तो टाइप 1 तो नहीं है. इन टाइप 1 वी विल हैव एंटीबॉडीज. टाइप 1 में एंटीबॉडी होती है कौन कौन सी? इन टाइप 1 वी विल हैव एंटी आइलेट सेल एंटीबॉडी, एंटी जिंक ट्रांसपोर्टर एंटीबॉडी, एंड द एंटीबॉडी दैट वी यूज़ कमर्शियली, एक एंटीबॉडी जिसको हम कमर्शियली यूज़ करते हैं, दैट इज कॉल्ड एनीवन एंटी GAD. Type 1.5 and LADA, they are used as synonyms. दोनों में एंटीबॉडीज होती हैं. सो दे हैव मिक्स्ड फीचर. टाइप 1 टाइप 2 दोनों के फीचर होंगे, राइट. अब देखो ऑटोसोमल डोमिनेंट पैटर्न है, स्किपिंग नहीं है, थोड़ा बहुत OHA का रिस्पॉन्स भी आएगा. दैट इज कॉल्ड MODY, मैच्योरिटी ऑनसेट डायबिटीज ऑफ यंग. एंड रिमेंबर मोस्ट कॉमन टाइप ऑफ MODY इज MODY 3. मोस्ट कॉमन इज MODY 3 एंड दिस MODY 3 विल अकर ड्यू टू म्यूटेशन. किसके म्यूटेशन में होगी? HNF1 अल्फा. So it is due to hepatocyte nuclear factor. HNF का मतलब क्या होता है? Hepatocyte nuclear factor. आकिब शिवानी, सासा गिरे, एनी डाउट? सो आंसर क्या होगा इसका? व्हाट विल बी द आंसर फॉर दिस कंडीशन? यस, कम ऑन. अब मुझे बताओ, एक क्वेश्चन पूछते हैं कभी कभी, लाइक MODY का क्रोमोसोम कौन सा होगा? व्हाट इज द क्रोमोसोम फॉर MODY? HNF1 अल्फा. व्हाट इज द क्रोमोसोम फॉर MODY? इट इज दैट क्रोमोसोम 12. Sometimes they ask you this question. Clear? So this is clear, easy है. Coming to next one, अगले क्वेश्चन पे चलते हैं. ये तो बहुत सिंपल है, easy one. A 45-year-old patient, 45-year-old patient present with chest pain, ST segment elevation in V2 to V4. अब देखो मेंशन कर दिया V2 से V4 में ST elevation. Let us cross check. You can see V2 में है, V3 में है, V4 में. So remember V1, V2, V2, V3, V4, V5, V6, V7, V5, V6 and 7, 8, 9. अब इसको कैसे याद करना है आपको? लुक एट द स्क्रीन. इफ़ यू सी ST एलिवेशन इन लीड V1 और V2, इसको हम बोलते हैं सेप्टल MI. V2, V3, V4 में चेंजेस है तो एंटीरियर वॉल MI, V5, V6 में lateral MI, and V7, V8, V9 posterior wall MI. And ultimately if you see changes in lead 2, lead 3 and AVF, इसको बोलते हैं inferior wall MI. तो ये तो easy question है बिल्कुल. You can say this is a case of anterior wall MI. And remember most common artery, इसको हम widow artery भी बोलते हैं. Widow artery means ये उसके पति को विधवा, क्या बोलते हैं, विधुर बना देती है, मीन्स उस पत्नी को विधवा बना देती है. विडो आर्टरी, इट इज मोस्ट कॉमन आर्टरी अफेक्टेड इन MI एंड मोस्ट कॉमन MI विल बी एंटीरियर वॉल MI. सो आंसर क्या होगा इसका? ए. हरिओम, आशीष, शिमु, इजी है, आगे चले। ओके, मूविंग टू नेक्स्ट वन, बताओ, इजी वन। अगला क्वेश्चन और सिंपल है। 66 ईयर ओल्ड पेशेंट, 66 इज द एज, सो ओल्ड पेशेंट, सडन ऑनसेट ऑफ चेस्ट पेन आफ्टर स्ट्रेसफुल इवेंट, कुछ ना कुछ स्ट्रेस हुई। ओके, जिसको भूख लग रही है यू कैन हैव, कुछ खा पी लो, साथ साथ खाते पीते सुनते रहो बस, राइट। स्ट्रेसफुल इवेंट रिजेंबलिंग सिम्टम ऑफ हार्ट अटैक। Subsequently, examination reveals transient left ventricular dysfunction with apical ballooning on imaging study. Means left ventricles जो है वो काम नहीं कर रहा है. So this is the suppose left ventricle. This part is not working. And apical there is ballooning. There is ballooning. On the apex it look like a balloon. So this type of heart, understand this type of heart. If you see the ventricle, apex पे थोड़ा balloon जैसा लग रहा है. We call this as octopus jar heart. Octopus jar heart. And the cardiomyopathy which occur due to some stress. So this is the hint in the question. Stress से है and it is more commonly seen in old female. यहाँ पर mention नहीं है male female, but remember it is more in old female, post menopausal female. Second hint, then it resemble like MI. Third hint, इसमें भी MI के जैसे ST elevation भी हो सकता है, MI के जैसे cardiac markers can also be positive. So it is a classical case of Takotsubo cardiomyopathy. Simple. Yes, Arpit, very good. It is a case of Takotsubo cardiomyopathy. किसी को डाउट है? मोनिका, आकिब, शिमु, आशीष, एनीवन? Am I clear? आगे चले? वेरी गुड. ओके, कमिंग टू नेक्स्ट वन. अब ये पहले तुम बताओ मुझे आंसर, देन आई विल गिव यू माय आंसर. इजी है, इजी क्वेश्चन है. 65 ईयर ओल्ड, एनीमिया, हाइपरकैल्सीमिया, रीनल फेलियर, लाइटिक बोन लीशन. Which diagnostic test is essential to confirm the diagnosis of multiple myeloma? बताओ. So आपके पास एक पेशेंट है who is having hypercalcemia, means calcium is increased. There is a kidney involvement, means renal failure, or I can say some sort of kidney involvement. ये renal failure multiple myeloma कई वजह से होता है. It can be due to hypercalcemia, it can be due to I can say amyloidosis, it can be due to paraproteinemia, it can be due to light chain, it can be due to immunoglobulins. So किसी भी रीज़न से हो सकता है. Then we can have anemia and you can see मैं ऐसे लिख दे रहा हूँ उसको, bony lytic lesion. Bony lytic lesion. So in short what we call them as, come on, क्या बोलते हैं इसको, क्या बोलते हैं इसको? Crab feature. Crab feature. तो क्रैब फीचर सारे के सारे हैं. ओल्ड पेशेंट है, अगर आप इसका सीबीसी कराओगे तो ESR बढ़ा हुआ आएगा. सो व्हाट दे आर आस्किंग मी, व्हाट इज द टेस्ट टू कंफर्म? नाउ अंडरस्टैंड वेदर इट इज आई कैन से एनी सॉर्ट ऑफ पैराप्रोटीनीमिया और मैलिग्नेंसी. सो इन्वेस्टिगेशन ऑफ चॉइस विल बी आपको बोन मैरो की बायोप्सी करनी है, राइट. सो हाउ वी विल मेक अ डायग्नोसिस? यू विल डू अ बोन मैरो बायोप्सी, एंड बोन मैरो बायोप्सी विल हैव मोर देन 10% क्लोनल प्लाज्मा सेल्स. तो उसमें आपको प्लाज्मा सेल्स मिलेंगे. इसके साथ साथ क्या चाहिए? क्रैब फीचर. दिस इज हाउ वी मेक अ डायग्नोसिस. अब इस ऑप्शन वन बाय वन. ESR इज एक्यूट फेज रिएक्टेंट. सो ESR तो किसी भी इन्फेक्शन में, इन्फ्लेमेशन में बढ़ सकता है. सो इट इज नॉट अ कंफर्मेटरी टेस्ट. सिंपल. सीरम प्रोटीन इलेक्ट्रोफोरेसिस को बोलते हैं, इन शॉर्ट वी कॉल दिस SPEP. इन SPEP अंडरस्टैंड, इसको समझो एक बार. सपोज इफ आई टेल यू ए नॉर्मल SPEP वर्सेज SPEP ऑफ मल्टीपल माइलोमा. सो लुक एट द स्क्रीन. इन नॉर्मल SPEP में क्या होगा? यू विल सी फर्स्ट स्पाइक, जो पहला स्पाइक मिलेगा, दिस स्पाइक विल बी ऑफ अ प्रोटीन कॉल्ड एल्बुमिन. उसके बाद आप छोटे छोटे स्पाइक देखोगे. दिस फर्स्ट स्पाइक इज ऑफ एल्बुमिन. देन ऑल अदर स्पाइक्स, फॉर एग्जांपल ये जो स्पाइक है, दिस कैन बी ऑफ IgG, दिस कैन बी ऑफ दिस कैन बी आई कैन से ऑफ IgA, it can be of IgG, or I can say let me say IgM, IgG, IgD. तो बाकी सारे छोटे छोटे स्पाइक मिलेंगे. इन इट इज normal SPEP. So normal SPEP, so first spike you will see that will be for albumin. Understand? अगर मैं आपको बोलूँ एक आपको normal spike मिलेगा and that will be of albumin, then you can see one more spike which is slightly shorter than the albumin spike, उससे थोड़ा सा छोटा होगा बस. And this spike you will see generally in IgG area in most cases, in 70 to 80% cases, or sometimes you can see this in IgA area. So ये तो क्या हो गया ऊपर देखो ध्यान से, this is what we call this as albumin spike, and the second spike which you can see which is slightly shorter than albumin spike, this spike is called M spike. So बच्चे गलती कहाँ करते हैं कि M spike IgM में होगी. M spike is not in IgM. Remember, M spike is seen either in IgG area or IgA. This pattern is called Church-Speyer pattern, right? And this is what we see in SPEP in multiple myeloma. So आप ये भी टेस्ट करा सकते हो, but again it is not confirmatory. Is it clear? मैं ये नहीं बोल रहा हूँ. So we can do SPEP, but it is not confirmatory. SPEP और हम कहाँ कराते हैं जहाँ पर प्रोटीन का लॉस होता है. फॉर एग्जाम्पल वी ऑल्सो यूज SPEP टू डायग्नोस नेफ्रोटिक सिंड्रोम. पंच्ड आउट लीजन, मेरे पास 3-4 पेशेंट आए थे, उसमें से एक का ही मिला था मुझे. सो पंच्ड आउट लीजन यू विल नॉट सी इन ऑल द पेशेंट. इज क्लियर? इन स्कल एक्सरे, बिकॉज मोस्ट पेशेंट दे विल हैव लाइटिक लीजन इन द पेल्विस. इज क्लियर? So remember, punched out lesion you will not see in all patients. So best test to confirm this, what we do, bone marrow biopsy. आशीष, मोनिका, अर्पित, एम आई क्लियर? हरिओम, शिमु, समझ आ गया? एम आई क्लियर गाइस? आगे चले? डन? ओके, मूविंग टू नेक्स्ट वन. बताओ क्या आंसर होगा. इजी है तो क्या आंसर होगा? इजी क्वेश्चन है, बताओ. जस्ट अ मिनट गाइस. अभी क्लियर है? बताओ. अ मैन 55 ईयर ओल्ड एडमिटेड विद हिस्ट्री ऑफ CVA. तो पेशेंट को सेरेब्रोवास्कुलर डिसीज हो गई कोई. ही फील्स टायर्ड एंड रिस्पॉन्स लिटिल ऑन द सेकेंड डे. ओके, समझो इसको. पेशेंट को एक सेरेब्रोवास्कुलर डिसीज हुई. इट कुड बी कोई कुछ भी हुआ, अभी नहीं पता, अभी आपने CT नहीं देखा है. CT फाइंडिंग इज डिस्प्लेड इन द पिक्चर बिलो. It is displayed in the picture below. So understand this, you are having an old man who was admitted with history of cerebrovascular disease. Means कुछ ना कुछ पेशेंट को स्ट्रोक है. अगर ये TIA होता तो पेशेंट इंप्रूव हो जाता. So it is not a case of TIA. TIA means transient ischemic attack. Am I clear? Arpit, Monica, simple. So क्या है? It's a case of stroke. So we have two types of stroke now. Understand? Either it could be ischemic stroke or it could be hemorrhagic stroke. अभी तक हमने CT को नहीं देखा है. Forget the CT now. CT को मैं छुपा दे रहा हूँ. Just forget the CT. Just focus on me. So it could be a case of ischemic stroke or it could be a case of hemorrhagic stroke. Ischemic stroke patient generally they improve when they passes, slightly improve. Deteriorate उतना नहीं होते. But hemorrhagic stroke bleed फैलती चली जाती है and patient condition usually deteriorate. So understand this thing. So patient is not responding second day or little response, that is telling you it is probably a case of hemorrhagic stroke. Then you can see the CT. If you see focus on the CT, you can see, अगर मैं CT को zoom करूँ तो you can see like this is the bleed and you can see a classical midline shift. So means a patient is having a huge midline shift, right, with the bleed. So this is an indication. अब देखो ऐसे में if you are giving aspirin, then what you are doing? You are killing the patient. Aspirin तो नहीं दोगे. Now understand what you will do. Can you give mannitol? Mannitol we are using from day one, but he is not responding. But again there is a bleed. Mannitol can disperse the bleed now. So you can see what is indication of doing urgent surgery. Indication देखो thrombectomy नहीं करो because there is no as such thrombus. Urgent surgery because there is a big bleed and that is causing midline shift. So patients are having features of raised ICP and this can lead to permanent brain damage. So इसलिए अगर कोई patient next day improve, तो this is the hint in the MCQ as per the like I'll tell you like what is written in Harrison कि अगर पेशेंट नेक्स्ट डे रिस्पॉन्ड नहीं कर रहा है, इन दैट केस इट्स अ डेफिनेट इंडिकेशन लाइक वी हैव टू डू गो फॉर डिकम्प्रेसिव सर्जरी. Super. So answer, I know many of you have marked the answer mannitol. Mannitol could be the answer if they mention like patient respond second day, but if this patient is not responding, so answer will be decompressive surgery. Clear? तो आंसर क्या होगा? सी. आगे चले. Okay. Okay, this question was not given proper. I don't know what is given in your booklet. So इसमें पूरा नहीं था, but I have added the options. Now look at the question. हम ऑप्शन नहीं देखेंगे because now see, when you want to solve a medicine question, medicine के question आपको बिना ऑप्शन के solve करने हैं. सोचना, just keep try to make things in your brain. 35-year-old man who has history of persistent smoking arrives at the OPD with fever. बुखार हो रहा है, exhaustion, yellow urine and clay colored feces. Right? So yellow urine, clay feces means they are telling you some sort of hepatitis. Right? He has had sudden and strong dislike of smoking cigarette. ये क्या हुआ? बदलाव हुआ. You can see there is a change. On examination, icterus was discovered. Which test would you recommend in order to rule out acute viral hepatitis? तो आपके पास liver function test दिए हुए हैं. Total bilirubin 18, मतलब इतना बड़ा हुआ है. Direct bilirubin 7.5. SGOT is 723, SGPT is 812. दोनों बड़े हुए हैं. दोनों बड़े हुए हैं, right? Both are increased. Now they are asking you question क्या पूछा था? What test you will recommend in order to rule out acute viral hepatitis? Arpit, Monica, am I clear? समझ आ रही मेरी बात? Am I clear guys? अब मुझे ये बताओ, पहले सोचो तुम, जस्ट टेल मी द आंसर व्हाट यू कैन थिंक. ऐसा एक क्वेश्चन आपके पास आया तो क्या क्या रीजन हो सकता है? व्हाट आई विल डू एज अ फिजिशियन, व्हाट यू विल डू. फर्स्ट थिंग इज पेशेंट व्हेन ही इज अ स्मोकर, सो आई अज्यूम लाइक ही माइट आल्सो बी अल्कोहलिक. सो फर्स्ट थिंग आई विल डू इज आई विल रूल आउट अल्कोहल कंजप्शन. सो मैं पेशेंट से पहले बात करूंगा, अल्कोहल को रूल आउट करूंगा, अल्कोहलिक लिवर डिसीज. Now once this is ruled out, now he is telling you it's a case of acute viral hepatitis. आपको रूल आउट करनी है. Acute viral hepatitis करने के लिए first you have to know like we have hepatitis A, B, C, D, E. So this is the tricky question because आपसे पूछा गया है what test you will do in order में. तो मैं इसमें क्या करूँगा? तो understand this thing. In acute hepatitis, what test I will do? So most common cause of acute hepatitis is hepatitis A. So I have to rule out hepatitis A. So मुझे A rule out करना है. I have to rule out hepatitis E. I have to rule out hepatitis B. C is generally chronic, right? लेकिन हम पेशेंट का C के भी टेस्ट कराते हैं क्योंकि because C is dangerous. So hepatitis A, E, then B and C. So these two usually causes chronic infection. C is causing chronic in most cases. B can cause acute and chronic. So B, remember, B in 90 to 95% cases it will cause acute infection. 90 to 95% cases. In 5 to 10% cases this B can cause chronic infection. So basically आपको क्या क्या रूल आउट करना है? A, E, B, C और D होगा तो B के साथ में होगा. इज क्लियर? अब इस पेशेंट के मुझे क्या क्या टेस्ट कराने हैं? तो मैं पहले इसकी एज देखूंगा, 35-year-old. सो ओवरऑल मोस्ट कॉमन कॉज ऑफ एक्यूट हेपेटाइटिस, ओवरऑल मोस्ट कॉमन कॉज इज ए. सो व्हाट आई विल डू, तो पहले देखो मैं अपने हिसाब से क्या करूंगा, बिकॉज ए और ई के अगर आपने टेस्ट नहीं भी कराए तो वो अपने आप ठीक हो जाते. हेपेटाइटिस ए एंड ई दे आर सेल्फ लिमिटिंग. तो फर्स्ट आई विल रूल आउट हेपेटाइटिस बी एंड सी. HbS एंटीजन, anti-HCV. So HbS एंटीजन टू रूल आउट हेपेटाइटिस बी, anti-HCV टू रूल आउट हेपेटाइटिस सी. अब मैं सी क्यों करा रहा हूं, बिकॉज सी इज डेंजरस. इट वेरी रेयरली कॉज एक्यूट बट आई हैव टू रूल आउट इट. वंस आई रूल आउट बी एंड सी, अगर ये रूल आउट हो गया देन व्हाट आई विल डू, आई विल टेस्ट फॉर हेपेटाइटिस ए. तो हेपेटाइटिस ए का टेस्ट कराऊंगा. सो आई विल चेक फॉर anti-HAV. then I can also check for anti-HEV. So these are the tests I will do. Up suppose if this is coming positive, HbS antigen, then my next test will be HbE antigen and IgM anti HBC antibody, core antibody. If anti-HCV is positive, straight away I need HCV RNA. और अगर B पॉजिटिव है तो उसको भी आपको देखना है वायरल लोड, देन व्हाट वी डू HBV DNA. इन A एंड E आई विल नॉट डू एनी अदर टेस्ट. इसमें मैं वायरल लोड चेक नहीं करूंगा बिकॉज मुझे पता है इन फ्यू डेज इफ यू गिव अ गुड डाइट दे विल सेटल ऑन इट्स ओन. तो मेरे को ये टेस्ट कराने हैं. अब इसमें से मुझे ऑप्शन ढूंढने हैं. क्लियर? नाउ लेट्स सी द ऑप्शन वन बाय वन. HBS एंटीजन कराओगे? यस. तो लेट मी चेंज द पेन टू मेक यू सिंपल. ये कराओगे? यस. IgM कराओगे? यस. एंटी-HCV कराओगे? यस. सही आंसर है, ये भी करा सकते हैं. सही तो है, बट वी हैव टू चूज इन सीक्वेंस. सीक्वेंस में क्या कराओगे? सबसे पहले आप यू हैव टू रूल आउट A. A के बाद B, C. सो नाउ सी A एंड B बोथ आर करेक्ट बट B इज मोर करेक्ट. तो अगर मैं बोलूँ A इज करेक्ट, B इज मोर करेक्ट बिकॉज इट इज गिवन इन सीक्वेंस. नाउ सी HBS एंटीजन, IgM, anti-HDV, एंटी-HCV, ये तो आपने सारे टेस्ट करा लिए. ये तो आप उसका बिल बना रहे हो, राइट? पहले B पॉजिटिव है, देन वी विल गो फॉर D. सो इट इज़ नॉट द आंसर. आपने anti-HAV A का कराया, सीधे IgM करा ली, बिना सरफेस एंटीजन के आपने IgM करा ली. अगेन दैट इज नॉट लॉजिकल. नाउ सी बोथ ऑप्शन A एंड B आर करेक्ट. नाउ व्हाट इज, बट दे आर आस्किंग यू इन ऑर्डर. ऑर्डर में आपको क्या कराना है? सो अगेन मोस्ट इन्फेक्शन आर ड्यू टू हेपेटाइटिस A. नाउ व्हाई दिस ऑर्डर इज नॉट करेक्ट? बिकॉज यहाँ पे देखो सरफेस एंटीजन करा लिया, B का टेस्ट करा लिया, C का करा लिया. वेयर इज द टेस्ट फॉर A? देयर इज नो A हियर, सो इट इज नॉट द आंसर. सिंपल. सो आइडल टेस्टिंग जो मैंने आपके सामने लिखी है दैट शुड बी दिस थिंग. अगर मैं बोलूँ सीक्वेंस में आइडल टेस्टिंग विल बी रूल आउट B एंड C, राइट? लेकिन अब यहाँ पर आपको A का टेस्ट नहीं कराया, सो दैट इज व्हाट इज नॉट द आंसर. Is it clear? So you have to choose answer as per the option. So that is why answer is B. अर्पित, मोनिका, आकिब, शिमू, थोड़ा सा डिफिकल्ट था बट ये मेडिसिन है सो इट माइट बी डिफिकल्ट. सिंपल. आगे चले. ओके, मूविंग टू नेक्स्ट वन. 28-year-old female presented with recurrent optic neuritis of both eyes. Extensive transverse myelitis. I hope most of you have got the answer now. Visual acuity in the right eye 6/60, in the left eye 6/18. There is partial response to steroid. So when this type of question is coming to your brain, like optic neuritis, then two things will come in my brain. First is MS, multiple sclerosis. Second is neuromyelitis optica. Neurosyphilis, it can have myelitis-like feature, but again optic neuritis is unlikely. PCA stroke will have some neurological involvement, but again you will not see transverse myelitis, unlikely. This is SACD, इसको शॉर्ट में बोलते हैं SACD. So basically this will present with dementia. Visual acuity is not that affected, so answer will be neuromyelitis optica. And it is almost like MS. Here you will see anti-aquaporins 4 antibody and you will see some partial response with steroid. Differences आप MRI कराओगे, MRI में MS में क्या आएगा? Patchy demyelination, we call that Dawson fingers. Here MRI is more, in most cases will be normal. यहाँ पर MRI normal आएगा. Simple. अर्पित, मोनिका, एम आई ऑडिबल? सब कुछ आ रही है आवाज? कुछ आंसर नहीं आ रहे तुम्हारे? ज़्यादा टफ हो गया क्या? ओके, आगे चलते हैं. 51-year-old मैन प्रेजेंटेड विद प्रोग्रेसिव डिमेंशिया मायोक्लोनस. डिमेंशिया हो रहा है, मायोक्लोनस एंड साइकेट्रिकल सिम्टम्स. स्पॉन्जियोसिस ऑफ न्यूरॉन्स फाउंड. Spongiosis of neurons कहाँ मिलती है? You need to understand pathology here. So it is seen in CJD, Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease is a prion disease. So below you know the diagnosis. So they are asking you what is the EEG finding. आपको EEG में क्या दिख रहा है? अब मुझे बताओ what EEG changes you will see in CJD. क्या मिलता है EEG में changes? क्या दिखता है बताओ? In CJD, in EEG you will see these waves. So बीच में जो sharp waves आ रही हैं, in between you can see these sharp waves are coming. So इनका नाम ही ऐसे ही पड़ा हुआ है. What we call them? We call them periodic sharp waves. Periodic sharp waves. So just remember, these are periodic sharp waves, and these are seen where? In a patient with CGD. So again, let me see hepatic encephalopathy. Hepatic encephalopathy, you will see these waves, इनको हम बोलते हैं triphasic waves. Now see NICT paper में ये बार-बार क्वेश्चन पूछते हैं. It's a repeat question, EEG finding. Cruz Jacob, I just told you, like periodic sharp wave. Generalized tonic-clonic seizures. So understand, in GTCS, what you will see like spike, different types of generalized spikes you can notice. So again, that is not classical, but यहाँ पर कुछ खास मिलता है आपको. ये लास्ट ईयर भी पूछा गया था क्वेश्चन. You will see here periodic lateral epileptiform discharge. Periodic lateralized epileptiform discharge. So let us see what you can notice here. You can see this is like phase 1, phase 2, phase 3. So this is phase 1. Let me you can notice here, this is phase 1 जो नीचे जा रहा है. Then we have phase 2, and then what we have phase 3. So this pattern with a lag, एक lag आ रहा है साथ में. This pattern with a lag is what we call. So let me just show you here, phase 1, then we have phase 2 and phase 3. This is what we call this as, anyone? Triphasic wave. Triphasic wave, and it is seen in metabolic encephalopathy. Means या तो पेशेंट का लीवर खराब होने के बाद मीन्स हेपैटिक एंसेफेलोपैथी और यूरेमिक एंसेफेलोपैथी, दोनों में क्या मिलेंगे आपको? ट्राइफेजिक वेव. Now can you comment on this type of EEG? What you can see here? At the end you can see this pattern. What we call this PLED, periodic lateralized epileptiform discharge, and this is something that we see in hepatic encephalopathy. This is something which we see in a patient with herpes encephalitis. Herpes. Okay, what you can see here? इसमें क्या दिख रहा है आपको? What you can see here? You can see this is total like generalized discharge. Right? This generalized discharge, what we see in a patient of GTCS. And here you can see this pattern, like sometimes you can see spikes, and this downward depression is dome. We call it spike and dome pattern. And spike and dome or spike wave pattern, this is something which we see in absence seizure or petit mal epilepsy. Absence or petit mal. Okay, following statement are true regarding ATP7B gene mutation. So ATP7B gene mutation is Wilson disease. It is seen in all patients with neurological involvement. So Wilson disease का नाम क्या होता है? हेपाटोलेंटिकुलर. लेंटिकुलर का मतलब होता है लेंटिकुलर न्यूक्लियस. ये बच्चे गलत समझते हैं, लेंटिकुलर को आँख का लेंस समझ लेते हैं. It is not lens of eye, lenticular nucleus of brain. So patient will have neurological involvement. True. ATP7A होता है मेनके में, 7B नहीं होता. 7B is in Wilson. It resolves with desferrioxamine. Desferrioxamine is chelating agent for iron. So desferrioxamine हम देंगे हीमोक्रोमेटोसिस में. यहाँ पर तो क्या देना है? D penicillamine, zinc, triantine, tetrathiomolybdate. So C, this is desferrioxamine is treatment for hemochromatosis. Seen in all patient with hepatic involvement. No. हर पेशेंट के अंदर नहीं होता. KF ring is seen in superior and inferior pole of descendant membrane. True. KF ring आपको superior और inferior pole में मिलती है, और कहाँ मिलेगी वो? Descendant membrane में मिलेगी. Am I clear? So 1 and 5 are correct. So आंसर क्या होगा इस क्वेश्चन का? ऑप्शन B. Am I clear? हरिओम, मोनिका, आशीष, तुम्हारे मुझे मैसेज क्यों नहीं दिख रहा है लाइव चैट में? तुम कुछ चैट कर ही नहीं रहे हो क्या? मैं फिर से रिफ्रेश करूं इसको? टफ लग रहा है क्या पेपर? सिंपल तो है. अब मेडिसिन है, थोड़े बहुत कुछ तो टफ आएंगे ना यार. राइट? ओके, अच्छा अभी मैं देख रहा हूँ तुम्हारे मैसेज, तब से कुछ हैंग हो गया था ये. अरे इतने सारे बच्चे आंसर कर रहे थे, मुझे पता नहीं चला था. मुझे लगा सबको टफ लग रहा है पेपर. यस, क्वेश्चन आर बिट ट्रिकी. ओके, आई एम सॉरी, मेरे को यहाँ हैंग हो गया था, मुझे पता नहीं, समझ में नहीं आ रहा था. ओके, वेरी गुड. कम ऑन, मूविंग टू नेक्स्ट वन. अब करो आंसर. A 25-year-old female came to medicine OPD, young female, with recurrent oral and genital ulcer. She said that few days back she had iridocyclitis which extended very quickly to another eye. एक आंख से दूसरी आंख में चली गई. She was complaining of pain in joint. What is the most likely diagnosis? तो पहले मुझे डायग्नोस बताओ. अर्पित, मोनिका, टेल मी द डायग्नोसिस. व्हाट डू यू थिंक? क्या है ये? तुम्हारे हिसाब से क्या होना चाहिए? व्हाट डू यू थिंक इट कैन बी? व्हाट डू यू थिंक इट कैन बी? क्या हो सकता है? मैं आपको हिंट दे रहा हूँ. यस, इट इज़ बेसर डिजीज. सो यू कैन सी पेशेंट को क्या हो रहा है. फर्स्ट थिंग इज रिकरेंट ओरल अल्सर्स, राइट. सो पेशेंट को रिकरेंट ओरल अल्सर्स हो रहे हैं. कैसे, क्या बोलते हैं उनको? एप्थस अल्सर्स. व्हाट एल्स? रिकरेंट ओरल अल्सर्स. दिस इज मस्ट टू मेक अ डायग्नोसिस. इसके अलावा एनी टू फ्रॉम दिस लिस्ट जो मैं अब लिख रहा हूँ 2, 3, 4, इसमें से कोई 2 होने चाहिए. क्या क्या? सो दिस ओरल अल्सर इज मस्ट, तो इसको तो ऊपर लिख दिया हमने. रिकरेंट जेनाइटल अल्सर्स, राइट. देन यू कैन सी लाइक आई इन्वॉल्वमेंट. एम आई क्लियर? और आई इन्वॉल्वमेंट अगर नहीं होगी देन यू कैन सी सम स्किन चेंजेस and a positive pathology test. So recurrent oral ulcers plus 2, 3, 4 में से कोई 2. Clear? In this case, how we make a diagnosis? We call this Behcet syndrome. Behcet syndrome का दूसरा नाम क्या होता है? Silk road or Silk road disease. Simple. So Silk road disease is also another name of Behcet syndrome. ये मैंने आई थिंक क्लास में बताया था और नोट्स में भी लिखा था. हमने बस सिल्क रूट लिख लिया था, यहाँ पर सिल्क रोड दे दिया. सो आंसर इज सिंपल, इट्स बेसर डिजीज. सिंपल. ओके, मूविंग टू नेक्स्ट वन. बताओ, ये तो इजी है. व्हाट यू कैन सी इन दिस ईसीजी. ओके, लेट्स सी द क्वेश्चन. 45-year-old मेल हु वाज हीमोडायनेमिक अनस्टेबल है ड्यू टू ब्रेडिकार्डिया हो रहा है. ऑन एग्जामिनेशन ही वाज इन अ स्टेट ऑफ डायबिटिक कीटोएसिडोसिस. सो डीके का पेशेंट है. अब देखो, whenever I see this question, I can say like DK के पेशेंट में जो इलेक्ट्रोलाइट abnormality which we see in DK is generally related to potassium. हमारा सो DK का पेशेंट के अंदर क्या होगा? या तो आप KCl ज़्यादा दे रहे हो, उसको ट्रीटमेंट में कई बार हाइपरकैलेमिया हो जाता है. समटाइम पेशेंट कैन डेवलप हाइपोकैलेमिया. सो DK पेशेंट कैन विल डेवलप इलेक्ट्रोलाइट abnormality related to potassium mostly. Sometimes they can also develop abnormality related to sodium. कैल्शियम अनलाइकली होता है, तो कैल्शियम तो मैं हटा ही देता हूँ मैं. और कैल्शियम, रिमेंबर, कैल्शियम विल हैव सम चेंजेस इन द QT. क्लियर? सो नाउ आंसर इज आइदर हाइपोकैलेमिया और हाइपरकैलेमिया. सो व्हाट यू कैन सी इन दिस ECG. ECG में आपको क्या दिख रहा है? व्हाट यू कैन सी? यू कैन सी अ ब्रॉड QRS, राइट. ब्रॉड QRS, राइट. व्हाट एल्स? और कुछ दिख रहा है? कम ऑन, बताओ. P वेव थोड़ी सी गायब दिख रही है. सो नो P वेव. You can see a broad QRS. So I can assume like this patient potassium will be above 8. 8 से ऊपर है. And after like few I can say hours, after few hours or few minutes, he will have this type of pattern. इस pattern को हम बोलते हैं sine wave pattern. और अगर आपने ECG इससे पहले कराया होगा, then you can see ST elevation with tall T wave. So these are the changes. हाइपरकैलेमिया में क्या मिलेगा आपको? ST elevation, tall T waves, absent P wave, और P wave start disappearing. Then we can see broad QRS and ultimately we can see sine wave pattern, और ultimately पेशेंट को क्या हो जाएगा? डायस्टोलिक अरेस्ट. तो आंसर क्या होगा? हाइपरकैलेमिया. सिंपल. ओके, हाइपरकैलेमिया. एंड रिमेंबर कैल्शियम, इफ यू वांट टू रिमेंबर, कैल्शियम इज इनवर्सली प्रोपोर्शनल टू QT. सो अगर हाइपरकैल्सीमिया होगा तो QT शॉर्टनिंग, हाइपोकैल्सीमिया QT प्रोलॉन्गेशन. क्लियर? ओके, नेक्स्ट बताओ. 19-year-old मेल, 19-year-old मेल विथ नो मेडिकल हिस्ट्री, कोई पास हिस्ट्री नहीं है. वॉज बॉट टू इमरजेंसी विथ ओलिगोरिया. ओलिगोरिया कब बोलते हैं? व्हेन यूरिन आउटपुट इज लेस देन 400 ml. फटीग, एडिमा इन लोअर लिम्ब. क्रेटिनिन लेवल्स ऑफ 11.2 बढ़ गई. क्रेटिनिन मीन्स I can say patient is having some disease. Patient को कुछ disease है and with that disease he is developing AKI. So just I can say ही इज हैविंग अ क्वेश्चन मार्क डिजीज। देखो मैं अपने मन में डायग्नोस बना रहा हूँ, सेम थिंग यू हैव टू डू, एंड पेशेंट इज डेवलपिंग AKI विच शोज पेशेंट वॉज एन एक्यूट रेनल फेलियर। AKI को क्या बोलते हैं? ARF। देखो अब आगे दे भी दिया, बट लेकिन आपको सोचते चलना है, कई बार MCQ में नहीं दिया होगा तो क्या करोगे आप? सो यू हैव टू रिमेंबर दिस। ऑन चेस्ट एक्सरे देर आर कंसोलिडेशन, मीन्स कंसोलिडेशन था एक्सरे में, प्लस यू कैन सी diffuse infiltrate, diffuse infiltrate. So these are the hints. Means I can say there is a disease which was affecting lung, that disease now transform into kidney disease. So उसको हम बोलते हैं pulmonary renal syndrome. PSGN में लंग का इन्वॉल्वमेंट नहीं होता, पोस्ट स्ट्रेप्टोकोकल ग्लोमेरुलर नेफ्राइटिस, और ये अपने आप ठीक हो जाती है। IG नेफ्रोपैथी, अगेन हियर यू विल सी हेमाचूरिया होगा, लेकिन अगेन लंग का इन्वॉल्वमेंट नहीं होगा। अब आपके पास बचे दो ऑप्शन, वैगनस और गुड पास्चर, बी और सी, दोनों में होता है। कैसे डिफरेंशिएट करते हैं? आके मोनिका, शिमू, अर्पित, आशीष, मैंने बताया था क्लास में हाउ यू विल डिफरेंशिएट, दोनों को कैसे डिफरेंशिएट करोगे, गुड पास्चर और वैगनर्स को। गुड पास्चर, वैगनर्स, बोथ विल हैव pulmonary renal involvement. So in good pasture syndrome you will see lower respiratory tract, means bronchioles, terminal bronchioles, ये सब involve होगा। In vagus you will see upper respiratory tract and lower respiratory tract दोनों involve होंगे, means no sinus, ये किस में involve होंगे? vagus में। Then both will have kidney involvement। अब आपको देखना है, now you need to see question में no sinus का involvement है कहीं पर? मोनिका देखो एक बार, नोज साइनस का इन्वॉल्वमेंट है या नहीं? कैन यू सी एनी इन्वॉल्वमेंट ऑफ नोज और साइनस? यस आशीष, वेरी गुड। वैगनर में कैविटेशन होंगे, लेकिन यहां पर क्या दिया है? कॉन्सोलिडेशन, डिफ्यूज इनफिल्ट्रेट। अगर देखो कैविटेशन भी आप नहीं देख रहे हो, यहाँ यू कैन सी देयर इज नो साइंस, पूरे क्वेश्चन में कहीं पर मेंशन नहीं है साइनोसाइटिस और नेजल पॉलिप और रिनाइटिस और राइनोरिया और नोज ब्लीडिंग और सैडल नोज, ऐसा कुछ मेंशन नहीं है। मीन्स अपर रेस्पिरेटरी ट्रैक्ट इज स्पेयर्ड, दिस इज व्हाई वैगनर्स इज नॉट द आंसर। सो आंसर क्या होगा इसका? गुड पास्चर सिंड्रोम। क्लियर? समझ आ गया? एम आई क्लियर गाइस? ओके, मूविंग टू नेक्स्ट वन। फॉलोइंग स्टेटमेंट is or are true about RTA type 2. RTA is renal tubular acidosis type 2. So let us see this option one by one. RTA type 2, is it a PCT defect? This is correct or not? PCT का defect होता है तो correct. So let me write it right here, T4 true. So ये तो correct है. Nephrocalcinosis stone formation RTA type 2 में नहीं होता, तो ये भी एक correct statement है. RTA रीनल ट्यूबुलर एसिडोसिस, एसिड बन रहा है तो आप सोडा बाइकार्ब दोगे, तो ये भी सही बात है, देंगे। अब या तो PCT का डिफेक्ट होगा या DCT का डिफेक्ट होगा, तो DCT का डिफेक्ट तो ही नहीं है, तो ये एक फॉल्स स्टेटमेंट है। सो 1 2 3 दीज आर करेक्ट, सो आंसर विल बी रीनल ट्यूबुलर एसिडोसिस। ओके, सो जस्ट आई एम ट्राइंग टू समराइज दिस। वी कैन हैव टाइप 1, टाइप 2, टाइप 4। टाइप 4, तो आंसर क्या होगा इसका? 1 2 3। क्लियर? आंसर विल बी बी। ओके, अब इसको देखो, टाइप 4 को हम बोलते हैं हाइपरकैलेमिक टाइप, एंड टाइप 1 एंड 2 दीज आर कॉल्ड हाइपोकैलेमिक टाइप। टाइप 2 में आपको PCT का डिफेक्ट दिखेगा, टाइप 1 में DCT का डिफेक्ट, राइट? देन ट्राई टू अंडरस्टैंड दिस स्टोन फॉर्मेशन। स्टोन फॉर्मेशन, यू विल सी स्टोन फॉर्मेशन ओनली इन टाइप 1। अब सोडा बाइकार्ब आपको सब में देना है। सोडा बाइकार्ब के साथ अगर आप थायजाइड दोगे, दैट इज गिवन इन टाइप 2। हियर यू कैन सी ऑलरेडी पेशेंट हैविंग लेस पोटेशियम, तो आपको क्या देना है? पोटेशियम रिच डाइट, तो यहाँ पर पोटेशियम नहीं देना है। इनफैक्ट यू हैव टू यूज आई कैन से डायूरेटिक्स टू गेट रिड ऑफ दिस एक्सेस पोटेशियम, बिकॉज पोटेशियम पहले से बढ़ा हुआ है। सो ये RTA से क्वेश्चन बार बार आता है, सो दिस समथिंग यू हैव टू रिमेंबर, डिफरेंट टाइप्स ऑफ RTA। क्लियर? ओके, मूविंग टू नेक्स्ट वन। Which of the following condition will not give a negative methacholine test? Okay, first try to understand this thing. What is this methacholine? So आजकल इस टेस्ट को हम करते नहीं है, पहले करते थे. So basically it is like a provocative test. So where we can see diagnose asthma by seeing the value of FEV1 and by seeing the bronchospasm which can occur due to this. So, sometime if any patient who is taking steroid or any patient who is taking I can say LABA, long acting. So, आजकल तो V LABA भी आ गए, very long acting beta agonist like indacaterol, oladaterol, these are V LABA. LABA आपका क्या था, salmeterol. Or a patient taking leukotrienes inhibitor. Leukotrienes inhibitor means it could be montelukast, zafirlukast, right? Or LOX inhibitor. LOX inhibitor means 5-LOX inhibitor, that is your Xylitol. So, अगर पेशेंट स्टीरॉयड पे है लंबे समय से, whether they are IV और ओरल स्टीरॉयड, किसी भी तरीके के स्टीरॉयड और इनहेल्ड कॉर्टिकोस्टीरॉयड, लाबा वी लाबा ले रहा है, ल्यूकोट्राइन्स इनहिबिटर उसको चल रहा है, मोंटेलुकास चल रहा है, in that case you will notice like they can give a negative methacholine test. Which question आपसे पूछा which of the following will not give. So short acting जो beta agonist होते हैं उनका action थोड़े time का होता है, that's a very brief action. So here you will not see negative result. Clear? So answer will be A. Diksha, any doubt? Hyperkalemia? Yes. So answer क्या होगा इसमें? A. Mast cell stabilizer. अब one more. Mast cell stabilizer को हम आजकल use नहीं करते, like nidocromil, sodium chromoglycate. So these are also drugs. So one more thing I can add, patient on mast cell stabilizer. They will also give negative methacholine test. Clear? Okay, moving to next one. Following monoclonal antibody act against IL-5. So इसको हम देखो, इसको फार्माकोलॉजी से डिकोड करते हैं इस क्वेश्चन को. So if you see refractory asthma में क्या देते हैं, omalizumab. So omalizumab mechanism of action will be anti, yes, very good, IgE. Antibodies against IgE. Mepolizumab, resilizumab, these are basically against anti-interleukin 5. Dupilumab is anti-interleukin 4. अब बच्चा tezepelumab, इसको समझो एक बार. This is a new drug and this is expected question, right? So remember, this is like basically an antibody which is targeting a particular cytokine. So this is, understand, it is called anti-thymic stromal lymphopoietin. इसके अगेंस्ट में बेसिकली व्हाट इट इज अ साइटोकाइन. इस साइटोकाइन के अगेंस्ट में देयर आर सम रिसर्चेस एंड दिस ड्रग इज नाउ WHO अप्रूव्ड. लाइक अस्थमा इन रिफ्रैक्टरी केसेस, कई बार पेशेंट का इंटरल्यूकिन्स आप देखोगे IG दे आर नॉर्मल, स्टिल दे डेवलप अस्थमा अटैक. सो दैट इज बिकॉज इन देयर बॉडी देयर इज स्टिमुलेशन ऑफ दिस thymic stromal lymphopoietin. So you have to inhibit this cytokine. So that drug is tezepelumab. So अब हमारे क्वेश्चन पे आ जाते हैं. They are asking you anti IL-5. So answer will be 2 and 3. 2 and 3 का दिया B. Clear? Is clear? Simple है. So these are all antibodies which we use to treat asthma. सब किसके लिए? अस्थमा के लिए. Okay, moving to next question. मेरे पास 17 क्वेश्चन है. जरा अब मुझे बताओ आपके पेपर में कौन सा क्वेश्चन था 17th पे. I think this was in your question. This was, यही था. आकिब, आशीष, एक बार बता दो मुझे. This was the question. आशीष, आकिब, अर्पित, मोनिका. Try to answer. I know some of you, तुमने खाना भी नहीं खाया है फिर भी अभी पढ़ रहे हो इतना. That is something which is needed for a society. यही तो बाकियों से अलग बनाएगा तुम्हें. And be different to make the difference. फिर हैंग हो गया क्या ये? ओके, तो बताओ मुझे. This was a question. 15-year-old white female present to OPD with complaint of numbness in both legs which started 1 day ago. Right? She has recently recovered from URI. URI means upper respiratory infection about 10 days ago. 10 दिन पहले. Additionally, she also complained of mild weakness in her proximal muscles. what is true about her condition. अब अगर आपने diagnose बना लिया, yes Ashish, very good, if you make a diagnosis it is clear. So it's a case of GBS. So basically patient को क्या है ये, you can see GBS में क्या होता है, या तो patient को gastroenteritis की history होगी या कोई respiratory tract का infection होगा, उससे 1-2 हफ्ते बाद क्या होगा, myopathy, muscle weakness, right? So that is simple telling you like patient is developing ascending muscle weakness that is preceded after upper respiratory tract infection और gastroenteritis. So या तो patient को campylobacter का infection है और GBS के variant होते हैं. So we have acute variant and we have chronic variant. So अब आप देख रहे हो like it is coming in less than 8 weeks. So 2 हफ्ते 10 दिन की बात है. So that is acute. अगर something which is occurring less than 8 weeks, so acute में form क्या होते हैं, AIDP. Then we have acute motor axonal neuropathy, मेरे नाम से ये. Then we have acute motor sensory axonal neuropathy, and what we have Miller-Fisher syndrome. Miller-Fisher syndrome. So these are 4 variant in acute. Chronic में एक ही variant आपको याद करना है, that is called CIDP. So basically ये GBS का case है, simple. अब let's see the option. Now understand, अगर acute case है, in acute cases, what is the treatment? In acute cases, what you will give? आपको patient को admit करना है, आपको पेशेंट को IVIG देनी है और आपको प्लाज्मा एक्सचेंज, इन शॉर्ट आई एम राइटिंग प्लेक्स. इन क्रोनिक केस व्हाट वी हैव टू गिव, क्रोनिक में आपको पेशेंट को स्टेरॉइड देना है बिकॉज एक्यूट इज लाइफ थ्रेटनिंग. तो लेट अस सी द ऑप्शन वन बाय वन. इट इज ओनली वायरल इन ओरिजिन, नो इट कैन बी बैक्टीरियल. कैम्पेलोबैक्टर तो बैक्टीरिया होता है ना, एम आई राइट? देखो डी ऑप्शन इसलिए गलत लग रहा है, क्यों? बिकॉज मोस्ट कॉमन कॉज ऑफ GBS in United States it is Campylobacter jejuni. Even in India, it is mainly after bacterial infection like Salmonella, Shigella. So only viral तो नहीं होता. और she should be sent home and advised to rest and drink plenty of fluid. आप उसको घर तो नहीं भेजोगे, अब उसको मायोपैथी हो रही है, right? Consist of symptom which wax and wane over time. CIDP होता तो ये आंसर हो सकता, because CIDP is chronic. But again, a total waxing waning is not seen. It involves degeneration of anterior horn cell. No. So it requires treatment with IVIG and plasmapheresis. So answer will be A. Very good, Akib. So this is about the last question. I hope you enjoyed this. So थोड़े से tricky होते हैं question, but again this is like to refresh your knowledge. So I hope now you can take a break, have a cup of tea, and those who want to sleep, those now they can sleep. And remember, just ऐसे ही पढ़ते रहना है बस कुछ दिन और. Right? And remember, difficult roads often lead to beautiful destinations. So with this, we'll conclude. Thank you so much. Keep working hard. Bye-bye.
So welcome all, welcome to this anatomy discussion of CBoT 6 with me Dr. Ankit, your anatomy faculty. So here's the first question. The question asks that keratinized, okay, so look at the question carefully. It is asking keratinized stratified squamous epithelium is not present in which of the following. So basically you should know keratinized or stratified keratinized squamous epithelium is present where. First of all, let's understand this particular epithelium. It has to be stratified squamous, so it has to be what? It has to be multi-layered. First thing, superficial cells or superficial layer of cells have to be squamous and they need to be covered by keratin. Now, what is the function of this type of epithelium? Obviously, it is to provide protection, to provide this body's defense against friction. And keratin is basically where it is on the surface because you prevent the desiccation from the contact with the air. Right? This is the functional histology of this particular type of epithelium. Now, where it would be present, most commonly it is present around the areas of the skin and structures which are very close to the skin. Right? So, let us see where it would be present. Now, first option is skin, obviously it would be present. Tonsil, see, tonsil, it is, we're talking about the tonsil which is present on the pharynx, the oropharynx part. Here, there will be stratified squamous, but it will be non-keratinized. I will show you the epithelium. Cornea, again, cornea is actually covering the environment, so we think it should be keratin, but here the light is have to pass. And it is all the time kept moist by continuous blinking of the eyes, right? We continuously blink our eye like this after every few seconds. Again, it will be non-keratinized. Membranous urethra is a part of the posterior urethra. There is no point over here of getting stratified squamous keratinized. It is sort of columnar epithelium. So it is basically columnous trachea. Is a part of the upper respiratory tract. Here it will be a respiratory epithelium, that is our pseudo-stratified ciliated columnar epithelium. Bronchus, again, there will be there's a respiratory epithelium sort of similar. Uterus will again have columnar epithelium. Bowman's capsule, it has actually the squamous epithelium. Right, it has the squamous epithelium because it is just inside the, you can say the glomerulus. Then tongue over here, or tongue again, the anterior part of the tongue is very close to the surface. So here it will be stratified squamous, but parakeratinized, or we can call it as keratinized as well. So skin we have, tongue we have. Esophagus again will have stratified squamous, but again non-keratinized. So we can see it is present only in 1 and 9. So it will be absent in the remaining. So if you look at the options, option number E over here, 2, 3, 4, 5, 6, 7, 8 and 10. Because it is present only in 1 and 9, so we have to identify where it is not present. So not answer will be option number E over here. Now let us see some images. On this logical slide, you can see over here that this particular part, this is your stratified squamous epithelium. And here you have this multi-layered or thickened keratin. This is a slide taken up from the thick skin. Okay. Next slide over here, what you are seeing is a tongue part, right? This is a slide from the tongue. These are the fungiform papillae. These are the fungiform papillae. And these are the filiform papillae. These are the filiform papillae. Now, in the anterior part of the tongue, obviously it is the stratified squamous epithelium, but here you can see some part of keratinization being done. Therefore, we say that skin and tongue we have this stratified squamous keratinized epithelium. Next slide, if you look, this is a slide taken up from the trachea, right? You can see, identify this by this hyaline cartilage over here. But if you look at the epithelium over here, if you look at the epithelium, this epithelium is which variety? It is of pseudo-stratified ciliated columnar. That is also what is regarded as a respiratory epithelium. Okay. Next slide, if you see, this slide is taken up from the bronchus or the small bronchus over here, because you can see the cartilages are now being scattered into some plates. Here again the epithelium will be the respiratory epithelium, pseudo-stratified ciliated columnar epithelium. Next slide over here is a slide of the tonsils. Slide of tonsil. Now, what will be the, how to identify? You can see various lymphatic nodules over here. The E for epithelium over here, this is stratified squamous, but it is non-keratinized, right? It is in the oropharynx. Next, this slide, to avoid confusion, to remove the confusion, we have the slide over here of the cornea. This is a zoomed in image, that is a normal image. This is the EP for epithelium. You can see it's stratified squamous, but non-keratinized, right? And there's always tears around it to prevent the desiccation from the air. Okay, so these are the few slides. Now let us come to the next question. The questions ask us that 32-year-old male patient presents to the ENT clinic with complaints of sweating over the jaw region at the time of taking his meals. Sweating at the time of taking the meals around the region of the jaw. This particular line will tell you if we are dealing with which syndrome. We are dealing with the Fraze syndrome, also known as auriculotemporal syndrome. Let's see more of it. The patient was clinically examined and evaluated, and all relevant investigations were done, but the clinician was still unable to rule out the cause. Every investigation was normal. On further asking about any previous surgery done, now listen carefully, the patient found to have undergone 2 recent surgeries in the past. First option, he had a cholecystectomy, and second option, he had a paroidectomy. Cholecystectomy, that is removal of the gallbladder, paroidectomy, removal of the parotid gland. Could be some small benign tumor. Now, which of the following surgeries is the contributory cause, and what is the anatomical basis for the same respectively? Now, we all know that we are dealing with the Fraze syndrome, auriculotemporal syndrome, also known as what? Another name for this is gustatory sweating. Gustatory sweating, that is whenever the patient tries to take meal, he starts to sweat. This is known as gustatory sweating.
Operation which is responsible for this is actually parotidiectomy, so we will look for option number 2. And injury is actually to the auriculotemporal nerve. So the answer over here will be option number D over here will be the answer. Why this injury to this nerve? Because when we do a parotidiectomy, we obviously have to cut the skin. And when you suture it back, then there is cross connection between the auriculotemporal nerve and the great auricular nerve. What these are doing, understand. Great auricular nerve is a sensory nerve at this particular area. And the auriculotemporal nerve is a nerve which is postganglionic and that goes inside the parotid gland. So this nerve has a role in secretion of the saliva from the parotid gland. Well, great auricular nerve is a sensory nerve, so it has a role of sympathetics. Now, if they cross connect, the moment the patient takes food, his auriculotemporal nerve will try to stimulate the parotid gland for secretion. In the meantime, this nerve is also stimulated for sympathetic stimulation, that is the sweating part. That is why this is what we call it as the Frey syndrome. Now, let me show you some images over here. This is a cadaveric image on the side view of the head. And here we have this is what is the parotid gland. You can see how superficially it is located, covered by the skin fascia and also part of the deep fascia. Now, if you look at this particular image, here we are trying to show you the sensory supply of the face. Now, here focus on this particular area. Which nerve is this? This is the great auricular nerve. But where was auriculotemporal? It was actually going supply deep inside the parotid. An auriculotemporal nerve is actually a branch of which nerve? It is a branch of the mandibular nerve. Let me show you next image, the auriculotemporal nerve as well. Auriculotemporal nerve has two things. See, first of all, it will go and supply the parotid gland, the postganglionic secretory. And then being sensory also, it will go and supply the auricle and the temporal region. See, this nerve is going where? Into this auricle and the temporal region. And then this nerve and this nerve, they have cross connection after doing a parotid surgery. Because in parotid surgery, we have to encounter the great auricular nerve, we have to encounter the auriculotemporal nerve as well. There is a cross connection. Fine. So remember this question was basically on the Frey syndrome. That do you know, the examiner wants to check whether you know about this famous syndrome, Frey syndrome, also known as gustatory sweating. Fair enough. Let's see the next one. A fairly straightforward previous year question. Which of the following parts of the brachial plexus doesn't have any branches? Now, what are the various parts of brachial plexus? We have roots, we have trunks, we have divisions, we have cords, and finally we have various branches coming from the cords. This can also be remembered by right to drink chilled beer, right? So there is a mnemonic you can remember, right to drink, C for chilled beer, right? This is the mnemonic over here. Now, if you look at the inside anatomy of the brachial plexus, the roots do give branches. The trunk do give branches. Remember that the branches on the root and the trunk are known as supraclavicular branches because they are lying above the clavicle. The cords obviously are giving branches. They are known as infraclavicular branches. Which does not give branches is the answer over here, straightforward. It is a division. So, though the name is division, but they are referring to the ventral and dorsal divisions. They don't itself give any branches. They join to form cords. So, answer over here will be the division. Now, let us look at the image of the brachial plexus. This is the root, trunk, division, cords and their branches. You can see the branches from the roots, if I may put it like dorsal scapular nerve and the long thoracic nerve. Now, look at the branches from the trunk, basically the upper trunk with the suprascapular nerve to subclavius. And then if you want to see, these are all the branches, these are the main terminal branches from the cords. But division over here, the division over here, it gives off no branches, remember. And where does it lie? It lies just behind the clavicle. Just behind the clavicle. It is also known as retroclavicular part. Retroclavicular part. Okay, so PYQ important one. Let's see one more question. Again, a question from the upper limb. Let us see the question. 5-year-old boy presents to the orthopedician, 5-year-old boy only, with pain in the elbow region. Toddler with a pain in elbow. According to the mother, the boy fell on an outstretched hand on the ground. Boy fell on the ground while playing. Clinician suspected a supracondylar fracture of the humerus. Already diagnosis made. Most common fractures in toddlers. And to assess the severity of the fracture and confirm clinical diagnosis, an X-ray of the arm and forearm was done, obviously. The patient was applied a POP cast and sent back home. Fair enough. Which of the following, now here's a question, which of the following is the most common nerve affected in supracondylar fracture of the humerus? This should be very clear. And what is the most common late complication respectively? It's a combined question of anatomy and orthopedics. Now we should be knowing very clearly that the most common nerve affected in supracondylar fracture, we can remember it by the mnemonic AMRU. What is A over here? A is the most commonly affected, that is the anterior interosseous nerve. See now two options, B and D. After A comes the M for median nerve. So we have the anterior interosseous, median, we have the radial nerve, and finally we have the ulnar nerve. So all these nerves can be injured. But going from most common to least common. So we know, okay, anterior interosseous nerve could be damaged. Then the second part of the question is, what is the most common late complication? Late complication out of non-malunion is the malunion. Malunion means that the union will occur, but it will not be properly aligned. That's the whole case, and could give rise to the anomalies, the deformities are known as cubitus varus. Let me show you this. First of all, let me show you the anatomical part over here. This is the anatomical part around the elbow region. Here you can see a few nerves, if I may highlight them. Here what you're seeing is the median nerve. Here what you're seeing is the ulnar nerve going behind the epicondyle. On the lateral side, you also see the radial nerve, right? But where is the anterior interosseous nerve? The anterior interosseous nerve is actually nothing but a branch of the median nerve, that is anterior interosseous nerve. The point over here, let me tell you one important extra point. When there is a supracondylar fracture of the humerus, suppose this is the humerus over here, and when there is a supracondylar fracture of the humerus, here you can imagine, if I may show with some different, or this is yellow color only, imagine this is the median nerve coming down. In supracondylar fracture, it is basically the median nerve which is located over here. And what actually happens is, this median nerve, as it comes down here, it will give off a branch below the elbow region. This is the anterior interosseous nerve. And the question comes, why AIN is most commonly injured? The point over here is that AIN is a very thin nerve coming off from the median nerve. In supracondylar fractures, what actually happens is, as there is a fracture in this area, so this median nerve is being pulled up or pulled in the direction of the fracture. Now this area is sort of fixed area, therefore it breaks from this area. AIN is break from this area. That is the reason. Right, so this is the reason why AIN is most commonly injured. Then comes median, then radial, because they are anteriorly, and then comes the finally ulnar nerve that goes behind the middle epicondyle. That's an anatomical part. This is a late complication part. You can see the cubitus varus deformity here. It's a late complication when there is malunion. When there is malunion. Okay, so that part. Next question again from the upper limb is, which rotator cuff muscle is not attached to the greater tubercle of the humerus? If you look at the humerus over here, then this is, imagine the upper end of the humerus having this head of the humerus, right? And it goes down, this whole shaft over here, then below we have the two condyles. The greater tubercle of the humerus present superiorly, and it goes posterior aspect as well. The lesser tubercle of the humerus present anteriorly. Now rotator cuff muscles, we all should be knowing that rotator cuff muscles, we can remember it by the mnemonic SI small t and S. This S is your supraspinatus, infraspinatus, tibialis minor, subscapula. You can see all the four names. Out of this, in the lesser tubercle, only one muscle is attached, that is subscapularis. Therefore, this will be our best possible answer over here, option number A. While do these three nerves, yes, these three muscles, SINT, supraspinatus, infraspinatus, and tibialis minor, they all attach onto the greater tubercle. So these three will attach to the greater tubercle, and the subscapularis will go attached to the lesser tubercle. Let me show you a simpler image over here. With the help of a hand, they are showing over here the subscapularis being attached to the lesser tubercle. While all these three muscles, supraspinatus, infraspinatus, and tibialis minor, they are coming and attaching to the greater tubercle. These are the four muscles of rotator cuff, the musculotendinous cuff. Next question, again image-based question from the neuroanatomy. Which of the following is not involved in the formation of circle of Willis? Now, circle of Willis is actually a misnomer. It is not exactly a circle, sort of hexagon. Here the image is also being given. We should be knowing about this image. Let me clarify this over here. The arterial supply of the brain comes from two sets of arteries. One is this vertebral artery coming from the foramen magnum, and one is this internal carotid artery coming from the carotid canal. That's it. This area, if I may highlight, this is what is known as a circle of Willis, COW. Here what happens is the branches from the vertebral system of artery, it anastomoses with the branches of the carotid system of artery. Let us label few arteries over here. This is vertebral artery, this will be the basilar artery, and this is the final branch of basilar known as posterior cerebral artery. The internal carotid will give the lateral most direct continuation of the internal carotid. This number 4 is the middle cerebral artery. It is going laterally outside. It passes through the lateral sulcus, supplies the superolateral aspect of the cerebral hemisphere. This number 1 vessel over here is the anterior cerebral artery. And both anterior cerebral artery are joined by number 2, which is known as anterior communicating artery. And finally, number 3 is again a branch of the ICA. This is known as a posterior communicating artery, PCOM or posterior communicating artery. So if you realize over here, you will see that this number, this whole artery which I am trying to highlight with this blue color, this is the circle of Willis. You can see the contributions are coming from artery number 1, artery number 2, artery number 3, and also the posterior cerebral artery. But there is no communication, direct communication or direct involvement of the middle cerebral artery into the circle of Willis, COW, circle of Willis. As MC was marked number 4, we would go with the answer being our number 4 over here. So number 4 does not directly contribute to this circle of Willis. Let me show you this labeled image over here as well. This is what is the labeled image, and let me again highlight these few circle of Willis arteries communicating. You can see anterior cerebral, you can see posterior communicating, you can see, and posterior cerebral. These are the 4 major arteries involved in circle of Willis. And this was our middle cerebral artery that is going laterally out, not involved directly in the circle of Willis. To supplement to this, we have this cadaveric image as well, just to be sure, okay, this is what actually happens. This is the inferior view of the brain. Now let me just enlarge it a bit more, and let us see over here what actually happens. See, this over here is the internal carotid artery. Okay, just a second, let me just decrease the size of it. Just a second. Yes, this over here is the internal carotid artery. The lateral going branch over here is the middle cerebral artery. This was labeled as anterior cerebral, and if you can visualize the small artery over here, this is ACOM, right? And finally, this is PCOM, posterior communicating artery. This will be the B for the basilar artery, and that is its branch, that is posterior cerebral artery. So you can very well see all these branches which are contributing to the circle of Willis part. These are all contributing to the circle of Willis part, right? So do remember that. What are the various arteries that participate in circle of Willis part? Okay, fair enough. Let's see the next question over here. Fine. Which of the following is the branch or are the branches of the pterygopalatine part of the maxillary artery? Now, maxillary artery itself is a very important topic. Maxillary artery, we should be knowing that maxillary artery over here is actually a branch from the external carotid artery. It is one of the largest branches, and it is divided into 3 parts. First of all, theory. It is the largest branch of external carotid artery, having 3 parts. In 3 parts, number 1 part, number 2 part, and number 3 part. Understand? Number 1 part will be more superficial. So it will supply what? Number 1 part actually rises behind the neck of the mandible. Then it goes medially. Number 1 part is going to supply the mandible. It is going to supply the ear part. It is going to supply the meninges part. Simple as that. Number 2 part passes through the masticatory muscles. And the other thing is that this whole maxillary artery, as we are saying, divided into 3 parts. It is actually divided by the pterygoid muscles, which are the masticatory muscles, into 3 parts. So number 1 part is supplying the outer areas. Number 2 part is going to supply the muscles, the masticatory muscles. And then the number 3 part actually goes inside into the pterygopalatine fossa. And this is what is known as the pterygopalatine part of the maxillary artery. It is lying most deep. Right? It is lying most deep. So even if you have no idea about the 3rd part, you should know that number 1 part is supplying the mandible, the ear, and the meninges, because they are lying more superficially, closer to the skin. Number 2 part supplying the muscles. Whatever is left is number 3 part. You'll see the image also. Here's the image. But first of all, let us make it how to approach how to easily answer the question. Now, If you look at the options, inferior alveolar artery, we can imagine it is supplying the mandible. Middle meningeal artery, it is supplying the meninges. Greater palatine artery is neither mandible, ear, meninges, nor it is masticatory muscle. We can put an arrow over here. Pharyngeal artery, again we can put an arrow. Muscular branches, it is must be coming from the second part, because second part we said muscles. Okay. Artery-pterygoid canal, you can put an arrow. Sphenopalatine artery, you can put an arrow. Deep auricle ear, again should be from the first part. The first part we said ear, mandible and meninges. Anterior tympanic again is ear, should be from the first part. Posterior superior alveolar artery, we can put an arrow. So wherever we have put an arrow on these 5 arteries, these are actually branches from the third part. So we have option number C, D, F, G and J. And here we have our answer. Simple as that. So if you remember the first and second part, automatically third part comes. And third part, these are all the major arteries. Whatever is left, we can see over here. So this is the, we can say that the artery over here, that is the maxillary artery. Now, how to understand this? If I put a highlighter over, this is the course of the maxillary artery. So this is the initial part, is the first part. You can see what are the branches coming up from the first part. Let me point out over here, this tympanic, auricular, middle meningeal, right? Then you have inferior alveolar and accessory meningeal artery. These green highlighted are branches from which part? These are branches from the first part. Now let us see about the second part. Second part, what we have, supplying the muscles. So deep temporal artery, okay. Then we have a buccal artery as well. Then we have what? We have mesenteric artery as well. These are supplying what? These are supplying the, these are coming from the second part. So if we can say this is supplying the second part. Now what are coming from the third part? Third part, let me put a red highlighter. Pharyngeal artery, arterio-pterygoid canal, sphenopalatine, infraorbital. Then we have posterior superior alveolar, we have greater palatine artery. These are all coming from which part? They are all coming from the third part, because we are going more deeper. This is the complete image, and here you can understand how to approach how to find out the answer. A very good topic. Another question, which of the following structures pass through the common tendinous ring of the superior orbital fissure? Okay, pass through the common tendinous ring of superior orbital fissure is what they are asking. So we should be knowing about the superior orbital fissure. It is present in the posterior aspect of the orbit. It is the largest fissure in the orbit. What passes over here? Here you have the motor nerves to the eye, they will pass. You also have the sensory nerve to the eye, that will pass. Okay. Then you have the veins, ophthalmic veins, that will pass. Sir, why not artery? Let me tell you that the ophthalmic artery and the main nerve of the eye, optic nerve over here, they have their own separate canal. Just a second. Yeah, ophthalmic artery and optic nerve's own separate canal known as the optic canal. So they pass from here. So here we have the motor, sensory and the veins over here. Now what is the motor nerve of the eye? 3, 4, 6. What is sensory nerve of the eye? Ophthalmic branch, right? We have over here the ophthalmic branch, V1. Ophthalmic branch itself has few other 3 branches we can remember as the lacrimal frontal nerve, and third one is nasociliary, and finally you have the ophthalmic vein. So the point over here is 3rd, 4th, 6th nerve, lacrimal frontal nasociliary nerve of the V1 and ophthalmic veins, they pass through superior orbital fissure. The question over here is one step more. What passes through the common tendinous ring? Let me show you the image over here. As you look at the image, this is the superior orbital fissure. Let me highlight it. This is our whole superior orbital fissure, right? And here, if I may highlight over here, this is the part that is the common tendinous ring. So on the lateral aspect of the superior orbital fissure, some other structures, but we have to focus over here. What is passing over here? Here we have both the branches of the third nerve, superior and the inferior branches of the third nerve. So we have third nerve. Between third nerve, we also have the 6th nerve, so subdistance nerve also passes, and most medial branch of the ophthalmic, that is the nasociliary. So these 3 structures, they pass through the common tendinous ring. Then sir, what passes through the lateral part? Lateral part, what we have is the lacrimal, frontal and trochlear. They pass on the lateral aspect. They are remembered by the mnemonic LFT. LFT, what we do for the liver function test, we can remember mnemonic. Lacrimal, frontal, they are parts of the ophthalmic, and trochlear is the 4th nerve. So trochlear over here is the motor nerve, and these are two are sensory. So these three nerves, they pass through the common tendinous ring. Do we have any option? We have vein 6 over here, option number B, 6 cranial nerve. It passes through the common tendinous ring. A good question, just one more step into the supraorbital fissure anatomy. Again, question from the sutures or the openings in the skull. They are important, right? Choose the correct statement. Question from the lower limb, we can say, or abdomen, lower limb junction. Okay, let's see each option. Midpoint of the inguinal ligament is the midpoint of the imaginary line between the anterior superior iliac spine and pubic symphysis. So we should know where is the inguinal ligament. Inguinal ligament is from anterior superior iliac spine to pubic tubercle. Simple as that. So when they say midpoint of the ligament is the midpoint of line between ASIs and pubic symphysis, it is not symphysis, it is tubercle. Wrong. Mid-inguinal point is the midpoint of line between ASIs and pubic tubercle. See, this point which they are saying, this will be the midpoint of inguinal ligament. Midpoint of inguinal ligament, not the mid-inguinal point. There's a small difference. It's a very insightful question, a very knowledgeable question, will give you extra knowledge. Or if you have forgotten, it will be a good revision. So option number 1 over here, actually this is the mid-inguinal point. Option number 1, if they are talking, this is the mid-inguinal point. So they have just exchanged the meaning of these two sentences. Option number 1 actually is mid-inguinal point. They are saying it is midpoint of inguinal ligament. Option number B is the midpoint of inguinal ligament. Now option number 3 over here, midpoint of the inguinal ligament is the midpoint of the line between ASIs. That this is what is our midpoint of inguinal ligament. Because inguinal ligament is between ASIs and pubic tubercle. Option number 4, mid-inguinal point is the midpoint of imaginary line between the ASIs and yes. Option number 4 is also correct. So there we have two correct options, 3 and 4. We have to identify the correct statement. We'll go with option number C over here as 3 and 4. Supplement it with an image over here. So here in this image, let us simply put marking ASIS. We have put a mark, pubic symphysis and pubic tubercle. Now we know that from ASIS to pubic tubercle, this blue colored line, this is the inguinal ligament. And this cross over here, if you put as a cross number A, this is the midpoint of inguinal ligament, cross number A. Well, if you take a point from ASIs to pubic symphysis over here, this will be the mid-inguinal point. If we say it is cross number B, this is the cross number B. Remember this image, very basic question. Which artery supplying the adrenal gland is a direct branch from the aorta? Very good question. Why? Because the adrenal gland is a very small gland. We all know about the adrenal gland. It has two parts, cortex and medulla, coming from mesoderm and neural crest and all that. It is a very small gland situated above the kidney, known as suprarenal gland, but it is basically endocrine gland. Endocrine gland means the secretions are going into the blood. Therefore, it is common sense that it would have an increased blood supply. And mind you, the small adrenal gland normally has 3 arteries supplying the small gland. So these 3 arteries are simply named as superior, middle and inferior, depending on their vertical level, suprarenal or adrenal arteries. We can write over here suprarenal artery, suprarenal. We can remember it by mnemonic, which I also remembered it by PAR. What is PAR? P is for the inferior phrenic artery. It means that the inferior phrenic artery gives the superior suprarenal artery. A over here is the aorta. Aorta gives the middle suprarenal artery, and R over here is the renal artery going to the kidney, gives off the inferior suprarenal. In this question, they are asking us that which artery supplying comes from the direct branch of aorta. It is the middle suprarenal. If we go into the options, we come to the option number D, 4th option. And let us see it in the image over here. So in this image, you can identify this as the suprarenal gland, adrenal gland on both the sides. Here you are seeing inferior phrenic artery giving off what? It is giving off the superior adrenal or suprarenal artery. Here this is the middle suprarenal artery. You can see it is coming directly from the aorta. This is the middle one coming from the aorta. And finally these renal arteries, inferior, you can see over here, if I zoom it, this part is the inferior coming directly from the renal artery. Okay, so this is how the adrenals are. You can see how rampant supply is. And remember their venous drainage. Let me put a point over here. If you talk of the veins over here of the adrenal gland on both the sides, the right and left side, do remember, on the right side it directly drains into IVC, on the left side it drains into left renal vein, which then drains into IVC. What does it mean? It means that, see, this vein becomes very important. Which vein is this? Right adrenal vein. Because this vein will be the one which is carrying all the hormones from the right adrenal gland. Now, if you are doing any surgeries on the right kidney, you have to take care not to disturb or damage this vein, because this vein will be also very close to the IVC. It will be very small vein. Okay, so you have to keep that in mind surgically as well. Fair enough. Next question from the pelvis part, which is not a content of the ischiorectal fossa. Now, ischiorectal fossa, we should know the basic anatomy. It is lying in the anal triangle of the perineum. On the lateral side, we have the ischium. On the lateral side, we have the ischium. And on the medial aspect, we have the rectum and anal canal. And between them, what do we have? We have this space filled with fat, that is the ischiorectal or the ischial fossa. The second thing that we need to know is that in the lateral ischium part, we have a canal over here known as the pudendal canal, which will have the internal pudendal vessels. They give off the inferior rectal vessels. And we also should be knowing that here we have one more nerve that is known as what? It is known as the pudendal nerve. It gives off what? It gives off the inferior rectal nerve. So the basic content of the ischiorectal fossa is always going to be the pudendal nerve, or this inferior rectal nerve, branch of pudendal nerve, inferior rectal nerve, and vessels will be the basic content. So this and this will always be the pudendal nerve, obviously giving off inferior rectal. Now confusion lies in C and D. Now posterior scrotal vessels. Now scrotum is lying in the anterior part of the perineum. And as the name is saying, posterior scrotal vessels, these vessels will be coming from behind, that is from the anal region. So they might also be present. But if you look at the option number D over here, D is saying deep artery of clitoris. Now deep artery of clitoris or penis over here will be lying more anteriorly. So this is the major content of what? The anterior part of perineum. So it is not found in the anal triangle, but it actually is found in the urogenital triangle. Though the branches will come from this internal pudendal artery only, but this artery will go anteriorly. Let me now show you an image of the ischiorectal fossa. This is a coronal section, what we are looking at as the coronal section. Remember, posterior part of the perineum, anal triangle. As I already told you, this is the rectum and anal canal lying medially. This is the ischium lying laterally. This is the ischiorectal fossa, already labeled. And here the pudendal canal is also labeled. And you can imagine the inferior rectal artery going from here to here. Let me put it in this way. Inferior rectal artery. Then you will have inferior rectal vein, and also you are going to have them nerves over here. Now this artery on the lateral side, as this artery will be the internal pudendal artery, it will give off the posterior scrotal or posterior labial branches in females at this anal triangle only, that will go forward. So we can argue, okay, that these vessels might also be present in the ischiorectal fossa. Now, second point is that why we are so much of concern about this, why they have asked this question. Is this clinically important? The answer is a big yes. Why? Because the problem over here is that this area is a seat for developing abscesses. The ischiorectal abscesses, the fistulas, the fissures, and we have to drain the abscess. So while draining, obviously, we have to do some instrumentation. And while doing instrumentation, we should be aware that what are the structures lying over there. That is why this question becomes important clinically. Which of the following muscles, next question, are supplied by the superior gluteal nerve? A theoretical question. Now, superior gluteal nerve, it supplies three muscles. This should be at the tip of your tongue. What are those? Those are gluteus medius, gluteus minimus, and tensor fasciator. Second question is, sir, why is this important? Because these two muscles are basically doing the function of abductors of the hip joint. That is involved in walking, running. And when this nerve is paralyzed, then these muscles will be paralyzed, or this nerve is damaged, then these muscles will be paralyzed. This is what we call it as a Trendelenburg's sign. So that is a famous question. More famous than this is the Trendelenburg sign over there, where the normal side pelvis drops down when you walk. So if you come back to the question, medius and minimus, A and D are the best possible options over here, A and D, and I hope should be one of it. If you look at other options, maximus is supplied by the inferior gluteal nerve, and piriformis directly from the branches of the sacral plexus S1, S2. Right? Fair enough. Let's see the next question over here. Again, arrange the following components of the intercondylar area of the tibia from posterior to anterior. Let me tell you, when you were in first year MBBS, first prof, common question asked during your vivas. You are given a tibia bone in your bone viva also, we are asked this, or in a short question as well. And the mnemonic, which was a very famous till now, you remember it. If you go from anterior to posterior in the intercondylar area of the tibia, the question is from posterior to anterior, remember. The mnemonic over here is Medical College Lucknow, Lucknow Medical College. Anterior to posterior. So you have to just reverse it out. And what is all this? See, M over here is medial meniscus. Okay. L is lateral meniscus. C is cruciate ligament. Simple as that. So M over here is anterior horn of medial meniscus. C is anterior cruciate ligament. L is anterior horn of lateral meniscus. And again, this will be the posterior horn of lateral meniscus. This will be the posterior horn of medial meniscus, and the C will be the posterior cruciate ligament. This is the basic knowledge of it. Now they are asking posterior to anterior, so we can go in this way as well. Now let us see, because all the 6 options are given. First is posterior cruciate ligament. Here, if you see option number 4, so we have to deal with only these 2 options. That is smart way to approach the answer in MCQ. First, most posterior is what? Most posterior is posterior cruciate, option number 4 over here. So we have to deal with this only. Now see the difference over here if you want to save time. Second option is 6 or 5, so we have to choose one. We know after posterior cruciate we have the posterior horn of medial meniscus. It should be either 5 or 6. 6 is posterior horn of medial meniscus, 6 over here, 6. This is right. We need not to go into details of 5, 2, 3, 1, but even if you want to go, after this comes what? 5. 5 is posterior horn of lateral meniscus here. This is then 2. 2 is anterior cruciate, right? 2, 3, 1, and sorry, 2 is anterior horn of lateral meniscus over here. Then 3 is anterior cruciate here we have, and 1 is yes here we have. So option number C is the answer. So if you know the theory, answer becomes 100% clear. Here is the image. Here's the image. This is from the upper end of tibia is being shown to you, and here you can see the medial meniscus. Here you can see the lateral meniscus, and these are the 2 cruciate ligaments. This is your intercondylar area, because this is the one. These are the 2 condyles. This area, this is the intercondylar area. Here you are seeing the structures. When the next image you will see their attachments. You look over here. These are attachments over here going from posterior to anterior, or anterior to posterior. Let me again highlight it. See, medical, right? Then college, Lucknow Medical College. Simple as that. Okay. Basic question that is asked in your first year as well, but they are asked in the form of MCQ too. So be prepared for that also. Which of the following is not a 6th pharyngeal arch derivative? We have arches: first arch, second arch, third arch, fourth arch, and 6th arch. We have 5 arches, fifth one is missing. Now if you talk of the nerves over here, first arch nerve is mandibular, second arch nerve is facial, third arch nerve is glossopharyngeal, fourth arch nerve is superiorlaryngeal, and 6th arch nerve is recurrent laryngeal. And these both are branches of vagus nerve, 10th nerve. Superiorlaryngeal nerve, let us put it more, is divided into external laryngeal nerve and internal laryngeal nerve. And this is recurrent laryngeal. This is the basic knowledge. Why I'm telling you in detail over here, the reason is that these 2 arches are supplied by the nerves. Both are vagus and both are laryngeal nerves. And all of these options given over here, they are what? They are nothing but the muscles of larynx. Now, if you know more basic anatomy, you will realize that all the muscles of larynx are supplied by which nerve? Which nerve supplies them? The answer will be the recurrent laryngeal nerve supplies all the muscles of larynx. But here options are given. Except, there is one exception over here. Except which muscle? Exception will be the answer. Exception is the cricothyroid muscle, which is supplied by what? External laryngeal nerve. Is there an option like cricothyroid? Yes, option number 1. So it will be a muscle of which arch? External laryngeal nerve is the nerve of 4th arch, and therefore this particular muscle over here will become as the 4th arch muscle. All other muscles will be the 6th arch muscle, because they are supplied by recurrent laryngeal. This is how we can approach the answer. Couple of images over here. These are all the arches shown, and here you can see the red and the green color. These 2 color over here, they are the 4th and the 6th arches, already labeled 4 and 6 over here. So both these arches, they combine to form the larynx. But it is a recurrent laryngeal nerve will supply all the muscles, but cricothyroid will be supplied by the fourth arch nerve, therefore comes in fourth arch. And here are some muscles to show you on the lateral view of the larynx. This is what we are trying to show is the muscle. This over here, this is the cricothyroid muscle. Going from cricoid to the thyroid. It is also one of the extrinsic muscles, the only extrinsic muscle because it lies more on the outside. And here in this image, you are seeing the posterior aspect of the larynx. Some other muscles, let me show you. This is the posterior cricoretinoid, the only abductor of the vocal cord. This over here will be your transverse arytenoid, right? And this over here will be the oblique arytenoid that continues as epiglotticus, that you can see in our lectures on the larynx as well. All the muscles are discussed. Next question is, which segment of the liver directly drains into IVC? And a very, very important topic from the abdomen, liver and its various segments. If you know about the coinot segments, there are around 8 segments, right? Segment number, let me tell you, segment number 2, segment number 3, segment number 4, they are the segments that are lying in the left functional lobe of the liver. Then comes segment number 5, segment number 6, segment number 7, and segment number 8. They lie in the functional right lobe of the liver. What does it mean? It means that these are going to drain into the right side or right hepatic veins, and they are mainly going to drain into the left side of the left hepatic veins. But here we have missed a segment, that is segment number 1. It is also known as the caudate lobe of liver. Second thing is, it is autonomous. It is autonomous, meaning by it is not right or left, it is both. So this is the one segment that will directly drain into the thick, big inferior vena cava. The other thing is, you have to remember that IVC is in which relation to the liver? IVC is lying posterior to the liver. And so is the caudate lobe also, that lies posterior aspect of the, lying in the posterior side of the liver. Goes to the IVC. So therefore, answer over here, if we choose option number 1 will be the answer. And let me show you the image over here, all the various segments over here. So here a few segments, let me just outline over here. This is C segment number 2 written, 3 written, 4 written, 5, 6, 7 and 8. Which segment is missing over here is 1. Caudate lobe, that is lying posteriorly. And this over here is the IVC, which is, you can see the hepatic veins are draining into it. So as the caudate lobe is lying posteriorly, its veins directly enter into IVC. It's an autonomous segment. Autonomous meaning by that the caudate lobe gets supply from both the portal veins, right and left portal vein, gets supply from both the hepatic artery, right and left, drains into both the hepatic ducts, the bile of it, right and left hepatic duct, and its venous supply drains into directly into IVC normally. So it might join somewhere middle hepatic vein, then go, but normally it enters into IVC, right? So this were the MCQs. I hope you liked it. Any queries, let me know. And that's all the best. Mark the important topics, do your revision. That's it. Bye-bye.
Hello friends, good evening. So let's get going with the discussion on questions which came from pediatrics in today's CBoT. So the first question was, a newborn presented to you with an X-ray showing a right shoulder fracture. Baby is born a normal vaginal delivery at term. Which of the following reflex abnormalities is seen in this case? So we know that the child has suffered from a right shoulder fracture, right? So that is what is given to you. Now, what will be the abnormality seen? That is the question. So unilateral absent morose reflex at 30 to 37 weeks. Unilateral absent morose reflex at 20 to 28 weeks. Totally absent morose reflex at 28 weeks. Bilateral absent morose reflex at 28 weeks. So to understand this question, first of all, you must be knowing, or you should know, that what is the normal time of appearance of morose reflex, right? And when does it disappear? Of course, that should also be known to you, but for solving
this question, at least the time of appearance should be very well versed with you. So first of all, let us see. Morose reflex, as we all know, is a vestibular reflex, and it has many components. The first component of morose reflex, I hope everybody knows how to elicit a morose reflex, and that is, you support the back of the child on your forearm, and the head should come in the palm of your hand and at an angle of 45 degree from the couch. Then you let your arm fall. Obviously the child will also come with you, and then we see what are the movements which are seen. So what are the movements that are seen because of this is, first of all, there is going to be a hand opening, and there's going to be extension and abduction. So if the child's hands are like this, the arms are like this, they will extend and abduct. And then, of course, again the child will come like this in a posture of anterior flexion. So, and this is followed by a cry. Remember, cry is a part and parcel of morose reflex. And there are certain, precautions to be followed while eliciting a morose reflex. First of all, the head should be in the midline. If the head is not in the midline, then you can, see some abnormality or asymmetry in the elicitation of morose reflex, and that will not give you the correct result. Another thing which should be kept in mind is, as I told you, this is the way to perform the morose reflex. The another way is you can also, catch hold of the baby's hand and then, get the baby's upper part of the trunk off the couch, and then again let the baby, gently fall on the couch. This is also the way to elicit the morose reflex. But I know this is not very, very nice to look at. So it is always better you elicit the morose reflex by supporting the back of the child in the hollow of your forearm, right? So that is how it is done. So let us see, how does morose reflex tend to evolve in a child? Does it appear all at once, or it appears, piece by piece? What is meant by piece by piece is, like, the first component of the morose reflex, that is hand opening, that usually appears by 28 weeks of gestation. Remember that. So that means when you try to elicit a morose reflex in a child who is a preterm child born at 28 weeks, then probably when you do this maneuver of eliciting the morose reflex, all that you will get to see is just the hand opening, and you will not get to see the other parts of the morose reflex, that is extension, abduction, and the anterior flexion, right? And of course the cry may or may not be there. So that is what is there, that at 28 weeks, what do you get to see is only and only hand opening. And when you elicit this reflex, let us say around 32 weeks. So around 32 weeks, you will get to see, obviously hand opening would be there, and there would be the component of extension and abduction. That means which component is still missing is the anterior flexion. So that means at 32 weeks, the child, 32 weeks of gestation, the child who's born at 32 weeks of gestation would elicit, if you try to elicit a morose reflex, then it would be an incomplete morose reflex, right? And finally, the last component, that is the anterior flexion, that usually comes by 37 weeks of gestation. So that means around term gestation, you get to see a complete morose reflex, right? And this is a child, in the question, the child which is being described is a normal vaginal delivery born at term, that is 37 weeks or beyond. So what we are expecting is that the child should be having a complete morose reflex when we try to elicit it. But what is the problem is that in this case, the child has suffered from a right shoulder fracture. So will there be a problem in the morose reflex? Of course, there's going to be a problem in the morose reflex. So as you can see, asymmetric morose reflex is seen in many of the conditions. As I told you, when the head is not in the midline, that is one of the physiological correction that you can do. Apart from that, if the baby is holding on to something in their hand, so that means the hand should be free. And of course, the scenario given in our question, fracture of humerus or clavicle, it is just given a shoulder fracture. So we don't know whether the child's humerus is fractured or the clavicle is fractured. In any of the case, there's going to be asymmetric morose reflex. That means the arm of that side, the ipsilateral side where the fracture has occurred, will not show all those movements of extension, abduction, and anterior flexion for the obvious reasons, because the child would be in pain, right? So that is one of the reason. And Erb's palsy and spastic hemiplegia are other reasons where you get to see asymmetric Moro's reflex. Absent Moro's reflex is seen when there has been a cerebral damage, either antenatally or during, or the child has suffered from severe perinatal asphyxia. And the reflex normally disappears after the age of 3 to 4 months, right? And if the persistence is there beyond 6 months, then this is considered as pathological, and then one has to suspect probably the child is suffering from cerebral palsy or any other disorders pertaining to the brain. So that you should remember, disappears by 3 to 4 months. Of course, in every child it will not disappear at 3 months or 3.5 or 4 months. It might persist up till even 5 months, but then persistence beyond 6 months is definitely pathological. So when the question comes on Moro's reflex, there's always a controversy as to what is the correct answer for the time of disappearance. Remember, starts disappearing by 3 to 4 months, but then persistence beyond 6 months is definitely pathological. So coming back to the question, if we see, so this is you can see the child, the way the child reacts with a startle, that is how the Moro's reflex is elicited. So coming back to the question, what abnormality would be seen? It is but obvious. Now you would be able to attempt it, and that is unilateral absent Moro's reflex at 32 to 37 weeks, right? Anyways, the child's Moro's reflex would be incomplete at 28 weeks. Bilateral absent Moro's reflex might be there, it is just the hand opening which comes at 28 weeks. So therefore, the abnormality with right shoulder fracture would be a unilateral or a right-sided absent Moro's reflex. So I hope this is correct, and the correct answer in this case is the option A. Okay, now let us move forward to the next question. 12-year-old male adolescent presented with chief complaints of fever, fatigue, headache and swelling in salivary gland that causes puffy cheeks and tender swollen jaw. What is the most common complication which can occur in this scenario? And the options given are deafness, pancreatitis, meningitis or encephalitis, or urethritis. So let me just give you the answer straight away, and then we will discuss this question. The answer straight away is going to be meningitis / encephalitis in this case. So first of all, what are we dealing with? Yes, the scenario is compatible with the diagnosis of nothing but mumps, right? So we are discussing mumps over here. Typically, mumps is seen in a 5 to 15-year-old child. We know that is the age group, 5 to 15-year-old, and it is caused by a RNA virus belonging to the genus paramyxovirus. We know this from our knowledge of microbiology. Mumps is very rare in infancy, but we are supposed to do the vaccination, MMR. That is what we are doing in the private practice. Although I know that in your national immunization schedule you are only supposed to give MR, that is measles and rubella, but in private practice we give MMR, which also incorporates mumps for the second M included in the short form. So measles, mumps and rubella, that is what we give as a combined vaccine. And the mumps, as we know, it is spread by direct contact and or the airborne droplets or even the fomites. The spread is also can occur through fomites if it is contaminated by saliva or urine. And it has been shown that the virus has been isolated from saliva as early as 6 days before the appearance of salivary gland swelling to 9 days after the appearance of salivary gland swelling. So we can write it down that viremia, the virus isolation, right? 6 days before to 9 days after the appearance of parotid gland swelling. So the most common salivary gland to be involved is the parotid gland, and we know that the duct is known as a Stenson duct, and the opening of the duct, if you see in the oral cavity, is red and inflamed when you examine these children. And usually what happens is there's a viral prodrome, in the form of fever would be there, and there would be very much pain in the jaw, and usually the swelling is in the lower part of the jaw. We know this, and usually there would be total completely puffy cheeks as detailed in the question. The incubation period is around 6 to 18 days, that you should be knowing. And usually in this case the child can also experience earache, jaw tenderness while chewing, dryness of mouth can be there. There'll be swelling at the angle of the jaw. Needless to say, the ear lobe can be pushed forward, because that is the usual location of the parotid gland. So the ear lobe like this would be pushed forward, and usually the defervescence takes around 1 week or so if the child does not develop any complications, right? So this is how the child with mumps, and since it is a highly contagious disease, you might get a scenario that the child, there has been a child with swelling on the lower part of the jaw, and his other two friends also got infected, and what are we supposed to do? So as far as the treatment goes, nothing much, just supportive treatment is there, and what we are going to do is just advise them to avoid sour foods, because sour food intake increases the salivation, and that would further cause pain to the child. So sour food intake, khatta khana nahi khana, so that has to be avoided, and you can give antipyretics and painkillers, simple paracetamol types, and of course mouth washes can also be given. So that is all is what is required in this. As far as the diagnosis goes, you should know that the diagnosis of mumps is more or less a clinical diagnosis. Of course, if you want to investigate the child, serum amylase is elevated in 90% of the cases, but then we never go for the investigation until unless the child comes with a recurrent swelling, because mumps, once it occurs, please remember this, confers immunity lifelong, and same goes even for the vaccination, that if the mumps vaccination is given, then it confers immunity, whether it is vaccination, whether it is infection, it confers immunity lifelong. Now coming on to the very important aspect over here is the complications, what we are talking about. So complications, you should know the most common complications will be surprised to know, especially in adolescent males, right, or let us say adult males, is the occurrence of orchitis. That is the most common complication, remember that. And usually the orchitis usually begins in 1 to 2 weeks, and maybe after a week or so, and it is very painful. Usually the involvement is unilateral. Of course 30 to 40% in cases may the involvement can be bilateral, but usually it is a unilateral kind of orchitis, and usually it is associated with fever, with chills and rigors, and very much pain and swelling of the testicular of your the scrotum area and the testis. And very importantly, you should remember is that orchitis is rare in the prepubescent males. So that means in prepubertal males, if the male suffers from if the child suffers from mumps, then the occurrence of orchitis as a complication is less likely. It is more likely in the pubertal males, or we call it adolescent males, or the adult males. So remember that ways. Now one very interesting feature about orchitis and mumps, and everybody knows this, and you are asked in your exams in form of MCQs, that the sterility as a result of orchitis is very much rare. Remember that. And you will be also surprised to know, even if there is bilateral orchitis, then too sterility is very much rare. That is a good news, that it does not hamper the reproductive function of the testes at all. Okay, so that is it. So remember, the most common complication is orchitis. What about oophouritis? Of course oophouritis can occur in girls, but it is uncommon. Even in pubertal girls or adolescent girls, it is uncommon. It can occur, but it is not as common as orchitis occurring in pubertal males. So that is one point you should be knowing about, although it may cause severe pain. And one thing about mumps that you should know is, especially oophouritis, is that if at all it occurs, oophouritis, if at all it occurs and it is occurring on the right side, it causes such pain that it is confused with appendicitis in these girls, and that is so unfortunate, because nobody bothers to take the history that the child has been suffering from mumps around a week or 10 days back, right? So has suffered a bout of mumps. So that is what it is confused with appendicitis, because pain is so much if at all it occurs, although remember it is not as common as orchitis. Now the second most common complication is nothing but meningitis or encephalitis, depending on the degree of involvement of the brain. And why does it occur is because the mumps virus, the virus belonging to the paramyxovirus genus, is neurotropic in nature and it gains entry into the CNS through the choroid plexus. Remember that, right? And because of this, the child suffers from features of meningitis in which there would be irritability, lethargy, seizures can also occur, right? Disorientation can be there, stupor, the child can go into stupor. So these are all the manifestations of meningitis, and it is very classically known as aseptic meningitis. For the simple fact is, when you do a CSF evaluation of this child, so what you get to see is preponderance of lymphocytes to begin with. So many lymphocytes would be there, and since it is a viral meningitis, so proteins are more or less going to be normal, and we would always assume that glucose is going to be normal. But here is an exception, and what is an exception is that in 30 to 40% cases of, again, mumps, in the CSF, mumps meningitis, you can get to see something known as a low glucose level, which is so very atypical of a viral meningitis, because in viral meningitis we expect near about a normal glucose level. That is what we expect, a normal glucose level. But here you get to see a low glucose level, and we know a low glucose level in CSF goes by the name of, yes, we guessed it right, it goes by the name of hypoglycorrhea. So hypoglycorrhea, if they ask you that is seen in which of the viral infection, then you should remember it is mumps. Another thing about mumps is, another distinction about mumps which you need to remember, because this is all your classic MCQs which comes, is mumps is supposed to be the most commonest cause of aseptic meningitis. Although the other way around, aseptic meningitis is the second most common complication seen in mumps, but mumps is the most commonest cause of aseptic meningitis. So let me write it down for you. Mumps is the most common cause of aseptic meningitis, right? Apart from this, there could be other complications also. So what could be the other complications? So more or less, hearing loss can be there because of the auditory nerve damage. Auditory nerve involvement can take place. Encephalitis we have already discussed. Pancreatitis can also occur in mumps. It's again a very common, I would not say very common complication. Yes, one of the listed complication of mumps. And orchitis can occur, ophthritis, that we have already discussed. Apart from this is a whole list over here which you can see for yourself, that all these things can occur. Apart from this, even arthritis is well documented in all the pediatric infectious disease textbook as a result of complications of mumps, right? So if we go back to our question, and that was that which is the most common complication seen in this scenario, and we had already made a diagnosis of mumps. So most common ideally should be ophthritis or orchitis, but of course in this case, since it is not there, then we will go with the diagnosis of meningitis, that is meningitis oblique encephalitis, right? So I hope this is clear. Let us move to the next question, and the next question was 10 hours after normal delivery of a 3 kg male baby, the baby develops central cyanosis. He is immediately started on supplemental oxygen, but there is no improvement, right? On auscultation, no murmur is heard. Which one of the following is the most likely cause of this problem? So we know there's a 3 kg male baby, and most likely this would be a normal term delivery, although it is not mentioned, and the child has developed central cyanosis, which more or less goes with our diagnosis of some or the other cyanotic congenital heart disease, right? And the options, if we go through the options, they are also the options in which are the examples of cyanotic congenital heart disease. Now the question is, which is the most likely case in this scenario? No other thing is given. On day 1 of life, the child has developed cyanosis. So let us first, see which would not be a diagnosis in this case, and that would be the option B and option C. Why? Because both of these disorders, they are acyanotic heart disease. I hope we know this, that acyanotic heart disease, more or less we study 3, and one is your ASD, another is PDA, and another is VSD. So if I have to write it down over here, so all the cyanotic congenital heart disease, so this is your congenital heart disease, right? And all congenital heart disease are, then divided into acyanotic and cyanotic heart disease. We know this, right? And acyanotic heart disease, we have mainly 3, which you all have to remember, and that is your ASD and VSD and PDA. So if we go back to the question, definitely ASD and PDA were given as two options. They are not to be considered because the child has developed cyanosis. Now coming to the remaining options, the one option was TOF. Okay, so cyanotic heart disease, one option was TOF, if I have to write down the options over here, and other was TGA. And now we have to, make our diagnosis whether it is TOF or TGA. So cyanotic heart disease are again divided into two categories, those with increased pulmonary blood flow and those with decreased pulmonary blood flow. All said and done, we are not going to details right now, but you should remember one thing, that if we have to choose between TOF and TGA, which one is the correct answer, and especially when the cyanosis is occurring on the day 1 of life, or for that matter in the first week of life, always remember our diagnosis is going to be TGA. Why? Because TOF does not present in the first week of life. Always remember only one variety when you have TOF with pulmonary atresia. Okay, so this is one variety which might present early, right, in the infant, in the, let us say, neonatal period. But the regular TOF, in which we don't get to see pulmonary atresia. What we get to see is involvement of the pulmonary arteries in the form of infundibular stenosis and not pulmonary atresia. So that is a regular TOF, and that TOF does not present in the first week of life. Now the question occurs, when does it present? So usually the presentation of TOF we get to see is around, remember, 6 months to 1 year of life. So 50% of TOF would be symptomatic at around 6 months of life, and the almost 70 to 90% would be symptomatic around 1 year of life. So not so early as day 1 of life. So definitely by this information our diagnosis becomes TGA. So this child, what we were dealing with in this case, the question which was given. So this child is definitely, suffering from what? The child is suffering from transposition of great arteries, right? So there's a list over here, which I got for you just for your reference, so that you know that all those congenital heart defects, and especially the cyanotic congenital heart defects who present early at birth or within the first week of life, we should be aware of is, so one is TGA without VSD, that would be the scenario, we were just dealing in this question. Obstructed TAPVC can be the answer, then tricuspid atresia can be the one of the differential diagnosis, severe Epstein's anomaly, pulmonary atresia, and of course your HLHS. HLHS, if I have to write down, is the full form is hypoplastic left heart syndrome, and this is very much known to present with shock in the first week of life, maybe in the first 3 to 4 days of life, when the ductus is finally closing, because although the ductus close by 10 to 14 hours, we know this, but usually the ductus closure is delayed, and in that case, the child will be symptomatic as early as 2nd or 3rd day of life, or might be symptomatic any time in the first week of life with features of shock and cyanosis. Then you have to think about HLHS, right? So in this scenario, there was no other thing to choose from. We just had to single out our option from TOF and TGA. So the logical answer in this case is going to be TGA without VSD, and that is the answer to that question. Let us move forward and let us come to the next question. Identify the correct sequence of secondary dentition. So this is the sequence given. So for this we should know about the secondary dentition. Let us educate ourselves. Let us see what is secondary dentition all about and what is the sequence, and it is not very difficult to remember this, right? So secondary dentition, as we know, if I have to write down over here, secondary dentition, usually it starts by 6 years of age, right? Starts by 6 years of age and it completes by 12 years of age, except for third molar, right? Because third molar or the wisdom tooth, as we all know, can erupt at any time later on. It can erupt at 20 years of age, or maybe 30 years, or even 40 years of age. So except for the third molar, rest of the dentition, secondary dentition, completes by 12 years of age, right? And total number of teeth, we all know, is, I will write it down like this, total number of teeth is going to be 28 to 32. Why 28 to 32? Because the four third molars, one in each jaw, can erupt at any point of time later on, right? Now, first tooth to erupt, you should know, is first tooth to erupt in secondary dentition is the first molar. Okay. So, first tooth to erupt is the first molar, and the last tooth to erupt, of course, the last tooth is not very difficult. Everybody knows that. Today only I have, repeated at least 3 times. So, last tooth to appear is the third molar. It can appear at any time. Now, what is the sequence of appearance? So, for this, a mnemonic is there which you have to remember. If you remember the mnemonic, it will become very simpler for you. And the mnemonic is My India is pure and perfect, can make magic. We know our country is actually perfect. We live in a wonderful country. So, a mnemonic which is not difficult to remember, My India is pure and perfect, can make magic. So, how do we remember? So, as I told you, the first teeth to erupt in secondary dentition is the first molar. So, M. So, go only by the first letter, right? So, I'm encircling the first letter of this mnemonic. So, M is for first molar, right? Then, this is the first incisor, I for incisor. Then, this is the second incisor. Again, I for incisor. Then P. P means first premolar. Then again, P is second premolar. And can make magic. C is for canine. You know, canine is only one in the 1/4 of the jaw. Right? So canine. And M is for your second molar. And another M is for your third molar. There are, in each jaw there are how many canines? So, there are 2 canines in each jaw, 2 upper and 2 lower canines, right? So, this is how eruption takes place. So, this is how you have to remember. My India is pure and perfect, can make magic, right? So, this, please remember this. This is how the occurrence, the sequence of the secondary dentition progresses. So, let us now go back to the question, and I hope we'll be able to do it now. Okay, so this was the question. Central incisor, first molar, no. Anyways, we know that first molar is the first tooth to erupt. So, this is a wrong option. Again, here first molar is coming later on. This is the wrong option, right? And now we have to choose between B and D, because in B and D, the first molar is the first tooth to erupt in the sequence. So, this is correct. Then, My India. So, second was the first incisor. So, central incisor. So, yes, this is again wrong option. So, the correct option in this case is going to be the second option, that is first molar. My India is pure and perfect. They have, somehow not given the sequence of eruption of premolars, and they have straight away come to canine and then the second molar, can make magic. So, this is make, and then the third molar is magic, right? So, can make magic. So, this is how you have to remember, and this is asked in your exam. So, please, try to remember. It's a very easy mnemonic and you will be able to do it. So, let us move on to the next question. The next question was, a term baby presents with respiratory distress and cyanosis and coarse crackles on auscultation. On delivery, passage of thick greenish black staining fluid per vaginum was seen. What is the most likely diagnosis? So, when they are giving you, the child is suffering from respiratory distress, cyanosis and coarse crackles along with the passage of thick greenish black staining fluid from the vagina of the mother, then we know this child has born through meconium stained liquor, and there's a high likelihood, since he is now suffering from respiratory distress, there's high likelihood that this child has suffered from meconium aspiration syndrome, right? Remember, all children who are born through meconium stained liquor, they need not suffer from mass. Only when the respiratory symptoms develop, then we say, yes, now the child has developed meconium aspiration syndrome, right? So, now the question comes, what is the most likely diagnosis? So, we have already discovered over here, it is meconium aspiration syndrome, because of the very obvious history which was given, and that was that the child per vaginum of the mother, what we could see is the thick greenish black staining fluid, which suggests nothing but meconium in this case, right? Now, few words about meconium aspiration syndrome. We should know the risk factors. So, usually the risk factors of meconium aspiration syndrome, the usual classical is either it is a a post-term infant, or it is a maybe a IUGR baby or a SGA baby, small for gestational age baby, or any baby that has suffered any kind of hypoxic insult in utero. So this is a term baby, does not fit in the first two scenario because they have not talked about the weight, and we are assuming the weight is normal of the child. It is according to the gestational age. So what is the cause of meconium, passage of meconium in this baby in utero? Would be some kind of hypoxic insult. When the child undergoes some hypoxic insult in utero, then one of the responses on the part of the child is passage of meconium, right? And of course, that meconium, after all, at the end of the day, is a waste material, is a chemical, and if the child, aspirates the meconium, then it is going to, develop into respiratory distress. Why? Now, the big question is, why does it happen so? So, there are three mechanisms which explains the pathophysiology of meconium aspiration syndrome. And what are the three mechanisms if we have to see? One is it leads to chemical pneumonitis, because as I told you, at the end of the day, meconium is nothing but a waste material and of course a chemical. So it results in chemical pneumonitis. That means that there will be inflammation of the lung parenchyma when the meconium enters the lung parenchyma. Another reason why the child from meconium aspiration syndrome goes on to develop respiratory distress is because meconium is a thick viscid liquid, it will block the airways partially or totally. So if it is blocked the airway totally, then that would result in atelectasis of the terminal bronchioles and the alveoli. And if it has blocked the airway, let us say partially, then it will lead to obstructive emphysema. So that is another way of injury, induced or inflicted by meconium. Another way because of which these children of mass suffer from respiratory distress and are very difficult to handle in neonatal intensive care unit is because of mass. What happens is there is defective gas exchange, and because of all these factors, they all contribute to defective gas exchange, and because of the low oxygen saturation, what happens is PPHN. What is PPHN? The most dreaded complication of mass. This is nothing but the name given to persistent pulmonary hypertension of newborn. And what does this mean? This means that the pulmonary vasculature undergoes vasoconstriction because of the hypoxia. Why hypoxia? Because of all these factors, the gas exchange is compromised, the child suffers from hypoxia, and his pulmonary veins along which the gas exchange is supposed to happen, pulmonary arterioles along which the gas exchange is supposed to happen, the capillaries, they all go into vasoconstriction. Now what happens is it's a nightmare to manage these children, because even if you put the child, attach the child to a ventilator, the ventilator will just push in oxygen into the alveoli with force, will try to overcome the obstruction. Okay, the oxygen laden air has reached the alveoli, but if the capillaries on the other side of the alveoli through which the gas exchange has to occur is in a constricted state, is in a vasoconstricted state, then how will the gas exchange occur? You cannot do anything at this point apart from, then there are drugs like sildenafil, nitric oxide, which helps us in, relaxing these arterioles so that an effective gas exchange can occur and oxygen can reach the peripheral tissues of the newborn, right? So these are the mechanisms through which the mass, the problem in the mass progresses, and this is what we have to manage. So complications are pneumothorax, because there is a obstructive emphysema, so pneumothorax can occur, and because of pneumothorax, even bursting of the alveolar rupture occur, which results in air leak syndromes. And therefore, no wonder the X-ray shows you hyperinflation and the patchy infiltrates because of the pneumonitis inflicted by the meconium. So this is all about the meconium aspiration syndrome. Okay, now let us move on to the next question. A term newborn exhibits jitteriness, poor feeding, irritability shortly after birth. The mother has a history of high blood sugar levels. What is the most likely cause of infant symptoms? So in simple words, we can say this is a child of infant of diabetic mother, and he is having jitteriness, poor feeding, irritability. What can be the reason of this? So Two complications which are very common in infant of diabetic mother, in the setting of infant of diabetic mother, are the neonatal hypocalcemia and neonatal hypoglycemia. Remember, hypernatremia is not a known complication because of the mother being diabetic, right, during pregnancy. So we can just strike this off. And again, hypothyroidism, again, neonatal hypothyroidism has the reasons are totally different, nothing to do with the diabetes of the mother. The most commonest cause for neonatal hypothyroidism, you should know, is nothing but thyroid dysgenesis. Dysgenesis matlab the thyroid gland itself is not formed properly. So anyways, this has got nothing to do with infant of the diabetes in the mother, so that is why we can also strike it off very conveniently. Now we have to choose between hypocalcemia and hypoglycemia. What do we do? Both of these conditions are common and they have the reasons why they are common. We'll just discuss the reasons. But one thing which you have to remember is hypoglycemia usually manifests in the first 1 to 3 hours of life. As soon as the newborn is formed, hypoglycemia is common, and reason I hope we all know, because of the high blood concentration of the maternal blood in utero. What happens is this blood crosses over the placenta, comes to the fetal side, and this stimulates islet cell hyperplasia, because the islet cells of the neonate, of the fetus, I would say fetus right now because still we are discussing the in utero pathophysiology. So in utero, the islet cells of the fetus, they sense the high blood sugar, and that results in islet cell hypertrophy, and this islet cell hypertrophy pours out lots and lots of insulin in the child's body, in the child's circulation, the fetus circulation. And this is the reason why infant of diabetic mother are usually, more in weight. They are large in weight. They are large for gestational age. They are LGA babies. And the reason is because, in utero, insulin is one of the prime growth factors responsible for the growth of the fetus. And in this case, when the mother is suffering from diabetes, poorly controlled diabetes, then her glucose laden blood enters the fetus circulation and results in islet cell hyperplasia and hence high insulin levels. Now what happens? The moment the child is born, you have cut off the maternal blood supply by clamping the cord. Now the child is a separate entity. Now this is a newborn, no longer a fetus, no longer in contact with the maternal blood. Now what happens? There are no increased blood concentration, because the maternal blood supply is cut off, but the insulin levels have not come down to normal level. They continue to remain at a higher level because of the islet cell hyperplasia, and this high insulin level results in the child developing hypoglycemia. I hope this is very clear with you, right? So this occurs, and the lowest glucose concentration in the newborn's blood is usually seen around 1 to 3 hours of life, and then spontaneous recovery starts between 4 to 6 hours of life. Right now, in these 1 to 3 hours are very crucial. At this time, the child can have all these features which is described in the question, may also develop hypoglycemic seizure depending on how low the blood glucose concentration goes. Right. So this is what happens as far as the hypoglycemia is concerned. Now coming to hypocalcemia. Hypocalcemia, remember, is a known complication in an infant of diabetic mother. Again here the dip or the lowest level of serum calcium concentration in the newborn, who's born to a mother who had diabetes, that is usually seen, this is known as nadir. So nadir is usually seen between 24 to 72 hours of life, not before that. That means कैल्शियम का खेल जो भी होगा वो डे 2 पे शुरू होगा. डे 1 पे it is all about glucose, and day 2 पे the calcium becomes the main ion to worry about, right? And why does it happen? There are 3-4 factors contributing to it. One is immaturity of parathormone level. So because of which what happens, PTH is not able to manage the blood calcium levels efficiently. Another is vitamin D antagonism at tissue level, right? So these are all factors which contribute to a lower serum calcium level, but remember, not in the first 24 hours of life, but after the first 24 hours of life. The third case, obviously not related to infant of diabetic mother, is any premature child. Prematurity also contributes to hypocalcemia. One more thing which every, at your age you should be very clear about is that there are 4 factors which there are 4 scenarios where you get to see early onset hypocalcemia. And early onset hypocalcemia is early onset hypocalcemia is, when you get to see low sugar level at 24 to 72 hours of life. And what are those 4 factors which everybody has to remember? One is infant of diabetic mother, that scenario we have discussed. Another is a IUGR or a SGA baby. Another is prematurity. And the 4th factor or the 4th scenario where you get to see early onset hypocalcemia very commonly associated with is your perinatal asphyxia. Perinatal asphyxia. So when you have settings of any of these, then always think about hypocalcemia, but never on day 1 of life, after day 1 of life, right? So when we come back to the question which was given to us, the child had, the newborn had all these symptoms shortly after birth. Remember, these symptoms can occur in hypocalcemia as well as hypoglycemia, but the timing shortly after birth brings us that our correct answer is going to be neonatal hypoglycemia. So it is going to be neonatal hypoglycemia. So this is the correct answer. The C option is the correct answer over here, right? So that brings us, okay, there's one more question I believe. So let us quickly do the last question over here. A 7-year-old male neonate is diagnosed with HIE, hypoxic ischemic encephalopathy. In short form, it is known as HIE. On examination, he is lethargic with a flexed posture and the pupils show meiosis with hyperactive tendon reflexes and clonus. The pediatrician orders EEG, which is suggestive of low voltage changing to seizure activity. Which stage of HIE does the neonate belong to, right? So, see here, if you have to see, the child is lethargic, flexed posture, pupil is showing meiosis. This is the biggest giveaway if I have to see. So, meiosis indicates what? Indicates parasympathetic stimulation, right? We will come to it. What does this mean? And very importantly, yes, the child is having hyperactive tendon reflexes and clonus, but very importantly, another thing which gives away the diagnosis or the answer is the EEG showing you seizure activity. So, whenever seizures are there, always it is stage 2 HIE according to Sarnath and Sarnath staging. I hope you know this staging. Sarnath and Sarnath staging is a very famous staging, used to categorize or used to, see the prognosis of these children who suffer from perinatal asphyxia. So, stage 2 HIE the child will have seizures and the child will have parasympathetic stimulation. And so, this is the staging, very simple to remember, one stage which you all should remember because you get questions from it. So, stage 1 is sympathetic stimulation, we know this. Stage 2 is parasympathetic stimulation and stage 3 is both systems, both autonomic nervous system, that is sympathetic and the parasympathetic link, both symptoms are depressed. Remember that. So, in this case, if you see, the child will be stuporous or comatose, activity will be absent, the child will be almost comatose. So, muscle tone will be flaccid and, in between the child will be having the decerebration. This is known as decerebration when the child does like this, right? Both the upper limbs and the lower limbs, right? Stretch reflexes will be decreased or absent. All the reflexes, the primitive reflexes will be absent and the pupils will be variable in size, the heart rate will be variable and the seizures are uncommon. Of course, you are not going to, classify decerebration as seizures. Decerebration would continue. If you have to see stage 1, there will be all features of sympathetic stimulation where you will have mydriasis in the pupils and the heart rate will show you tachycardia and the child will be hyperactive. The reflexes would be hyperactive. Now, that is what, although the suck would be depressed, always remember, all reflexes would be hyperactive, but the suck is depressed even in stage 1 HIE. In fact, if I have to elicit history of perinatal asphyxia from any couple, from any mother, the first thing I'm going to ask is, was the child sucking on the breast or not? If the mother says, the child was sucking on the breast from the word go, that means soon after birth, then it is unlikely that the child has suffered from asphyxia, because you can see even in stage 1 HIE, the suck is going to be weak, rest all reflexes can be hyperactive. Coming to stage 2 HIE, the giveaway, as I was telling you, is the meiosis and the heart rate will show you bradycardia. And very important secondly is the presence of seizures. Very, very common. Rest all reflexes are going to be, weak or absent, although the stretched reflexes are going to be overactive, right? So this is how, you have to categorize. So if we have to go back to the question. So this question was, the child was having hyperactive tendon reflexes and clonus, and the child was having seizure activity. So what is this? This is straight away stage 2 HIE. So that brings us to the end of this discussion of the pediatric questions. I hope every one of you got it right, and if any doubt was there, I hope I was able to solve all of them. So keep MCQing always. All the best. Thank you.